Patou, tu veux un essai son, voilà, 1, 2, 1, 2, 1, 2, 3, nickel, merci. If some people need a translation in English, you just have to get a headset that's at the entry of the room. Je le dis aussi en français d'ailleurs, pour ceux qui veulent bénéficier d'une traduction de l'anglais vers le français, n'hésitez pas, on a des casques de traduction qui sont disponibles à l'entrée de la salle. Voilà, je vais vous inviter à vous asseoir assez rapidement, s'il vous plaît.
Now, please take a seat, please, because we're going to get started. Well, we're going to get started at 10, if we can. I think we're just lagging slightly behind, so let's start as soon as possible. Thank you.
Voilà, il nous manque toujours quelques personnes qui sont
We're
bloquées.
still waiting for some people who are still in a traffic jam. We always have traffic jams, but we're going to get started because we have many remote participants, and therefore we don't want to keep them waiting. So let's get started very soon after the jingle.
Bonjour, bienvenue à tous.
Well, good morning and welcome for this new conference of the Global South eHealth Observatory in the southern countries. This is the initiative of the Pierre Fabre Foundation, and this is a meeting we have here face-to-face in Toulouse in this company's incubator, and we're speaking here of digital companies devoted to e-health, but also to healthcare services. And I think that this is something which is really in line with the values that we have in the eHealth or Global South eHealth Observatory. So I would like to welcome you all. I know that you might be in some other remote campuses in other countries or either here in Toulouse. And we've been working for more than 6 years altogether so as to be able to discuss and exchange good practices. Now, I would like to tell you that last year, well, we had a last edition. We have had many participants, more than 3,000 participants who have been participating online. Now, wherever you are, I would like to welcome you and just send us a small welcome message and just let us know how you feel about this meeting, because we feel very happy to have you here in Toulouse, and we're so happy to get messages from remote countries and from worldwide participants. And I think this is going to be a wealth of good practices and reflections. And so as to open officially the 6th conference of the eHealth Observatory in the Global South eHealth Observatory, Béatrice, unfortunately, who is the executive manager of the Pierre Fabre Foundation. Béatrice, I know you have the COVID, so we're sorry not to have you here, but we have Solène Bard, who is also in charge of the program at the Pierre Fabre Foundation. You have the floor. Well, good morning. And on behalf of the whole team of the Pierre Fabre Foundation and Pierre-Yves Rivol's as president, the administrators, and also on behalf of Béatrice Garrett, the executive director, I'm very pleased and honored to launch this 6th conference of the Global South eHealth Observatory. We're very happy to welcome here participants coming from Mali, Burundi, Indonesia, India, Pakistan, and the United States, from very many countries. Thank you for traveling so many miles to be here with us today. The conference is also going to be streamlined on internet, and also thanks to the French Agency for Francophonie. This is going to be a very challenging meeting here in Toulouse. I would also like to say that we want to improve the access to healthcare of the poorest, and this is why we have founded this Pierre Fabre Foundation. And this is also why we have been developing this. And we have two other partners, the Foundation for Future and the Initiative Network for Information on e-health. Thank you for this very positive partnership. Now, since it started being operational, the ODS has always been complying with its mission. That is to say, we want to know and assess all the different digital initiatives for e-health development in many countries. We have more than 165 projects in 84 countries, and 34 projects have been supported financially and technically. Thanks to the annual conference and thanks to its expertise and the exchanges with the different institutional entities, the different partnerships and stakeholders in southern and northern countries have been able to build together a common and shared vision concerning their participation. And the 6th conference is very special for many reasons. We're here in Toulouse, face-to-face, because the Pierre Fabre Foundation has been starting to there are some repairs in the foundation of Pierre Fabre. But we started also renovating the site of the e-health observatory, and you can also go on the web page if you want to see all the information we have been broadcasting today. We have 5 years of work, and we have to capitalize on that. We have to capitalize on this experience, on these information, and see what we have done, what we still have to do, what are the new avenues to pave in the field of research, international research, but also about all the digital projects. So, for instance, if we have a project locally, how can we roll this out internationally? In the very hyper-dynamic sector, what are the investments that we can make? And this is why we want to be together today to be able to assess what we have done, what we have in our portfolio. And we have 5 specific operational projects in e-health. And just before I give the floor to Mr. Pierre Kampf of the AfD and Professor Gemshoff, I would like to welcome you again and hope that this conference will be very fruitful. So we have Pierre Kampf and Slim Kalbous. Well, thank you very much for this opening. And we have been partnering with Pierre Fabre since the very beginning and the French Agency for Development. It's Pierre Kampf, who is Project Team Manager, Health and Social Protection Division. And he is here to represent this agency. Mr. President, Pierre-Yves Revol, Mr. Dean, very dear friends, very dear colleagues, it's a pleasure and an honor for me to be here to represent the French Agency for Development, and Agnès Souka, who is in charge of the Health and Social Protection Division, who unfortunately cannot be with us today. So I would also like to say that I feel very proud because we are here to support this observatory. And I'm not familiar with all the background, but I think that since 2016, we have been able, all together as we wish to do, to keep up with this partnership, which I think is very robust and very challenging for us, for the Health and Social Protection Division, and for our agency, and for all the other partners. I would like to thank you all to be here and for participating to this meeting. I would also like to thank all the stakeholders, all the actors representing different projects and different countries. I would like to thank Marine, Jean-Claude, Maxime, Victoria, our team, our organizational team, for supporting us. And I would also like to thank Beatrice. Unfortunately, she is not here with us. I'm sure that she feels very sorry about that. Now, just a few words about the AFD. That is to say, it's a public financing and project agency, French agency. The AFD has 3 members. The French Development Agency has been funding projects. That is to say, for the collectivities and other sectors, and ProParcours in the private sector, and another Expertise France branch, which is supposed to mobilize the different expertise that we have for cooperation and collaboration. So just to give you a few figures, we have been supporting each year several thousand projects for 12 billion euros. And the 12 billion euros, of course, have to be considered in a holistic way, because 10 billion euros, which concern what we call loans, which are loans for different projects, and then 2 billion euros, which are subsidies, and which is public support for the development of France and projects in France. Now, in the sector of health and e-health, or digital sector, what we can say is that digitalization offers new, different possibilities, diverse possibilities, and we could just list a few of these aspects. For instance, if we speak of biotechnologies, healthcare, we see here that there's a very strong relationship, because the technologies help us to give access to health services to many populations, and we also have treatments with a wide series of treatments, but also this helps us to reduce the distance between patients and the treatment centers, but also other tools for the coordination of healthcare and healthcare services. We should not forget the production of knowledge, because this is very important, because digitalization is something which is now developing thanks to many teams producing more information, more data, and I would say that this is very positive, because it's helped us to reinforce the democracy, because citizens are today and patients at the very center of the system. This is what we hope to do and to develop in the future. This, of course, means that there is a real revolution when it comes to the relationships between health professionals, patients, and also within the systems themselves. Now, the AFD, the French Development Agency, is involved in 3 different kinds of projects. That's the main project in Tunisia is to support the transformation and the national policy of e-health, but other projects which are numerous, diverse projects where digital is playing a massive role, and this so as to comply with other tasks and goals. And we also have support initiatives which are supported by our institutions, our entities through different networks, and also thanks to the what we call lobbying, but also collective commitment. And therefore, we feel very happy to be a part of this with the observatory. Now, we are in Toulouse, and therefore, I think that we have to mention the extraordinary work of Dominique Pont, who has been the ministry representative for e-health and who is from Toulouse. And he has just been working 3 or 4 years for the major transformation of the e-health environment in France. And he has been at the very heart of what we have done in terms of transformation, in terms of achievements. And I consider that he is a real pillar of our initiatives. I think that we have in the field projects which are now developing, and I think that we should keep in mind that we have to promote, support, develop what we call institutional dynamics or momentums, because the public entities have to be more strongly involved in this transformation process. Having said this, I would like to stress the fact that this digital transformation has to help us to reinforce the sovereignty of countries and states when it comes to managing their own data and information. I think states have to play an important role there. They have to protect the data, confidentiality. This is a major issue which is in the hands of all these governments and states, and therefore this is why sovereignty, I think, is essential. Now, the other aspect I would also like to mention is how can we struggle against inequalities, because the e-health has to help us to do this, and we have to reinforce democracy in the field of health. If not, we will have missed one of our main goals. Now, from a more operational point of view, I think we also have to keep in mind that interoperability is also essential because everybody has to be able to play its role. We need people in the field of industry, of health, but also in politics because we have states. All these people, all these stakeholders have to interact at the right moment, at the right place, and I think that this is something which will help us to develop these dynamic initiatives, this transformation process. We should not forget that, as I've said previously, that there is institutional support and control so as to make sure that there is a real interoperability, that there is a real development taking place, but with control of data and information. I'm sure that this is going to be a very fruitful meeting, and therefore have a nice conference. Well, thank you very much, Pierre Kemp. This is fantastic. And you're representative of the Health and Social Protection Division of the Agence Française de Développement, and you have been at the very heart of this observatory. And I think that the Pasquim Pan-Bouquier, the Dean of the French Agency for Francophonie, is here with us, and he's going to say a few words now. Of course, I'm very happy to be here, very honored, because we are here again, Mr. President Pierre-Yves Revol, dear Beatrice, I hope that you will soon feel much better, and dear colleagues, dear friends. Yes, the French Agency for Francophonie and for Development has been part of this project at the very start, but also a partner of the foundation, Pierre Fabre Foundation, for very many other very challenging and thrilling projects. Now, being here in Toulouse is always a pleasure, especially for me, because I've been studying in Toulouse, and I feel very happy to come back to this city, which is very pleasant. I would like to say two words concerning the international agency, which was created in 1961, and which is supposed to accompany the development through knowledge, especially through the expertise, the academic expertise throughout the world. And the Agency for Francophonie is the first international academic network, because we have more than 1,000 universities and labs part of our network, and these 1,000 universities represent more than 120 different countries. And as you can see here, we really defend the scientific Francophonie, but also in the French-speaking countries, not only in other countries. And our proximity network is also very important. We have, I'm sorry, Slim Kalbous. I think someone has been speaking without being invited to do so. So let's get back to Slim Kalbous. So we've been working for more than 2 years on the development of what we call the proximity networks, that is to say, networks everywhere in the world. We have 60 countries with digital campuses who are a part of this meeting, but also new development centers so as to develop the possibility of finding jobs, employability for younger students, and therefore we have been extending our network, and this is something very specific in our organization because we have a world network, but we also have proximity services in all fields concerning science in the primary, secondary sectors, but also concerning the very specific academic and scientific expertise. Now, when we speak of e-health, well, we've been working a lot in this field for some years, but we have been ramping up in the last 2 or 3 years because, of course, the COVID pandemic has challenged us, and this is why we have been investing a lot. Now, we have 3 sectors in the French, the Agency for Francophonie, that is to say, how we can set up new networks, research, and also We have two main networks which have been set up in CIDMEF, which is the first network, which is the oldest academic network in the French-speaking, and the CIFERMEF, which is also the other network we have, which brings together all the representatives and experts of pharmacies in French-speaking countries. And last year, we have a third also network in the Science for Health, that is to say, it's a public network. This is something that was missing, because this means that we will be able to bring together people who are involved in our policies, national policies, and researchers. And this is why we have three major networks which bring together experts coming from very many different countries in the world and who are members of this network. And with a very dense activity concerning the prospective studies, especially in the field of health science, especially also in the field of health technologies. Now, this network building is also being developed thanks to a kind of commission or a committee which brings together the representatives of all these networks. We have 5 sectors. One of them is health, the health of sector, where we find these 3 networks I have just mentioned. And Michel Serres, that I would like to thank, because he is the president of the CIFERMEF, who is today presiding over this committee for 2 years. And we're going to be talking and working on interactivity and all the connections we have between the members of these networks. And also, we are going to try to develop what we've already done in the technological area, because this is very important for the science of health. So this was the first pillar I wanted to mention. Now, the second pillar, now training. Training, I think, is remote training, and we have IFI, which is a specialized institute in Tunisia, which concerns digital engineering, with a relay and all the campuses that we have in the 60 countries I have mentioned previously. So this is what we call the academic centers, which are rather member of this network. So we have different diploma and curricula concerning the science of health, and different levels, of course. So you can have either universities member of the IF who will provide our students with the diploma, like in Aix-Marseille, where we have a specific curriculum concerning the quantitative approach of e-health. In Bordeaux, it has another approach concerning epidemiology in the field of cancer, and a master of e-learning in the field of health. The University of Lorraine, and we have graduated who have a master in the field of health. In Alexandrie, where we have a master in neurobiology, and all these masters are in French, and this so as to extend the French-speaking knowledge and French-speaking training. And there is also a tender today, because for those who want to be registered on these remote training platform, and this for many of our students until the 18th of September. Last year we had more than 1,000 students. So if you have students who could be interested by this e-learning in the field of e-health and science of health, well, why not? And I would invite you to provide them with this information. So we've been today talking with our friends in Lebanon, so as to have 3 universities in Lebanon with a specific diploma concerning the control of the quality of drugs. So quality control of drugs, and l'AUF and the foundation we have in the Middle East are going to be partnering for this. We also have very many initiatives in the field of training of trainers, and training of trainers is also essential. I'll give you just one example. It's the example of what we've been doing with the Pierre Fabre Foundation. For 5 years now, this project will involve other members. This is a framework convention, and this is taking place in Benin and Togo, so as to improve the quality of training and trainers in the field of health. So this is just to give you an idea. So we have networking, training, and research.
In research, As many other bodies, we organized a number of webinars, cycles of webinars, one of which was very successful on the health of women and also health of newborns. This is a taboo in a number of southern countries for reasons of hygiene, but we also discussed contraception, and those are themes that are not very often covered and that we try to showcase in those webinars, because again, those are unmet needs in a number of countries. We also organized a number of conferences on COVID research, and a book was published on CSR post-COVID crisis. We have two experts co-writing that book, and that book, so say the experts, have become a reference on questions pertaining to COVID. Around that theme, we also launched a call for project for young researchers in universities, again, to demonstrate how university researchers can contribute to research. 2.5 million euros during the COVID pandemic. Today, about 100 projects are funded by the French agency. We had more than 2,200 applicants, and this is applied research. So research translating in concrete actions. We had a number of very interesting candidates, a number of mobile phone-based apps. We also had very interesting projects on digital platforms for follow-up of COVID, diagnosis supporting tools, and also a number of projects to help in the hospitals, especially with robots, again, to have immediate solutions to the shortage of staff. Now, before I conclude, I would like to say that health sciences are becoming more and more a topic of more interest in research. A number of universities do have curriculum in this field, and the partnership that we have with ODS is certainly a very nice illustration of all collaborations that we have between political decision makers, universities, and private bodies. Thank you very much. Thank you very much to the Dean of the University Agency of Francophonie. Thank you very much for this very nice reminder of everything you do, all the efforts that you put in order to help knowledge be disseminated around the planet, because this is one of the most important richness that we share. You were no less than 3,000 participants last year for the last installment, and maybe you follow from home or from your school. And amongst the different campuses connected tonight, the campus of Maidol in Bangkok, Thailand, we are going to go there immediately. Hello, who's speaking today? Is it Dr. Bunjai? What time is it in Bangkok, and what's the weather like in Bangkok?
Good morning. It's good evening. Good afternoon here. This is our student and our faculty in the department. It's nice to be in these e-health observatories, really. And the weather is quite hot today, and we have it's quite okay, but a little bit wet in the last few days ago. And we are waiting to participate in this conference. Thank you.
Merci beaucoup, Dr. Bunjai, d'être des nôtres aujourd'hui. Je trouve qu'il y a toujours un côté.
Thank you very much for being here. I find it's pretty magical to see so many people following from so very far away. We are going to showcase you. Last question for you, Dr. Bunjai, but we're going to ask questions to you. Who's with you on the campus today? Are those students, healthcare professionals, future medical doctors?
On the right-hand side, my colleagues, and in front is also my colleagues in data science for healthcare and clinical informatics program, master and PhD degree. And we have international. Many of them are the health professional, a doctor like at the end of the table, Dr. Cholatit, he is the emergency physician now taking the PhD in our programs. And Maria, the yellow lady over here is from Indonesia. She is the one that got the kind scholarship from the Pierre Faber Foundation, and she are going to finish her master degree in the near future, just a few months ahead. And we have a student from China, and a lot of many of our students are the health professional and health IT, and they're taking the graduated degree in Mahidol University.
Merci beaucoup.
Thank you so much, Dr. Boonjay. It's great to have students, PhD students, master students, healthcare professionals, and we have such students from everywhere in the world connected to benefit from the knowledge that we're going to share tonight. We also have a number of internet users. We're going to say hello to Roger Baku, he's writing from Togo. Hello, Roger. We also have Maurice from Lomé, thanking us for this conference. He says, well, I'm learning a lot of time on the French Agency of Development and the other agencies. Thank you very much. We say hello to Maurice in Lomé. And we also have Sad11 who says, what is the situation of, in terms of implementation of e-health in southern countries? And I think this is going to bridge very nicely with what is to follow, because without further ado, we're going to jump into the main topic of this conference, i.e., what is the situation in matters of e-health in the global south, and how can we capitalize on innovation in e-health? So what are the main trends in e-health in southern countries? Those trends can be a source of inspiration and also something that we can leverage. Florence Gaudry-Perkins is the director of a company named Digital Health Partnerships. And then we're going also to listen to Joy Ganesh Udayasamkaran. He's a member of the expert committee at the Foundation Pierre Fabre. He's also a member of the governing committee of the Asian e-health information network. And so they have this very difficult task in only 20 minutes to provide an overview of e-health in southern countries. So I'm going to give them the floor here at the rostrum. You have the floor.
Good morning, everyone. I think first and foremost, thank you to la Fondation Pierre Fabre and to Béatrice. Our thoughts are with you, Béatrice, for organizing this event every year, because I have to say that it's one of my favorites because of its quality, but also because of its location in the beautiful southern France, but also because of its size. Merci, Lionel. Jai and I are thrilled, in fact, to try to indeed do the challenging task of giving a bit of an overview on where we stand with digital health. We're going to focus specifically on Asia and Africa, just so you know. I just want to say that it warms my little heart to be doing this with Jai, because Jai and I have known each other since 2017, and we've worked on many things together, including the Broadband Commission reports, which was quite a task over the years, and it's the first time we're meeting in person. So it's quite symbolic that we're presenting together, and it's really, really nice. So with no further ado, let's try to get started. What I'm going to do is do a little bit of a global take on some of the big moves happening globally. Then I'll deep dive a little bit into Africa, and Jai will take over and take a glimpse at what's happening in Asia. Okay? Et ça n'a pas l'air de marcher, Lionel.
Ah. On va le faire défiler
Well, it
autrement,
seems that the remote
mais
control
c'est possible normalement.
is not
C'est
working.
toujours un effet,
Well, we
voilà.
always have some form of
Un effet
technical
magique.
glitch,
Ça marche
right?
aux essais, puis ça marche tout à
You know,
fait.
when we test, it works, and
Là,
then
ça
it
fonctionne.
doesn't. But anyways, it's just
So
working
we
now.
discussed this at the conference last year, the impact that the pandemic has had on digital health. And I'm not going to stay too long on it, but nevertheless, it's useful to sort of see where we stand with numbers. So somebody used, about a month or two ago, I heard somebody use the word digital pandemic, and I thought, oh my gosh, that's the absolute correct term, because as we were confined, or restricted to move, the world did go digital on us. If you weren't connected, you couldn't work, you couldn't study, and you couldn't seek healthcare. And hence the title of this slide. So quick look, plus 80% increase in investments in digital health just in 1 year from 2020 to 2021. You can see we're at 57 billion of investments in 2021. Just as comparison, we were at 13 billion in 2018. So you can see the growth is absolutely exponential. In the second figure, you will see that it's expected that the investments will double by 2027 to reach 550 billion. So we are really seeing a major acceleration, and I sincerely believe that it was largely due to this pandemic for the reasons we evoked. Multiple countries, put in tools to sort of track, measure, and evaluate, of course, the virus. So we evaluated that about 50 countries altogether put those kinds of tools together. And then telemedicine and telehealth, we discussed that again a little bit last year. Huge boom in that. Some people were saying that there was more progress on telemedicine 1 month when COVID hit than they had seen in 10 years, right? So we literally saw figures of plus 900% with Ping An in China, but similar figures coming out of the UK, the US, France, and multiple other countries. And even in Africa, there was a huge boost also of not only did existing solutions scale, but there were multiple startups in the field of telemedicine that were started. So telemedicine, telehealth was definitely one of the big ones. Next slide. This acceleration has translated into some major moves from the institutions. So we'll take a look at the bottom ones, which are a little bit global. Of course, Derek, I don't know if you're going to talk a little bit about that, but the digital health strategy from WHO had been in preparation for a while, but what the pandemic did spur was the WHO Berlin Hub for Pandemic and Epidemic Intelligence. So that was a pretty major initiative that got started due to the pandemic. The Global Fund is currently finalizing their digital health strategy, which is a pretty big deal also. I don't have exact figures on how much they've already invested, but know they're increasing substantially also their investments in digital health. And then G7 and G20 started getting quite active and vocal as well, which is very encouraging, and published some very interesting either reports or declarations. And then the EU has been ramping things up also with PRIDA, which is sort of a digital policy and regulation initiative that was largely funded by the EU, and creating also a digital for development hub for innovation. Next slide. So institutional funding, it's pretty hard to measure, and it's challenging actually to have a clear mapping of digital health funding, because a lot of the digital programs or the projects, you actually embed digital inside of it. So people have been asking me like how much, overall from the institutional funding, but it's quite difficult to have a precise visibility on it. But all of them, generally speaking, are ramping up. This is not an exhaustive list that I've put here on the list, but sort of I would say the ones that come up regularly when you talk about digital health. So USAID is one of the more traditional. They've been investing in digital health for a long time. They, in fact, have an official digital health strategy. But GIZ has been really ramping up as well for the last 2 or 3 years, which is wonderful in digital health. And then the traditional World Bank, JICA and ABEL, and then I listed towards the bottom also some of the more prominent foundations who are known to invest in digital health, and lots of new entrants coming in because it's a hot subject, digital health. So, but we'll talk about that a little bit afterwards. The funding is a difficult one because it's also been a cause for fragmentation. I'm not going to stay too long on that, but I pointed to the bottom right on this slide a very important initiative that was actually done in 2018, which are the principles of donor alignment, so that we stop, so that the donors kind of get together and act more together. So we stop sort of, because digital is really an overarching solution. And so you can't just keep financing little pieces that are not interoperating together. So there's a lot of, and Mathilde Forslund is here from Transform Health. I'm sure she's going to talk a little bit about that, but there's a big push to a bigger donor alignment, better coordination in general. And then on the left here is a very interesting little initiative that many people still don't know about, which is the Healthcare Electrification and Telecommunication Alliance that just launched at the White House about 2 months ago. And this is a $300 million fund, it's like a co-funding mechanism with private sector from USAID. And this aims to connect and electrify 10,000 health facilities across sub-Saharan Africa over the next 8 or 10 years. And super important because it's a little bit more of an ICT play, and we'll discuss that, but you know, without the connectivity, we're not going to go very far on digital health. Next slide. So I'm not sure anyone's going to see that very well, and that's okay, because what this little chart is simply a completely non-exhaustive list of the diversity of players involved in digital health, which explains a little bit on how difficult it is, and also the fragmentation, right? So you've got, you know, academia, you've got the NGOs, you've got the private sector. Within the private sector, you've got health, you've got tech, and within tech, you have multiple different players, and then you have the mobile operators, and then you have the whole health sector, so med tech, pharma, diagnostics, and it goes on. And then, of course, all the institutions, some of which we just talked about. And that's going to bring me to the next slide, which I think is probably one of the more important messages that I want to relay today in terms of this sort of overview, is because digital health has increased, as we've just saw, because there's already huge amounts of players and there's a lot of new entrants coming in, we are in desperate need of more coordination and governance mechanism in this space, so that we stop fragmenting, so that we stop duplicating investments, et cetera, et cetera. So to my great joy, this has actually been starting to happen in the last 2 years. We're seeing organizations and bodies emerge to help coordinate better, to help cross-fertilize better, to help inform who's doing what, et cetera, et cetera. And Transform Health that you see to the left, I've actually just mentioned, and Mathilde is here with us. Mathilde, you want to say hi? Who is the executive director of Transform Health, which was started about 2 years ago, Mathilde, now, right? 2 years. And actually well-funded organization, in part by the Fondation Botnar. And there's 3 things that they do is advocate for more political leadership. These are their 3 main sort of strategic pillars. A global data governance framework, which Jai will talk about a little bit later, and also advocates for increased investment. So they're going to be, you might talk about this later, Mathilde, right? At Berlin, I'll stop there. And to my great joy, because that's one of the things that they do, is also launching country networks and regional networks, is that there's one that was just recently launched in West Africa. And Lionel, I know that you're also attached to this cause. We know, and I will point it out again, that Francophone Africa is behind Anglophone Africa. There's a number of reasons for that. I won't stay too long on it because I don't have the most recent numbers, but I always mention it because it's a plea for us Francophone actors to come and support and do more there. So thank you to Transform Health for launching this network, because it's very, very important. DICE is another one of these sort of coordination mechanisms that got started during the pandemic. So DICE is a bit of a, it was started by UNICEF and WHO, and it is meant to help, as you can see, coordinate between governments, and then for help donors in development to coordinate with the governments, right? To create this, so they're creating offices for that, and it's essentially insofar been focused on sort of COVID related, but the intent is that it will enlarge to other digital solutions. So that's another very encouraging sign for more coordination. IDARE is another body that was started also more recently, and that's a little bit more focused on research and AI. DCCC to the right is a more private sector type of coalition that also aims for more of this coordination, cross-fertilization, better information. And the Geneva Digital Health Hub is another one, recently started, that aims for these same things. And to the right, and I won't stay on that, to the bottom are the more, I would say, traditional historical bodies. They're absolutely not all there. They're just to show you. The more important thing was this, again, message of this coordination is emerging, but we need more of it, and we really need to support these coordination mechanisms, which are not always the most easily funded and supported types of things, right? Because everybody wants to reach out to how many patients have you touched, etc. But I really insist, this is probably my key message for this morning. Next slide. Okay, so now we're going to look a little bit more closely into Africa per se. So innovation booming, investments on the rise. I love this SORMAS example because for years and years and years that I cite up onto the top, I've been saying the innovation is going to come out of Africa. This frugal innovation that's happening in Africa is going to cross-fertilize into our industrialized countries. And SORMAS was a significant one that cross-fertilized during COVID. This is a solution that was a surveillance solution system that was developed originally in Ghana and Nigeria, and it cross-fertilized during COVID in Germany, France, Switzerland, Afghanistan, Papua New Guinea, and Fiji, and it's quickly expanding actually in multiple other countries in the world. We have now 1,276 health tech startups in Africa, which is great. Huge increase. It's booming. And in fact, the investments are as well. The investments on startups in Africa this year, 2.9 billion, 81% growth in just 1 year. Where we have a lot of work left is that out of that number, out of the $2.9 billion that were invested in startups in Africa, only 10% in health. So we have a lot of work to do still. On the bottom, you'll see some of the examples. Very encouraging to see also a health tech incubator, very recently launched also in Kigali by Norsken and the Novartis Foundation. You know, the OECD says there's about 630 tech incubators in Africa, but I don't know too many that are focused only on health. So super encouraging to see that happen as well. And we'll move to the next slide. A quick glimpse of where do we stand with connectivity, because like I said before, if we're not connected, we cannot do digital health. So quick comparison to the right there. Africa is still at 33%, you know, compared to some of the other regions in the world. So quite a bit of work there still to be done. The affordability is still a major problem. As you can see, there's a huge variety across Africa, by the way. In DRC, it still costs 20% of the gross national income to just have 1 gigabyte, to the cost of 1 gigabyte. Now, 1 gigabyte, I don't know about you guys, but when I travel, I use that up in about 1 day. You do 2 or 3 Zooms and do some emails, so it's not much data. And yet, if you were, just so you understand, 20% of GNI, if you were an American, that would mean, on the comparison to the US GNI, that you would be paying for 1 giga of connectivity over $13,000 a month, okay? So just so you understand the reality still. It's not happening across the board in Africa. There are some countries where it's better. I cite, for example, in Egypt, where it's only 0.5%. Kenya is actually doing quite well. Connectivity, you can see that only 26% of people in rural areas are using the internet, way too low still. And we still have 500 million people not using mobile internet in Africa. So yes, there has been huge progress, but still a lot to be done on the connectivity side for us to be completely be able to develop digital health. Thank you, Jai. Very quickly, a glimpse on the maturity of where we stand with what I call the roads. Pierre yesterday very nicely called it the trunk of a tree. I love that analogy. I don't know where Pierre went. Which are absolutely necessary, meaning the national digital health strategies, the governments putting together the rules, the regulations, the standards, the interoperability, the governance, et cetera, 34 countries in Africa have actually written a national digital health strategy, which doesn't mean much if you don't implement it. And only 12 countries have actually implemented these strategies. My feeling is that there's going to be a huge push towards that because of all this acceleration that I was describing to you. And I'm very hopeful for that because it's really fundamental that this happens. From a data governance perspective, which is also extremely important. So we're talking about data security, data storage, data exchange, data privacy, et cetera. And COVID has, of course, accelerated the need for this protection because during COVID, we had to exchange all this personal data. And so the good news is it is accelerating. There's many countries that have actually enacted new laws also since COVID, but the reality is that there's only half of the African countries still who have actually passed the legislation on this front. So still progress to be done. And since we're talking about governance, I'm going to hand the mic over to Jai, who's going to tell you a little bit more about that. Thank you.
Thanks, Florence. I think everyone agrees that in digital health, a lot matters in terms of data governance. So without having that, it's difficult to achieve, also provide safe digital healthcare. And Transform Health Coalition released this health data governance principles on just recently, a couple of months ago, on 7th of April. And then this was evolved organically, and then it went through different stages of review and then contributions from a lot of experts, regional organizations. And then we had this 3 broad pillars, that is protecting people, promoting health value, and then also prioritizing health equity. And these principles, they are not in conflict with any of the existing ones because there have been other efforts as well. In fact, WHO organized the summit on health data governance last year. So these principles are not in conflict with anyone, and then these have been endorsed by over 100 organizations and then many countries. In fact, recently there was also a meet in Geneva during the World Health Assembly, and then many countries have shown interest to actually endorse these principles and adopt them as well. So this is something that is very interesting. And then this main salient feature that I would like to highlight is this brings this lens on health, human rights and health equity. And then, of course, Mathilde is here. And then if you want any further information regarding health data governance principles, you could contact her. And let me move to the Asia. Asia in terms of, the trend, a bit of a trends of what is happening in Asia, and then move over to what we are practically doing from a regional network point of view, which I'm representing today, AHIN, Asia eHealth Information Network. And in Asia, the trend is there is a rise in health ecosystems. And then, for example, I've given some examples from Asia, that includes Indonesia, India, and China. You could see that these ecosystems are already catering to about 1 billion people. And then what's happening is there is a trend that people prefer to have single touch point in healthcare. And this could also include digital. And this is something that we found in Asia. A lot of people, especially after the COVID, and they are very comfortable to have this digital touch points. And Asia, it's a region of many variations. I would like to come about it a little later, but then we do have less number of doctors for 1,000 people. So when compared to the OECD countries, and then the population is also aging. By 2025, we are expecting to have over 450 million people who are senior citizens. That constitutes about 10% of the population. That naturally means that the demand for healthcare is going to actually rise. And then the digital health, in terms of digital health value, like by 2025, it's going to be about 100 billion, the value creation. And as I said, like the region is very diverse in terms of, the culture, the healthcare systems, the language, and, even the regulations also vary. And we have half the world's internet users are based in Asia. And then the government spend about 4.5% of the GDP, which is comparatively low when compared to many of your countries. And then governments foot the bill about over 60% in terms of health expenditure. And then, yeah, I think I'll move over to the next. And then this also brings to the point, like I think Florence also highlighted, there is also a fragmentation, and then there needs to be a coordination. But before that, we need to have a mechanism, because I'm sure that most of the countries have regulations enacted decades ago. They are not suitable for this digital health environment currently. They are meant for health, but they're a bit archaic. So innovations usually tend to have conflicts with regulations. And to amend the existing law takes years, typically. Like for example, India introduced this bill on personal data protection in 2019. It is still being debated. I'm sure that many other countries in the region as well as elsewhere also have the same problem. So what this trend is emerging. This is not something new. This was used in fintech, but this concept is now actually coming into digital health, where we have this regulatory sandboxes, and then where we have a very safe controlled environment, where we have this new technologies being applied under the approval of the regulators. And then if it passes, then they are empaneled into the services, whether it is application. And then also this actually keeps the risk, takes care of the risk, as well as balances the pace of regulations. So these 4 examples is what I'm able to say, but there are more. But these are prominent examples. One from Singapore, they started in 2018, and then India, 2020, it's known as National Digital Health Sandbox Environment. And then we also have from Indonesia, and then they focused, I think, starting with malaria, but then it's also extendable to other environment as well. It's not only not only for malaria. And then Malaysia has also started. And then many countries are also taking the example of Singapore, and then also having this kind of tie-up and having this knowledge exchange. And this is something that is happening in the region. I would suggest any country moving into innovations actually focus on having this kind of regulatory sandboxes in the country. And in terms of digital maturity, a lot of efforts have gone in Asia. And then we from Asia eHealth Information Network, and then in 10 years of learning from a network point of view, we suggest a simple framework known as governance gaps framework. That's governance, architecture, program, people and program management, standards and interoperability. There are multiple frameworks, of course, but in our experience, most of the problems or issues or challenges related to digital health could be related to these 4. And then we have already had this assessment done in 2017, and then now we are doing 2.0 right now, with 13 countries already sending their preliminary feedback. And then this is an ongoing exercise that we will conclude in the month of October, when we are having the annual general meeting, where we will release the the regional assessment. And we are also tied up with Health Enable, who has this global digital health indicators, and then we are working with them closely. And then currently, in fact, like we had this Asia workshop, and then they work with other regions as well, especially Africa and LATAM. And then having this kind of standardized indicators actually helps to keep track of where the country is in terms of maturity. In fact, like it also gives the confidence to donors and development partners what to invest and which countries to invest. So this is something that, again, I suggest. And these are the countries like who are the early adopters. I'm focusing only on Asia. It's happening in other regions as well. And then again, like we found one problem with in the region, that is multi-sectoral coordination is very much lacking. And that is very, very essential. And that is where EHIN also brings this concept of convergence workshops, and we have worked with 7 countries so far over the last 7 years. And then our role being a regional digital health network, we are not a corporate body, and we are a very neutral body who are whose mandate is worked together with the WHO country office or the regional offices, and then also the ministries of health. So we basically help them convene these varied stakeholders, because typically what happens is it's not just Ministry of Health alone who makes the decisions in terms of digital health investments especially. So usually the ministries of IT or telecom, and then some countries now also have this Ministry of Digital Economy. Of late they are having this, and then also sometimes we also have this post and telecommunication or other ministries. So we try to bring together multiple ministries who are relevant to digital health, not only the ministries, the academy, the professional societies, because in some countries, the professional societies in health and digital health or informatics play a major role. We try to bring everybody on the same page and then have the National Digital Health Strategy Roadmap being built. This is something that we have done. This kit is published by Asian Development Bank. How to do if any countries or anyone would like to conduct similar convergence workshop, like you can refer to this toolkit, and then also you can contact. We are willing to share this experience, and then in fact the development partners have approached us to take this experience beyond Asia. We are actually actively working with one of them right now to do it in the Middle East. And then this is my last slide, and basically this summarizes EHIN's goals. Like, we want a stronger networking, and then we want to we are already working with our peer networks in Latin America, and then Africa, and then Pacific Islands. And then we believe in actually co-creating the projects, because languages could be different, but then the underlying issue or the topic is the same. And then we believe in peer learning, sharing, and support. And then we have this mantra from EHIN that encourage cooperation, enable collaboration, ensure coordination, and then endeavor convergence, which I talked about, the convergence workshop, and that leads to an experience that is coherent. Because in terms of digital health that spans multiple domains, we need a coherent approach. Thank you very much.
So a very, very quick conclusion, because Lionel was giving me the big eyes. So these are kind of the key things that we want to leave you with Jai, on sort of, you mentioned the trends, what's happening, right? There are multiple challenges to be addressed, but here are the key ones that we think is this need for more coordination and governance. I insisted on that earlier. There's the need for more government leadership. We talked about only in Africa, for example, but it's the same for you, I think, Jai, in Asia, right? And in fact, I realized I skipped. I just want to go back to Africa for a minute, and it's important. The African Union is about to publish a digital health strategy. CDC Africa is ramping up, about to publish a digital health strategy. Smart Africa, digital health blueprint, be on the lookout. This all goes back to the government leadership, because all of these things are going to help us push governments. Need for capacity building is huge. I won't stay too long on that. Fondation Pierre Fabre finances already a degree. COB is here, but there are a few more, but we need more and more people to be touched. The push for Internet for all, I think I don't need to stay, I already presented the slide, still efforts on that. We're hoping the Smart Africa initiative will get ICT ministers, at least in Africa, way more involved. And this increased emphasis on equity and inclusion, Jai, you just talked about that. It's very interesting, and if you can skip to the next slide so they can visualize it, it's the hot topic. I've always thought it was all about that. I said, you know, digital to me equals access, but that's the big words. And you see the headlines to the right, you see some seminal reports to the left that have just published. Everyone is talking about those two words, inclusion and equity. So we'll leave you at that. There is the Dr. Tedros quote there. Did you want to say 2 words only? Because Lionel otherwise is going to, about the IT report.
Talked about the Broadband Commission report on virtual healthcare. And
micro, Jai, le micro, voilà.
How telehealth is like picking up or picked up already in countries. And then this ITU, WHO ITU standard on accessibility of telehealth services is very important. It was just launched on June 16th, and a lot of traction is already happening. For example, Derek is here from WHO HQ, and we are already working with Government of India, like, which has this largest national telehealth service in the world. And then we are actually collaborating with them to have this standard actually incorporated into the application. So that will make a lot of difference. Thank you.
Merci à tous les deux. Restez avec nous juste une toute petite minute. On peut les féliciter parce que c'est un travail.
Oui,
Jai.
Sorry, I just forgot to mention that I talked about the convergence workshops, and 5 days from now, the Foundation Prefab team is going to be in Laopedia to actually follow up on supporting the country in terms of digital health strategy. Just wanted to mention that. Thank you very much.
Restez juste une toute petite minute et on peut vraiment les applaudir parce que c'est un travail qui est difficile à faire, qui est complexe à faire et dans lequel on sent qu'ils ont mis tout leur cœur, leur passion et qu'ils avaient envie de nous le communiquer aujourd'hui. En tout cas, on en retient que ce soit dans le Sud comme dans le Nord. Depuis 2 ans, les investissements en santé digitale sont exponentiels et sont des fonds d'investissement. On est sur une tendance qui maintenant est durable. La digitalisation de la santé est complètement lancée. On n'est plus en train de parler d'un tout petit précaré ou d'un petit corner à côté de la santé. Non, elle est en train de se digitaliser et les choses vont augmenter dans les prochaines années. On retient, et c'est aussi un des thèmes principaux de ces journées, que si les investissements sont exponentiels, en face de nous, on a des structures qui peuvent être parfois isolées et on a un monde qui doit aujourd'hui se consolider, se rassembler et c'est l'une des grandes réflexions que nous allons mener tout au long de cette journée. Et enfin, ne pas oublier que si la digitalisation de la santé permet de rapprocher les personnes, de rapprocher les malades et de rapprocher les soignants, elle peut aussi créer des divergences et créer des mondes qui se séparent, malheureusement, que l'on ait accès à Internet ou pas, physiquement, financièrement. Et on voit aussi parfois ce schisme qui peut se passer sur des continents, que ce soit en Asie ou en Afrique, où on voit une Afrique anglophone très avancée dans sa digitalisation et une Afrique francophone un peu plus à la peine. Ça fait beaucoup réagir nos internautes, hein, votre intervention. Je ne vais pas poser beaucoup de questions, mais je voudrais saluer Corinne en Côte d'Ivoire qui nous dit « Nous, en Côte d'Ivoire, nous, agents de santé, avons besoin d'un centre de e-santé ». Voilà, le message est passé dans cette journée. Billon de l'université de Cocody, qu'on salue au passage, qui me dit la e-santé, il a raison de nous le rappeler, ce n'est pas simplement de mettre des ordinateurs dans une salle, c'est un peu plus que ça. Et puis il y a cette autre question que je voulais vous poser très rapidement, si vous voulez, à l'un à l'autre de cet internaute qui ne nous a pas dit son nom, mais qu'on salue quand même au passage, et qui me dit, y a-t-il beaucoup de passages, de partage, d'expérience entre les innovateurs et les chercheurs en santé digitale, entre l'Asie et l'Afrique, parce que vous avez bien présenté la situation sur chacun des continents, dans des visions très macro, mais est-ce que ça communique beaucoup ou est-ce qu'on est sur 2 systèmes de recherche encore séparés? Jai, au micro, voilà, merci.
We do have the relations with regional digital health networks in Latin America as well as Africa, like for example, African Alliance. And then we also have with ACFI, African Center for E-Health Excellence, based in South Africa. So we do have such relations. We do invite each other for our events, and we do collaborate, especially in terms of normative guidelines or any publications that we do. We already have this collaboration happening, and in fact, we have worked across, like for example, Health Information Systems program also to actually do the curricula. So we have worked together.
Ah, merci. Voilà. Bon message d'espoir et de coopération. Merci à tous les deux de cette intervention. On disait, hein, ce spectre de la santé digitale, il est large, il est complexe, il est sans cesse mouvant. Et donc les équipes de la Fondation Pierre Fabre, elles le scrutent grâce à cet observatoire depuis plus de 6 ans. On rappelle, hein, cet observatoire, il identifie, il documente, on envoie des gens sur le terrain, mener des enquêtes terrain, on répertorie véritablement les initiatives en e-santé dans les pays du Sud. L'observatoire, il faut le signaler, il est en accès libre, il est en accès gratuit, il a fait peau neuve sur odes.io et cette banque de renseignements, elle est aujourd'hui bien conséquente. C'est un travail unique qui est mené et pour vraiment se rendre compte de la valeur de ce travail, bien, je vous propose d'en découvrir les principaux chiffres en images.
Health and
Voilà, très très beau travail qu'on peut vraiment applaudir, mené par les équipes de la Fondation Pierre Fabre qui sont dans cette salle et aussi tous leurs partenaires qu'on a vus tout à l'heure. Et pour fournir toutes ces données depuis déjà 6 ans, je vous le disais, cet observatoire ne se contente pas de répertorier les initiatives. Il y a des équipes qui sont envoyées directement sur le terrain pour en savoir plus sur les déploiements des projets. Des spécialistes sont aussi envoyés sur place pour évaluer l'évolution des projets, cette fois-ci sur du très long terme, notamment les projets récompensés chaque année par les prix de l'Observatoire et appuyés derrière dans leur développement par les équipes de la Fondation Pierre Fabre. Et vous avez mené ce travail, Philippe Lepère. Vous êtes expert en santé mondiale après une longue carrière à l'étranger, dans des ONG, dans des institutions publiques. Vous avez beaucoup travaillé aussi pour ONU-SIDA et vous avez donc suivi 4 projets, entre autres sur du long terme, soutenus par la Fondation Pierre Fabre. Et on va s'attarder donc avec beaucoup d'intérêt sur vos conclusions. Alors, l'idée très claire dans les choses, c'est pas d'aller décerner des bons points ou des mauvais points à chaque projet. Ce n'est absolument pas l'idée de ce constat. On est dans une journée aujourd'hui sur la capitalisation. Donc l'idée, c'est vraiment d'aller voir quels sont les facteurs de réussite de chaque projet, les difficultés aussi qu'ont pu rencontrer les projets et comment tout le monde, qu'on soit en Asie, en Afrique ou en Amérique, comment on peut s'appuyer là-dessus pour se développer et aller plus vite. Et on va essayer de voir tout au long de cette session s'il y a de grandes règles générales finalement à respecter, s'il y a une synthèse que l'on peut faire de cette étude de projet. On va peut-être commencer, Philippe, par YEDA, qui est un projet qui est mené par l'ONG Terre des Hommes au Burkina Faso. Et on découvre tout de suite ce projet en images.
Ce qui a été révolutionnaire et décisif pour YEDA, c'est le fait qu'on a assez simplement finalement digitalisé des protocoles de prise en charge qui existaient, qui avaient été définis par l'OMS, mais qui étaient très difficilement applicables par les agents de santé au niveau périphérique. Donc, tout notre objectif a été justement de faire que ces protocoles soient plus appliqués qu'ils ne l'étaient auparavant. Et c'est en ça que ça a été révolutionnaire finalement, c'est qu'on a, avec du digital, apporté une réponse à cette problématique d'application des protocoles. C'est une co-création avec le ministère de la Santé. Cette approche, elle vise principalement à améliorer la qualité des soins qui sont prodigués au niveau des centres de santé périphériques, donc le niveau primaire du système de santé au Burkina Faso. Un des autres objectifs de YEDA est d'améliorer la qualité des données qui sont collectées et qui permettent justement au système de santé de construire leur politique et leur stratégie sur le pays.
Depuis 2018, on a élaboré un plan de transfert de technologie et également de la base de données sur les serveurs du ministère de la Santé. C'est une très bonne chose que YEDA puisse être repris par le ministère de la Santé, et en ce sens que cette reprise en main par le ministère de la Santé va permettre que la prise de décision puisse être faite sur des bases factuelles, parce que les données seront capitalisées par les systèmes de santé.
Voilà ce beau projet YEDA mené par Terre des Hommes, entre autres au Burkina. Philippe, vous êtes allé sur place avec une belle originalité et aussi une belle réussite de ce projet. C'est un passage à l'échelle.
Because you've been scaling up this project. Answer. Well, yes. I think that is the only project that we have been able to scale up national level. in this area of Africa. Normally, we have small pilot projects, what we call pilotype, that is to say small local projects. But here, as you can see here with the numbers, 85% of the overall territory. That's fantastic. Now, this is speaking of capitalizing and assessing the project. So it's a project, if I understood well, which you can assess easily when it comes to the impact on the different populations. Answer, yes, a few studies have been conducted, and you see that people consume less antibiotics, minus 15%, as you've seen on the slide, but we also have national indicators. And as shown by these indicators, there is an impact at several levels, that is to say, in terms of medical practice and for healthcare workers and professionals, things have changed. That is to say, the nurse is going to be close to the mother and for diagnosis with the mother. Instead of prescribing an antibiotic for a child who has fever, then he's going to start trying to help the mother to drop the fever with, let's say, a damp blanket, for instance. But this really has an impact on the medical practice, more proximity. And this means that today, if you have a mother who comes to the health center, if the nurse has a follow-up, she's going to leave because she's going to say, well, if you don't use a tablet, well, then I'm going to leave. But the mother is with the nurse and sees what's going on during the consultation. That's very important because they really have the impression that they share this, because when we reinforce the health system, it's really the well-being of clinicians and healthcare professionals, which is also another asset, another challenge, because the relationships can be much better with the patients if the healthcare providers feel better. This has a real impact when it comes to using this tablet. So this is very significant. And I must say that when we speak of capitalizing of assessment, well, we usually look at numbers, as I say, less antibiotics, and also how many people who are being treated. But we always forget that digital tools also imply a change, a modification in the relationship between patients and care health providers, because patients are embarked in this new approach. Yes, because if you only look into numbers and you forget that we have a better diagnosis, it doesn't help us to better give or distribute drugs, for instance, because you're not going to have the same indicators. Indicators are not going to change because you're always going to have the same morbidity rate, for instance. But you have to take into account the indicators, but also this relationship between healthcare providers and patients. Yes, because as you said, these indicators is something which will give us more information concerning what the health providers do. But what about the relationship between the patient and the doctor, the physician, the nurse? We need what we call informal indicators. Answer, yes, another indicator could be the expenses of the households, because if you have better treatments, if the treatment has an added value, then you don't come back and see the doctor. If your kid has fever, for instance, that means that you can be more available to go and work in the field. You don't have to spend money when you have to go to one point for another, so it helps the households. And if we look at the indicators of health improvement, that this makes a real difference. Yes, we've been speaking of very positive achievements with LIDA, thanks to these indicators. Now, is this a perennial, sustainable project? Answer, no, unfortunately. But this is something we're going to find with all the other projects. If you want it to be sustainable, you have to consider other factors, other items, and no project today is really sustainable for many reasons. I could go into this if you want to. For LIDA, for instance, the project has been scaled. It has been co-built and developed with the Ministry of Health, but the non-governmental organization has been implementing this, has been deploying this more rapidly than the ministry, because it has access to international funds the ministry doesn't have, and therefore, and the donors. So it's, I would say that it's a funding which is based on the results. So every 3 months you have to show that you have good results. So the ministry cannot keep up with that pace. So this is why the huge issue we have is how can we transfer this project to the Ministry of Health? Because the pace is not the same between the non-governmental, the NGOs, and the ministry. And the data is today being hosted in the United States. So we have a huge problem of transferring this data from the United States to the Burkina Faso. We also have another host center, which is in Oslo. So can you imagine what this means? Now, as we have scaled this project, we see here that the data is not being hosted by the Ministry of Health of Burkina Faso. And even though if they did, they don't have workforces for that. They don't have enough people, enough staff. So they couldn't use the data for their policy, their health policy. And another aspect is we don't know how much this project is costing because we never had a real economic audit. We don't know how much this costs for each patient. So when we speak of sustainability, you need a business model. And this is something you will find in all projects. Yes, Philippe, I would like to come back for a few seconds. Okay, this is a fantastic project. It's 85% of the population which has been included in this project. And therefore, that means that you've been able to reach population which doesn't always have access to medical treatments. We have an NGO which is very active, but maybe is going too fast because, as you said, the public institution can't keep up with that pace. Now, and the NGO is using tools that it controls very well, but sending data to the United States, to Europe. And this also means that from an environmental point of view, it's not the best approach. And you've said maybe we didn't take into account all the aspects when building up this project. Now, could you tell us if this is a problem with other files, other projects? Because if you start with NGOs, that means you start with a specific architecture. Maybe you have to reinforce this kind of structures to start with. Answer. Well, Terre des Hommes has been a pioneer because they have started developing this kind of project before we had this overall policy for digital health, before we had regulations, and therefore it's a learning by doing process, if I can say so. That is to say, they've been learning as they were doing. And this is something which is true for the NGOs and the government. There was no pre-established plan or program. It's a process which has been, I would say, growing progressively, and as it grew, it would start being rolled out and cross-fertilized. But now, I think that at this stage, we would have to see what are the lessons we can draw from this process, because what scale should we have when we start with this kind of project? As I said before, we're not trying to rank these projects and saying this one is good, this one is not as good. No, what we're trying to show are all the projects which have been accompanied, which have been supported by the Pierre Fabre Foundation. Now, having said this, we have many NGOs who would like to have the same situations that we have in Terre des Hommes, because I must say that it's a rather comfortable situation and the results are rather good. And I would like to remind you that we're speaking here that we've been scaling this at national level, which is quite exceptional. Another project which has been supported by the Pierre Fabre Foundation is the 16B, that is to say in Cameroon, and the blood donors. So what about the traceability in this field? Now, to answer, I would say that Cameroon is in a special situation, because I've been moving around in the French-speaking African countries, and I've been rather surprised to see that there was no national strategy when you had these blood transfusion. It wasn't really secured. It's now being done, but there is no political will so as to secure the blood transfusion and the blood donors organization. Now, I think that in 1995, the manager of the Yaoundé National Hospital said, we have to do something about this. We have to improve the organization and have what we call blood banks. And they started doing this. They have a specific team now. They have premises for that. But he realized, in spite of this, that the follow-up would not ensure the traceability and the security which was required. And and therefore
international.
he said, well, we have to make sure we have more traceability at international level. And in GenB in South Africa started partnering with this blood bank. It's a concept which comes from a South African country in which takes into account the African country specificity. So they started establishing this partnership. So I think that this is a success because this has been abiding by specific specifications. So there has been an organization. Well, I'll answer by saying that in France, we know that we have volunteers who give their blood. In Cameroon, people get paid for that. So you see, the software we have now targets, tracks people, and people who come every week because they want to get paid for that. We say, no, you have to wait 3 months before you come back. So I think that's already a good tracking system, but we have other specificities at local level which are really embedded in the software. And I think that this is thanks to the partnership between South Africa and Cameroon, and they also have a certification of the Blood Transfusion African Society. So it's the only one we have which is now being digitalized. So that means we have a partnership between South-South, in which works, which is running. We have better traceability, at least for the institutions and persons who are working with this hospital. Now, I would say that nonetheless, there are some hitches, there are some weaknesses. Why? I wouldn't say that it's a tool which makes the difference and which is defective. I think that our government today is going to start reorganizing what we've done up to now, because so you have a tool which can be a robust tool, and you have other blood banks which are now being organized, but they don't have the tool and they have not received any kind of certification. So that means that you can duplicate the model? Yeah, why not? That would be maybe one of the rationales. But the organization has been given and thrusted to the WHO. So what is the health organization going to do? Are they going to certify this tool? Now, if they choose another model, that means that the model we have, which works where, is going to become illegal. Now, I think that this is another aspect which we have to discuss. Before you scale the project, you have to ask the government if he accepts, and then the government says we have to look for a partnership with an international entity, and this is going to take time. This is going to be time-consuming. That means that your project is going to be a standby project, and we don't know how you're going to be able to scale this up, or if the project is going to disappear. Another weakness in the PSSB project, which concerns probably 80% of the projects in e-health, is that very often it's a project which is based on trust, on relationships between men and women who are very motivated. But when you scale this up, it's more difficult, isn't it? Answer: well, this is true. Literature never speaks about the human aspect of the projects and the human involvement. In the case of Cameroon, if we didn't have this involvement of Professor Fuga, we wouldn't have been able to set up this blood bank. So thanks to the manager of the hospital, we were able to do that. And I think that some people leave because they retire. I don't know what's going to happen when he is going to retire. Now, this is an autonomous blood bank, and he was able, as manager of the hospital, the executive manager of the hospital, to get financial support from the Ministry of Finance, but also he's been able to secure the budget he has in his own hospital for this blood data. So what's going to happen in the future? We don't know. So probably his leadership has been very important. In 3 or 4 years from now, I don't know what's going to happen. Is this project still going to be sustainable or not? Now, this is not only a subject or an issue which concerns the digital health, but it's something which concerns any kind of company. If you have a manager who has leadership, who is a pioneer, how can you prepare the transition when those persons leave, or when you have other companies or other organizations or entities coming in? How can you prepare this transition? How can you manage this? Because this is another possible weakness, and this is something you have to keep in mind when you launch a project. Now, another continent, another project we know, because it's been awarded, it's Cushy Baby. Cushy Baby in India, and the Kushi Baby project is a project which has been developed in the northern part of India, so as to facilitate the traditional healthcare system, which were rather poor, and also help remote population. They received an award from the foundation, GAFAB, a small collar small kids have, or where you have all the information, infants, for instance, where you have all the information concerning vaccines, and therefore if you have a tablet or phone, you get all the information which are in the pendants that or necklace that these babies or infants wear. And therefore there are other projects which have been cropping up, especially after COVID, and Kushi Baby now is working hand in hand with the Rajasthan Health Services. Now, Philippe, what do you think about this? What about the scaling up of this project, Kushi Baby? Well, this is the government of Rajasthan which has been rolling out this project. Now, if we look at AIDA, this is something different because this is something which started according to the concept we have 30 years ago. That is to say, it's an NGO which started. Now, it's different because it's the government who started this, and Kushi Baby, who is really the service provider, and therefore the philosophy, the ideas have been I would say, cropping up thanks to the motivation of specific people who in the Rajasthan state in India were trying to have dashboards to see how they could manage the access to e-health. And when they started working with the ministry, when the Kushi Baby team started working with the government, well, they set up a specific community and they worked together. They've been collaborating, but all has been funded by the government today. So all the initiatives, salaries of the healthcare staff, and so all this has been funded by the government. Now, of course, research has not been funded by the government. It's been the budget of Kushi Baby for the tools, for instance. Now, Philippe, I would like to say that the government really wanted to digitalize health, and I think that this is something very specific to the Indian government. Yes, because you have Digital India, which was launched a few years ago by the Indian, so as to have a digitalized society, and the unique identifier and the access through digital tools. This is something which started a few years ago. Now, in YEDA, you also have this digitalized file, medical file, which will stay, which will be hosted in the health center. And this is also the case of Kushi Baby. You see here on these images that they have adapted. It was a pendant, it was a card. Now it's just a sticker that you can use where you have all the information, and this is now being adapted. But you see, this is a model, a development model, which I think is very interesting, very challenging, because it's the government which is starting this, but working hand in hand with a company. Now, you said that in this project, something very specific is that the government works with a company and not with an NGO. Now, is this different from what we've just said before? Well, the difference is that the founders of Kushi Baby have been visionaries, they've been pioneers, because to start with, they've been working with a team of people who are very complementary one with another. You have different profiles, people coming from public entities, engineering, health sector. You have all the skills you need, and all the teams can work together. It's cross-sectional. It's a kind of sectional. You have a manager, but then you have really everybody at the same level. Everybody has a role to play because they can't do anything without the other people of the team. And that is why everybody really masters the tool. And this in a very startup environment. Yes, because when you speak with people, they say, well, of course I would be better paid at another company, a big company, but it wouldn't be as challenging and motivating. But now we work here all together and we are doing this for people, and that's why we feel happy. So it scales up. You work hand in hand with the government. So for Kushi Baby, that's fantastic.
là aussi,
Are there some weaknesses in
on pourrait
the
dire que tout roule, mais il
that
n'y a pas eu
solution? Well,
d'évaluation
we could
économique. On
say
ne sait
so,
pas
but there has
combien
not
coûte
been any
la prise en
financial
charge. Il y a
assessment.
beaucoup de choses
We do not know
tous
how
les
much
aspects
it
économiques n'ont
costs
pas été
to
abordés.
manage with
Et
children.
puis
Not all
je dirais, s'il
economical
faut être un peu
aspects have
critique,
been tackled.
c'est que leur
And again,
faiblesse
if we
vient de
were
leur
to
force. En
criticize,
fait.
I think
Toujours,
that
c'est
their
comme ça, le
weaknesses
facteur humain, c'est une
also
équipe qui est très
linked
jeune, qui
to
est très
their
dynamique,
strengths.
et qui
It's a
travaille
very
des
young
heures et des
team.
heures, qui
They're
ne
very
comptent pas les heures.
dynamic.
Mais
They work hours on
la
end.
contrepartie, c'est de
But
la
on the
jeunesse et du
downside of
dynamisme,
it,
c'est peut-être
they're
le manque
very dynamic
d'expérience.
and young, but I suppose
Et
that
donc,
they
dans
also
l'équipe,
lack
il n'y a pas
experience. And
Ça manque de vieux, quoi.
unfortunately,
Ce que vous êtes en train de nous
there
dire.
are not enough elderly
On va dire les choses
citizens.
correctement.
You need more
C'est ça.
experience
Donc,
and
voilà, c'est-
older members of staff. So you need to say things as
Dernier
they are.
projet, dernier pays,
Now,
on part au
last project,
Bangladesh,
last
cette fois-ci avec
country, we're going to
un
travel
autre
to
projet qui a été
Bangladesh
primé
with
ici,
another
récompensé
country,
ici, donc
which
encouragé,
received an
soutenu par la
award
Fondation
here
Pierre Fabre, qui
by
s'appelle
the
Traumalink,
Pierre
car
Foundation.
le
The
Bangladesh,
name is
on rappelle
Traumalink.
un petit peu
Bangladesh,
rapidement
as a
les
quick
données, c'est un pays où il y a beaucoup
This
d'accidents de la
is
route
a country
et
with
pas
many,
toujours forcément des
road
moyens
accidents.
d'intervention d'urgence
And
pour les
there
victimes. Et
are
Traumalink
no
a formé
emergency
des
services
centaines
for,
de volontaires dans tout le pays, le long des
victims
principaux
of
axes
accidents.
routiers au premier
And so,
secours. Ils ont formé
the
700
Traumalink
hommes, 60 femmes.
trained,
Ils ont mis en place un call center qu'on peut appeler, si on est témoin d'un accident, et le call center, donc par géolocalisation, va aller géolocaliser des personnes qui ont été formées, qui sont volontaires pour aller tout de suite, immédiatement sur l'accident de la route, apporter des premiers secours. Et le call center va s'assurer aussi, va se mettre en relation avec les institutions publiques pour éventuellement déclencher des secours type ambulance, pompiers à venir derrière. Premier constat, avant d'arriver à faiblesse, premier constat, il ne faut jamais l'oublier, c'est un système qui permet de sauver des vies tous les jours au Bangladesh.
Oui, à plusieurs niveaux, parce qu'en fait, au Bangladesh, c'est une route qui est extrêmement meurtrière. Il y a une densité de près de 5 accidents par kilomètre par jour. Faut s'imaginer ce que c'est l'autoroute. Vous avez les bus qui foncent, le gars qui avec sa moto qui, pour économiser quelques kilomètres, va remonter en sens inverse, va zigzaguer entre les bus, il y a le piéton qui va traverser. Et donc, il y a constamment des accidents et les gens qui habitent le long de ces axes routiers, par tradition, vont porter secours aussitôt. Et donc, au début, on s'aperçoit que les gens qui vont porter secours, qui ne connaissent rien en soins de première urgence, peuvent faire plus de mal que de bien, parce que quand on secoue un accidenté, on peut imaginer les dégâts qu'on peut faire. Et donc, là aussi, c'est le facteur humain. C'est l'un des fondateurs de Traumalink a eu son papa qui est décédé d'un accident comme ça. Il a dit, je vais mettre en place une formation en premier secours. Et donc, l'idée première, c'était ça, c'est de former des bénévoles communautaires pour porter secours et porter des bons secours, faire les soins appropriés. Et très vite, l'idée géniale était de créer ce call center pour justement mobiliser très rapidement ces bénévoles de la communauté et surtout organiser la pré-hospitalisation et aussi faire venir les services de police, etc. pour éviter le suraccident. Donc, on sauve des vies en évitant le suraccident, on sauve des vies en intervenant dans ce qu'on appelle l'heure d'or, c'est-à-dire en moins d'une heure, la personne accidentée est transférée à l'hôpital. On sauve des vies en organisant l'ambulance, parce qu'il n'y a pas d'ambulance dans le pays, pratiquement. Là aussi, comme pour tout ce qu'on fait dans la santé numérique, on est victime ou tributaire des faiblesses du système de santé. Là, le problème, c'est les transports. Donc, le call center, une fois que l'accident est géolocalisé, s'occupe aussi de mobiliser les secours pendant que les bénévoles ne focalisent que sur la prise en charge de l'accidenté.
Et là aussi, comme dans de nombreux projets de santé digitale, autre point commun, on a une maîtrise tech qui est quand même impressionnante, un vrai savoir-faire avec ce call center et une capacité à géolocaliser des volontaires et à les déclencher. C'est pas rien.
Oui, et puis c'est d'autant plus extraordinaire que leur trousse de pharmacie est placée au bord de la route, parce qu'il y a plein de petites boutiques le long de la route, elle est toujours dans une des boutiques, et donc les volontaires sont mobilisés immédiatement, viennent de chez eux, ils savent que le matériel est déjà prépositionné, et ils peuvent intervenir, et ils savent que la police va arriver pour sécuriser l'accident.
Alors on voit une notion de service total, rendre service, sauver des vies, aller jusqu'au dernier kilomètre, c'est le cas de le dire, là on le fait, maîtrise de la tech, call center, géolocalisation, reconnaissance du savoir-faire, adhésion de la population, on forme également de la population par centaines au premier secours. Ça, ce sont tous les points très positifs de ce sujet, embarquer les gens avec nous grâce au numérique dans les faiblesses.
Peut-être un point positif que j'ai oublié, mais qui me paraît très important, c'est une conséquence non intentionnelle du programme. C'est que les gens, les bénévoles sont tellement bien formés que dès qu'il y a un accident domestique ou un accident au champ, ce sont eux qui interviennent et donc permettent un désengorgement du système de santé aussi.
Et ça, on ne le retrouve pas forcément dans les chiffres classiques d'une évaluation de projet. Ce sont les fameux éléments périphériques dont vous parliez tout à l'heure.
Dans les faiblesses, c'est des faiblesses un peu structurelles aussi. C'est le manque de financement de l'ONG. C'est une toute petite structure, Tromalink. Et à chaque fois qu'ils arrivent à mobiliser un petit financement, ils progressent par 10 km par 10 km. Et donc, ils sont à un carrefour. Soit ils continuent comme ça 10 km par 10 km, soit ils se posent et disent tiens, on va changer de dimension, on va mobiliser. Et donc là, ça suppose peut-être une réforme de l'ONG, de voir comment fonctionner si on change de dimension. Et la deuxième faiblesse, c'est que, contrairement par exemple au Burkina Faso, où il y a une réelle volonté politique, ou en Inde, il y a une réelle volonté politique, là on est plus comme au Cameroun, où il n'y a pas de volonté politique de faire quelque chose. C'est-à-dire que la sécurité routière n'est pas une préoccupation pour le gouvernement du Bangladesh. Il n'y a pas de stratégie de sécurité routière, il n'y a pas de stratégie de prise en charge des accidentés de la route.
C'est-à-dire qu'à un moment, ceci c'est une constante, le passage à l'échelle est réellement complètement bloqué, impossible si la volonté politique ne suit pas. Il n'y a pas de pérennisation possible sans volonté politique.
Voilà, parce qu'en fait, il n'y aura pas d'intégration dans le système de santé en tout cas. Et puis là, comme les autres projets, on n'a pas de modèle économique.
And as in many projects, we do not have an economical model or a business model. We don't know how much it costs to manage those accident victims. So we've seen
des grandes règles générales que vous avez essayé de poser quand on va voir sur des diapos, Philippe.
We're going to have a few slides where we summarize the different keys for success or failure. Well, that's a very difficult exercise because we know we're talking about very different contexts, different tools, different scales.
Ce que j'ai retenu, c'est que dans tous les cas, c'est comme avoir un puzzle à 4 pièces où les 4 pièces du puzzle doivent être assemblées pour avoir la pérennité. Donc, il faut un leadership, soit c'est un leadership du porteur de projet tout seul, comme dans le cas du Cameroun, soit c'est un leadership partagé, comme dans le cas de Kouchi Baby. Donc, le facteur humain est quelque chose d'essentiel, ça on l'a vu. Il faut des partenariats solides, donc là encore, c'est le facteur humain avec qui ce leader va pouvoir créer les partenariats nécessaires. Il faut un environnement favorable, donc il faut une stratégie de e-santé, il faut respecter les droits humains, l'éthique, la confidentialité, la protection des données. Donc c'est vrai que le temps est un peu court, parce que, quel que soit le projet, j'aurais demandé, est-ce que votre projet est développé en conformité avec la politique nationale ou avec la stratégie nationale? Et à chaque fois, je ne sais pas s'il existe une stratégie, j'ai fait mon projet, je ne sais pas s'il y a une stratégie, je ne sais pas si c'est en conformité. Est-ce que votre projet respecte les lois du pays vis-à-vis de la protection des données à caractère individuel? À chaque fois, la réponse a été je ne sais pas. Donc ça, c'est des facteurs bon, il se trouve que j'ai recherché les stratégies, j'ai recherché les lois et tout c'était conforme. Donc il n'y a pas de problème. C'est encore une fois des projets qui des fois se sont mis avant la création des lois, avant les trucs, mais tous ont développé leur propre éthique et donc appliquent des règles d'éthique internes à leur organisation. Il se trouve que ces règles d'éthique, bon, elles correspondent heureusement aux compliant with, again, for example, the data privacy regulations. I also mentioned about gender inequalities. You know, in Bangladesh, for example, there are a lot of inequalities, very high gender bias. Access to services is gender-based, and this, of course, not in favor of women. We have a lot more volunteers, 700 male volunteers, and only 60 female volunteers. Now, they're highly recognized, they were empowered, and this is an indirect consequence of this project, an empowerment of these women. This is what I called a favorable environment. This is also a key success factor for sustainability. We also need to work at the same time on the health system, because you can very well improve a sector of the health system, but if you do not have enough medicines, if you do not have enough stocks, if data are not properly used, then your tool is going to be pointless. There's no need in having a good diagnosis if then the patient has no access to the drug. We've seen that in Cameroon is not the case, so it's a daily challenge to really try to fight against this unfavorable environment. And then, of course, eventually, capacité d'absorption du ministère de la Santé, de tout ce que va coûter un projet qui nous, à mon avis, c'est un des facteurs qui nous manque pour pouvoir convaincre un Premier ministre ou un ministre des Finances d'investir dans la santé numérique en disant, mais voilà, c'est un investissement, c'est pas une dépense.
Merci beaucoup Philippe Lepère pour ces explications, surtout ce puzzle un peu magique que vous nous donnez, 4 éléments. Vous dites vraiment il faut que ces 4 éléments soient dans le projet pour avoir un succès. Sur les projets que vous avez vus, malgré les forces et les faiblesses, on n'arrive pas encore à avoir les 4 éléments. Et on voit bien que ce puzzle, il part du terrain, de votre observation de terrain, et non pas d'une observation de bureau qui redescendrait et dégoulinerait sur tout le monde. Ça, c'est important de dire. Merci, on peut applaudir Philippe Lepère pour cette présentation. Et on va donc poursuivre nos réflexions sur cette journée qui est consacrée à la capitalisation sur l'innovation en e-santé. Et on poursuit nos réflexions donc sur l'innovation à e-santé, la manière d'évaluer la e-santé, de capitaliser sur cette innovation. Qui doit évaluer comment, quelles bonnes pratiques en la matière, comment le lien peut-il être fait aussi avec la recherche universitaire. Alors pour aborder ces questions, on va me rejoindre tout de suite Mathilde Forsmund, qui est directrice exécutive de Transform Health. Voilà, venez me rejoindre Mathilde. Et on peut applaudir parce qu'elle est venue de loin, elle est basée à San Francisco. Elle nous expliquera. Transform Health, c'est un regroupement d'organisations qui sont investies dans la transformation digitale de la santé à échelle mondiale. Anis Suad, qui vient aussi de très très loin, de l'autre bout du monde cette fois-ci. Il est chercheur au Centre de politique et gestion de la santé à l'université de Gadjah Mada à Java en Indonésie. Merci infiniment d'être des nôtres. Je sais que les choses ont été compliquées pour arriver jusqu'à Toulouse aujourd'hui. Vous êtes également membre du comité de direction de EIN, le réseau d'information sur la e-santé en Asie. Peut-être voudrez-vous un casque de traduction, si on peut en apporter un pour Anis, pour qu'il arrive à suivre cette table, sinon il va être un peu perdu. Avec nous également, on a la chance de l'avoir en duplex depuis l'Inde, depuis le Rajasthan. On parlait tout à l'heure de son projet. C'est Mohamed Chanawaz qui doit être en face de nous. Mohamed, si vous nous entendez, il est CEO de Cushy Baby, dont on a parlé il y a quelques minutes, et on est très heureux de le retrouver. Il est en face de moi, s'il nous entend, depuis l'Inde, à Udaipur, précisément, dans le Rajasthan. Mohamed, est-ce que vous nous entendez? Alors, je suppose qu'il est en face de moi, mais je vois également 2 sièges vides. Donc, je ne sais pas s'ils sont partis quelques minutes, s'ils se sont absentés. On va essayer de les contacter. Si quelqu'un peut me dire si effectivement ce sont les personnes que je vois à l'écran ou pas, puisqu'à ses côtés doit se trouver également le docteur Jitendra Kumar Soni, qui est directeur de la mission au département de la médecine, santé et protection de la famille au gouvernement du Rajasthan. On les retrouvera, je sais qu'on a la liaison, on va les retrouver, voilà, on est parti les chercher, on va les retrouver d'ici quelques minutes. Le temps qu'on aille vers l'Inde et qu'on me fasse signe de savoir si c'est bon ou pas, on va accueillir également autour de cette table Yvette Gonzalez, qu'on peut applaudir, qui est directrice adjointe du programme santé à l'ONG Terre des Hommes, qui est située en Suisse, et qui gère entre autres parmi ses nombreux programmes YEDA, que l'on a vu tout à l'heure. Anis Fouad, vous me disiez que l'évaluation, puisque c'est le thème central de cette journée, devrait être intégrée dans n'importe quel projet de santé digitale dès le départ. Pourquoi est-ce que c'est si important? Est-ce que c'est réellement le cas aujourd'hui?
Thank you, Lionel, for the questions. I think before I start to answer the question, I enjoy the former discussion that provide a lot of real experience. Sorry. A lot of experience that currently in the world there are many implementations, and I think the evaluation is becoming more and more important currently, not only from the perspective of the government, we heard a lot about this, but also from those implementers, the ONG, and also several programs also from the universities, but also from many institutions that provide the support international organization. So I think it is becoming more and more important, and currently the demand of the patient itself, the demand of the community, because if there is any new intervention without evaluation, they could not feel whether the impact is also coming to them. So I think it is not only about the fact about the number, but also the real impact to the community. It is very important right now.
À Nice, aujourd'hui, vous insistez beaucoup sur cette importance, mais quel est réellement le pourcentage
of an assessment? Now, how many projects are assessed? What is the percentage? Are we talking about 10, 20, 50% of projects are currently assessed?
Yeah, I think I would like to start with the current situation in my country. I am from Indonesia, and Indonesia is, like mentioned by Jai in the presentation, it is a country, even though it is the place that there are many startups is currently right now implemented in the country. There are many optimistic number about the potential of the startup in the country, and also the increasing budget from the country implemented for e-health. But to say the number is in French is very complicated. It's the number is not there. So I think it is the time that there are many participants from around the world. We start together to have a standard method to collect the data and then to measure the impact. So several data as in my country is available from the small scope. But in a number, in a country, it is very difficult to collect. It is also about how to bring awareness to the, for example, research institution. They need to report if they provide a result and give impact to the community. Several methods, for example, scientific method should report, for example, from the beginning. They should provide the procedures. They should provide the protocol. And finally, the impact. So at this, I think it is the time that not only the implementers from the government, any implementers from outside of the government should start to collect the number of impact right now.
Ouais, on sent bien l'importance aujourd'hui grandissante de cette évaluation. On la met peut-être en corrélation avec des chiffres aussi financiers qu'on a tout à l'heure, d'investissement dans les projets de santé digitale. L'un va avec l'autre. Je suis un peu désespéré quand j'entends que les premiers mots en français que Anis a retenus, c'est très compliqué. Bon, ça c'est une parenthèse que je me permets de fermer. Mathilde Forslund, pour vous qui nous arrivez de San Francisco, peut-être tout d'abord un mot rapide sur Transform Health. C'est quoi comme organisation et c'est quoi le but?
What is this organization? What is the purpose?
Yeah, sure. So my name is Mathilde Forslund. I want to say thank you so much for the invitation from PFAB Foundation. It's been really wonderful to be part of this today. So my name is Mathilde Forslund. I'm the Executive Director of Transform Health. And for those of you that don't know us, we are a coalition of organizations that was founded about 2 years ago in 2019. We are a coalition of about 50 organizations. We've grown quite rapidly. And we were set up by 7 founding members in 2019. Our focus is on advocacy and campaigning for stronger political will, which we've heard a lot about today, which is really a very important aspect. And then we also campaign and advocate for a global health data governance framework, which Jai mentioned earlier, which is really crucial to the work that we're doing. And the third aspect is increased and coordinated investment for digital health. So we focus on really the broader enabling environment and the incentive structure that shape the way that digital transformation are deployed, adopted and adapted across different contexts. And I think many have mentioned this here today, there's really an inability or really an unwillingness of many governments to deploy the right policy, regulation, legislation, and funding environment that would enable, digital transformation to happen. So this is really central to the work that we're doing at Transform Health, and we believe that the reason that we cannot achieve digital health transformation and scale digital health transformation is really is not technological, it's actually political. So that's really what we believe that we need to invest in.
Passionnant parce que vous nous expliquez effectivement cette grande règle que l'on a peut-être oubliée en se lançant parfois comme des fous dans la digitalisation.
Sometimes we've forgotten some of these rules when we start digitalization. I think that we need an environment. I think that we have a problem with the sound. Very sorry about that, says the interpreter. So we need a completely secured environment, a stable environment, if we want to be able to assess a project. Now, you've been working with WHO and with 6 target countries. Now, what is the goal? Because you want the 6 countries, the same environment, stabilized environment, the same rules in the 6 countries?
Yes. So our goal is really to build up these national coalitions and to start to really advocate for that enabling environment. So the right legislation, the right policies, the right regulation for digital transformation to happen. And the way that we do that is not by us implementing any of this ourselves, but really to build up these national multi-stakeholder coalitions in different countries, in the 6 priority countries, which is Indonesia, Kenya, Senegal, India, Mexico, and Ecuador. And to really, empower and have them build up their own national coalitions to drive this agenda forward.
Extrêmement important là aussi ce que vous nous dites sur ces 6 pays d'évaluation, la nécessité d'avoir un cadre
global, means that we really need a framework because we have a multifactorial
on a bien vu dans les
situation, and we've seen
des projets qui ont réussi
previously that if a project is successful, it's because at one point in time NGOs and companies are working shoulder to shoulder with the government, and I would say that this is a very exclusive condition or pre-requirement. Now, what about you've been doing with the governments? I think that everyday governments are being approached by start-uppers, by e-health developers, but they don't have the tools they need so as to choose the appropriate project. Did I understand right?
Yeah, sorry, the translation is a bit behind. So what we have been doing, and I'm going to speak specifically to the investment case that we're working on at the moment. So we're advocating for increased and coordinated investment, and I think this has been brought up here many times today. For the equitable, inclusive, and sustainable digital health transformation in LMICs. So we really face a number of challenges at the moment. The first one being that some countries have the funding to invest in digital health transformation, but some countries do require international donations or investments in order for them to build their digital health strategies. Another issue that we're facing is that countries and external stakeholders have really begun to step up their investment in digital technologies. But many investments have so far been very short-term, have been, kind of invested in solutions rather than kind of a systems approach. Another issue is as well that we have, there's a lot of transaction costs on health systems, particularly on healthcare workers with this kind of pilotitis that is happening. And then another issue is as well that policymakers really lack the information or even the understanding of the overall needs and demands for digital-enabled healthcare and healthcare services. The other issue is that obviously investors who choose to invest in digital health, they don't know which solution to invest in because often there's a multitude of investments. They don't know, and governments as well are very confused to which one they should choose to invest in. So this is why we must address this issue and increased investment and coordinated funding to ensure that we have a more sustainable systems-wide approach to at the national level. So in response to this, we have been working with Transform Health with its partners. I mean, we have a rather big network of organizations, including the Job Lange Institute, PATH, Digital Square, and many of the regional networks that are here, including AHIN, Helena, and others, that have been working on this kind of conceptual framework for an investment case that we're going to launch at the World Health Summit in Berlin in October.
Mathilde, très rapidement, dans la nécessité
I would like to ask you, Mathilde, when you have this you want to try to coordinate all this policy and this framework, I would like to ask you if there isn't a risk, because that means that I would say that the governments, for instance, wait to have a stable regulation and also framework before they launch their digital health policy, and the GNOs, for instance, or NGOs, sorry, are going to wait for the regulation too. So if everybody waits for everybody, what's going to happen?
Yeah, I mean, that's a really good question. I think the role that we have is to represent the voice of the unheard and unrepresented, and to really bring the agenda of people to the table of governments, right? So to represent civil society, and we heard a lot about equity and human rights perspectives, and I think that is really what we need to serve up to the government and really make sure that the needs of people are being addressed, by governments and in the decision making.
Yvette Gonzalez, pour vous qui êtes chez Terre des Hommes, qui est en charge entre autres des projets des opérateurs sur le terrain, principalement en Afrique, est-ce que la question de l'évaluation, de la recherche aujourd'hui est systématiquement ou pas tout à fait encore systématiquement?
I would like to know if research is systematically embedded in the project.
Merci beaucoup pour l'invitation pour être là.
Well, thank you very much for this invitation, and thank you for the presentation of the project IEDA with Terre des Hommes. Yes, I would like to say that the organization like Terre des Hommes, well, we can't really have an approach based on assessment. It's not systematic. Why? Because our priority is to be able to develop our activities so as to help people who need us. That's really the priority of Terre des Hommes. Now, the issue we have is that we have a different mindset. And there is a different mindset because we've been there. We've been trying to support this approach. We wanted to improve the quality of the healthcare. It's very important to see what's going on in the field so as to improve what we've been doing. The other challenge is to be able to scale up our projects, and we also have to assess the quality of these projects, which very often are pilot projects, and then scale them up. And the third priority or challenge is to be able to see how we can embed this project in the policies which are currently being adopted, and how can these policies change. How can we base what we do on operational research in the field? Because this gives us evidence, you see, and this can help the decision-making process. Oh, well, thank you for this. I think that you're convinced that assessment is important, and you know that the donors and the governments are expecting reports from you. But you say it's not a priority. It's not obvious because our operators, people who are in the field, are trying to answer, to meet the needs and the expectations of people who need them, and they're not there only so as to provide reports to the governments and so on. So do you agree with the statement? Is that what you really said? Yes, this is obvious, I've said. But even the donors feel like that, not only us and Terre des Hommes, because we have donors who are really involved in this kind of project like Terre des Hommes, and they don't want to invest their money, for instance, in reports and Excel tables and so on. But I think that we have today a small group of donors for whom our interventions, our actions are essential, and therefore they are funding us so as to be able to have these assessments. But having this kind of audit and assessment is very costly. You do this usually with academic partners, and you have to invest money, and you need the money. Now, I want to make sure we understand what you mean by assessing what is going on in the field. When we started preparing this roundtable, Yvette, you told us that there was a program concerning pregnant women in Mali, and that you've been testing this project. Now, it's not easy for the operators working in the field, because what kind of assessment can you really develop? How does this work? Answer. Well, I think that we can speak of a real challenge when you have this kind of assessment in the field. It's the experimental design of the assessment which is the real challenge. Because how can you have an assessment of what you're doing in the field? You have to start doing this at the very start of your project. And you have to see how the project is being developed, is being rolled out, what is the impact in the field. And for this very specific example you have mentioned, we've been working with the Johns Hopkins University for the design of the assessment, and we wanted to have an assessment, case control studies. That means that we have selected, well, we have chosen a small village where we have a first initiative and another village where there was nothing done really, and we've benchmarked all this. Now, what we wanted to do was to benchmark the digitalization of antenatal and postnatal consultation for pregnant women and women who had just given birth. And we wanted to see the difference between the location where you have the electronic tool and where you don't have it. And we've been able to see that the electronic tool can improve the added value of the service.
J'imagine, moi, les opérateurs sur place qui disent, bon, ce village, on va aider les femmes enceintes pour réduire la mortalité des enfants. Et puis ce village, volontairement, on va pas les aider, mais on va aller voir s'il y a plus d'enfants morts dans ce village, parce que c'est ça aussi l'évaluation.
Children who die or infants who die after birth. No, come on. This is not really how people react. Well, people already react like that because they don't have tablets, some have tablets, don't have, some have iPads. Of course, people feel a bit bewildered, but that doesn't mean that we don't help those people or those villages where we don't have the electronic tool. What I'm saying is that when we start setting up the electronic tool in some villages, we want to know what the bias is when you have an assessment, okay? In the villages where you don't use the tablet, well, you still have an intervention and you still try to improve the quality of the healthcare services. You have the whole process of observation, you have supervisors who are here so as to collect the data, okay? We do it, but we have some biases, and therefore we have to take into account these biases. So it's not easy, and this is why we need the electronic tool sometimes. The message I want to convey is that it's not easy to have an assessment of what we're doing in the field, and therefore we need skilled people, skilled team, and we also have to do this with the academic environment, experts who are in the field of operational research, so as to have at hand assessment tools which are really effective.
Je me tourne vers un autre continent, vers l'Inde à présent, où je vois du monde à Udaipur, dans le Rajasthan, qui est en train de nous suivre en direct. Là, ce sont les personnes normalement en charge de Kushi Baby, Mohamed Shanawaz qui devait être là. Qui est-ce qui est présent avec nous aujourd'hui depuis l'Inde pour cette conférence?
Actually, Dr. Jitendra Kumar Soni, IAS, who was supposed to join us in this conference, is unable to join, so sincere apologies for that. On behalf of him, I am Ajay Sharma, co-director of Kushi Baby, is going to present. So we can have this session.
Voilà, je vais essayer de vous poser. On a un tout petit problème de liaison et de son qu'on va essayer de résoudre. Je vous pose, ceci dit, notamment la question sur Kushi Baby. Aujourd'hui, comment assurez-vous l'évaluation de Kushi Baby et qui demande cette évaluation? Est-ce que c'est principalement le gouvernement du Rajasthan?
I would like to hear this conversation in English, if possible, please.
Voilà, je vais vous reposer la question et on va voir. Si on a trop de difficultés de son, on va vous retrouver d'ici quelques minutes. Je vous posais aujourd'hui de manière concrète, comment faites-vous l'évaluation de Kushi Baby et qui demande cette évaluation? Est-ce que c'est le gouvernement du Rajasthan?
I would like to get this translated in English if possible from your side.
Ce que je vous propose, on va régler les petits problèmes de liaison avec Udaipur et j'espère qu'on va vous retrouver correctement d'ici quelques minutes pour parler de cette évaluation de Cushy Baby. Yvette, j'ai envie de vous poser les mêmes questions sur des projets comme Yeda ou d'autres projets. Aujourd'hui, finalement, qui demande à évaluer? Est-ce que ce sont principalement les gouvernements, principalement les bailleurs de fonds ou des organismes mondiaux type
world
OMS
organizations
qui
like
demandent
the Health World Organization? Who's asking for this? Answer. Well, it all depends because it can change from one project to another. But for us as project developers, assessment is really an essential phase because it is essential for the certification and the quality of our project. So we have a specific department or division where we have an assessment of all the projects we propose. But we also have donors who are asking for the assessment. It's very important for donors to have an assessment of the project. Of course. Who? Can you give us an example? Yes, I'll give you an example. The Bill and Melinda Gates Foundation, for instance, have asked for an assessment. They're very much involved in the research field or sector for our projects. And we are also in contact with the academic environment. They're also very much involved in the academic world and environment, so we work with them, and they need the assessment. Now, what about the Swiss government? Because the Swiss government, I think, is funding most of your projects. Are they asking for a specific audit? Yes. The International Development Department of Switzerland is one of our major donors, and therefore, yes, they're asking for this kind of assessment. Now, one of the main questions or issues we have here is that now, how can you assess a project? Because there can be very many different ways of looking into a project. Do you think that a donor like Bill and Melinda Gates, the foundation of Bill and Melinda Gates, is going to have the same approach or not? No, I think that we are very independent. Well, and there isn't any conflict of interest when we ask someone to fund our project and when we have to assess the project. So I don't think that there is a great difference between the different people who are appreciating the project. The differences appear in terms of impact of the project and also the capacity of our teams to respond to the needs in the field. And as we've said with Philippe Lepere, we need financial and economic audits and assessments, and this is one of our weaknesses, I think, because we don't have enough assessment in this field. But I would say that we also have to look at the people, at the end users, the people who really benefit from the project. This is the most important part, I think, of what we're doing. It's very important for us to collect the data and see if people accept what we're doing, if we're really compliant with what we do. You've been saying something concerning the relationships with the Gates Foundation, and you've said, well, we have a rather positive and good relationship. Now, do you think the donor is the person who can really, most relevant person who is going to work with you? Don't you think that there are biases also among the donors, especially when you work hand in hand with a donor or with a government or with an entity, whatever? Answer. Well, I think that the research protocol is set up with the academic world or environment, and then the criteria are defined with the research people, with universities and so on, but not with the donors. And there's no interest conflict, because what's really interesting is what we do in the field. No, I'm not speaking only of interest conflict of interest, but I don't know. I would like to ask Mathilde how she feels about this, because but first, says Yvette, I would like to insist on the fact that what is interesting when we have this kind of assessment, operational assessment, that is to say, who is going to be benefiting from what we do? Is it, and I think it's the government who's going to use the results to take or to make political decisions, you see. I think that would be
Anis, en tant qu'universitaire, j'aimerais bien connaître votre opinion là-dessus. Est-ce que l'université est le mieux placé pour faire une intervention, parce qu'a priori vous êtes neutre, vous êtes censé être neutre. Est-ce qu'on peut faire une intervention, placer des critères d'évaluation des travailleurs de fond, un gouvernement et des personnes très impliquées
with God donors and other people?
I think it is interesting questions. As we know that in university we learn a lot about the scientific foundation of any implementation. For example, there are more than 100 theories on information systems. We can evaluate whether from the usability perspective of the users, and also whether the impact financially, or whether feasibility of any innovation to be applied in other settings, and also to evaluate from the efficiency or efficacy. So there are several perspectives, and there are many experts. One expert, for example, on digital health economic evaluation probably are not strong compared to those from the usability perspective. So I think from this aspect, we need also to learn that universities expert, even though they have many foundation scientifically and also theories, they have a different perspective. But for the implementation, the statement of conflict of interest are very important. Sometimes universities are also involved on the design of any intervention by the government. So if this is the case, so I think, for example, for the evaluation, should not be the same universities to conduct the design and then evaluate as well the intervention. So I think when Yvette mentioned about the conflict of interest is also very important. And also sometimes at the government, they have also the research units. So research unit at the government also need to provide conflict of interest during the research. So currently there are many approach on how to get independent research for any interventions, and also increasingly right now the coming of data. For example, when people using the mHealth apps, the data are coming every day, either from the review of the users or the data collected. It is also another sources of evaluations. So combining all are also very important, and also from the perspective of the university, it is also important to introduce the concept to the research team, also students, because students are also everywhere to need this kind of intervention for evaluation, for research, and also for studies. So collaboration with the universities are also very important. The statement of interest also important, and also the how independencies of the universities during any research.
Mathilde, vous vouliez réagir sur cette question qui est fondamentale finalement.
Mathilde, you wanted to react on that. So who assess who's better placed? What are the criteria? And as Annie said, there are as many experts and point of views as topics. A political leader is not going to have the same point of view as a scientist. A healthcare professional is not going to have the same point of view as an NGO leader. So you try to coordinate players, right? Can we have a common framework?
Yes. So I mean, I think without risking not getting any funding in the future, but I 100% do think that there's a lot of issues in the funding landscape, and there's a lot of political motivations behind funding, right? I mean, I don't think we should stick that under the table. But I do think that, and the way to overcome that, I would say, would be to empower communities to really make more decisions of where funding is going, and the way to do that is by creating more political demand on from the bottom up, from people, from society, to really demand that their issues are being addressed, when it comes to health. And I do think that, you know, the only way we can do that is by creating, you know, a kind of a movement among, you know, the general public to say, you know, health is really important, these aspects of health are really important, digital enablement is really important because of this and that. And so I think this is really what we need to invest in. Then I think when it comes to the way that we fund digital health, this is another really important thing, and this is something that we're also pushing, that we're hoping to push through the conceptual framework that we are developing and this investment case that I was speaking about. You know, we do need to establish new kind of parameters of how funding is pushed, distributed. And so with that, I think we need to have, you know, we need to look at existing modalities of funding and are there, you know, ways that we can coordinate funding better, but also ensure that there's democratization around funding, you know, so that, you know, it's not coming from a few countries of the global north, but really that the decision of how the funding is being distributed is taken at every level, including in LMICs, you know. I think that's very important.
Anis, j'aimerais bien que justement que l'on revienne sur ce que nous dit Mathilde, aussi qui est fondamental pour qu'un projet finalement puisse émerger, passer à l'échelle, se développer. Il nous faut à un moment une utilisation massive. Pour avoir des utilisateurs, il faut que les gens s'y retrouvent derrière. C'est l'un des paradoxes souvent de l'évaluation, c'est qu'on oublie de demander leur opinion aux premiers utilisateurs, on oublie de les impliquer dans l'évaluation du projet. Un marché privé, on parlerait de l'expérience client, quelle est l'expérience client, l'évaluation par le client. En santé, on parle de patient et moins de clients, et on lui demande souvent moins son avis. Est-ce que les choses sont en train de changer sur ce point-là, à votre avis?
Yeah, I think the issue about the evaluation from the perspective of the users and also the evaluation from the perspective of either the implementers or either implementation from developed countries to be applied in other countries. So I think there will be some consideration or discussion. I think what we heard before, any implementation should start from the condition. What are the problems in the real settings? So the problem in the real setting will be felt by the real users. Either the users are clients, are patients, either the users are carer, nurse, midwives, or doctors, either the users are those on managing health system. The setting are sometimes is very different from one to another. Many examples in Indonesia, for example, a digital health innovation applied in Java in urban area, it is not easier to be implemented in rural area, especially in the remote one. And second one is also important about the technologies. Technologies in the developed countries sometimes is very different to other countries. It is also related to the maturity of the infrastructures. And the third thing is also very important is the value proposition. Whether the value propositions, either from the providers, from the perspective of the economics, from the perspective of the results on the health, for example, the impact on the community, it is also sometimes also different. I think this kind of identification, assessment from the beginning are very important. Before then, we discuss about more general and also wider aspect from the perspective of organization, regulation, and also health system. There are also another issues, but from the small scope as well, I think we need to start for identification about any implication of any digital innovation to be applied in other settings.
Ouais, embarquer tout le monde, les patients, les soignants aussi dans cette évaluation, ce qui n'est pas toujours si naturel dans les organismes de santé qu'on soit au sud comme au nord. Là-dessus, personne n'a de leçon à donner à quelqu'un d'autre. Je me tourne à nouveau vers le Rajasthan, vers Udaipur, puisque je vois qu'il nous écoute toujours. Udaipur, can you hear us well this time? And who is listening to us in Udaipur today?
Hello. Hello.
Hello. Can you hear us? And who is listening today in Udaipur?
Yeah. I am Ajay Sharma, co-director of Khushi Baby. I am talking on behalf of Jitendra Kumar Soni, IAS Mission Director, Government of Rajasthan.
We are so glad to hear you today here in Toulouse. We're talking about evaluation. So could you tell us more about the evaluation of Khushi Baby? Who tries to evaluate it?
Yeah.
The government, the NGO, the donors? How do you manage your evaluation?
Yeah, actually, it depends on project to project which we carry out. In some cases, the evaluations are conducted by the third parties. For example, recently we had an evaluation of a global project that was conducted by an external party. So for the government, in the case of government, we ourselves provide the evaluation for the project. For example, we provide entire analytics for the project which we undertake in the state of Rajasthan to provide them insight on the project, what is going on and what is happening actually. So it depends on project to project. In some cases, the internal evaluation goes on, and in some cases, the external evaluation goes on.
What is the most important for you in evaluation? I mean, is it a political evaluation? How many people did you reach? How many families? Or is it more an economical evaluation?
Actually, for us, it is both kind of evaluation are important for government to understand the scenario. For example, qualitative. In the case of qualitative, we can say the government would like to know what is the scale of the project and where the impact is going on. In that case, the qualitative evaluation is important. To understand in depth, we also think the qualitative evaluation is also important. To understand any study in depth, the qualitative evaluation is very important.
I know that something else is very important for you. You like to empower the people in the project and in the evaluation. And you often say that the main people that evaluate your project every day are the patients, the family, and the health workers. How do you do to empower all those people in the evaluation, in the design of the project too?
So while designing a project, actually to empower, especially when we talk about the health workers, we generally, after having an evaluation of an ongoing project, we just come up to the challenges what we have faced in terms of scaling up of a project, for the adaptability issue first, and then to scale up. So we try to understand what challenges are coming up with the existing health workers to get the adaptation of the digital health platform while switching from traditional paper mode to digital media. So having a, you can say, the qualitative and quantitative evaluation helps us to understand the challenges they are facing to get the scale up. For the policy level, our evaluation makes some help to understand where the challenges are and what challenges, how we can cope up with those challenges, basically.
When we talk about evaluation, there is also a main question about it. Who pays for the evaluation? Is that the government that pays for Khushi Baby? Do you pay on your own funds for evaluation? And did you have a budget for evaluations at the beginning of the project? How did you manage it?
Yeah, when we talk about the budget related to any project, so as we should say that we are technical support partner of government, and we are committed to provide free of charge services to government. It's our duty to provide evaluation from our side to government to show the impact of the project and to enable government to scale up at the larger area after having a small study. So it's become our responsibility while having the evaluation. So in terms of fund, we have to generate fund from by our own from whatever sources we have for funding.
Thank you so much for those explanations and for being with us today live from India, from Udaipur. It's a great, great pleasure to have you live from India today in this conference. Please stay with us a few minutes. Yvette, je vais vous poser la même question, l'évaluation, il faut aussi dire les choses. Un coût aujourd'hui qui paye, qui doit payer, ce coût-il pris en charge dès l'amont du projet ou vient-il se rajouter lorsqu'un projet est déjà en cours de développement?
C'est quelque chose qui doit être dans les budgets du projet de tout début.
I think that the assessment should be budgeted from the onset. This is something that we need to take into account because it is important for all stakeholders. Again, we ask our funders to fund the project, but to also fund the subsequent audit. Do they do that from the start? Are they ready to finance? Are they ready to dedicate a share of the project to the assessment? And so, well, some funders do and others don't. Well, some, we understood that. Anis, I'm going to ask the same question. Who should pay for the assessment? Should it be an independent government? Should it be a funder? Should it be an NGO? Should it be a budget from the start?
I agree with Yvette that those who implement should include evaluation as part of the budget. Whoever, either from the government, either from the non-government institution, organization, either from the university, they should put the budget on the proposal during in the beginning. But then, from the perspective of my country, especially Indonesia, some innovation, especially from the local government, district or province, sometimes they do not have similar understanding, especially innovation that also a long-term, several years, and also the budget are also not for 1 year. Sometimes those who taking over the innovation in the next year, they do not know that they should include also the budget for the next term. So I think this is important that we need to have a similar framework about evaluation, because evaluation should start either from usability. Sometimes the prototype already start and then just only small users, but getting more and more, scaling up, widespread. So the evaluation probably in the higher level, in the regional. So I think the communication about budget is especially important for a country where they have a decentralization policy. The innovation starts from the lower level government. So I think it is important to communicate about any evaluation, especially the successful implementation that are aiming to be startup and also in the national level. But also we need also to consider about that not all digital health innovation will be successful. If the innovation are not successful, what else, what we need to do? For example, the evaluation, and then we need also to prepare the exit strategy on how to prepare everything, all investment, and also other impact as well. So I think because sometimes in several countries, any innovation and then ended by what? Someone going to the jail. Someone going to the jail because of the innovation are not part of that. So I think I'm very, we need to call that evaluation should be part of the beginning, and then all leaders should know about that, and also all implementers should also involve about the evaluation. And also the coming of, for example, from the research perspective, participatory action research or implementation research is also very important. Many studies, especially in Indonesia, about digital health innovation, we have just started the review about last week. We know that the call of, for example, this implementation research is very important, especially the situation of pandemic. It is not possible to have, for example, case control study or any intervention study. So, I think.
Merci Anis de nous rappeler effectivement que l'évaluation doit être dès le départ du projet.
Yes, I think I agree. I think it has to start at the very start of the project. And I think that you're opening up another window, another issue, because you've said we have to be prepared at the very start of the project, but we also have to assess the failure, the possible failure of a project, because sometimes there might be a financial impact, human impact of a project which can fail, and also an impact with respect to the healthcare. And I would like to thank you, the three speakers we have here, but also our friend in Rajasthan. And I think that we could maybe take advantage of the very last minutes we have for this session to see if there are questions in the audience concerning the assessment criteria, the capacity of understanding what's going on in the field with the teams, and what about the design of the project and also the funding problem. We have our friends from India here in live, and we can ask questions to them. So there's a mic here for the audience, but just before we ask these questions, we have reactions here from our internauts. I'm going to Aguillou, from a distance, thanks the team of the PIAFAP Foundation. He's in the Bamako University, and he has been, and Mariama from Guinea, thanks us for all the information we have just provided him with. Radzak, who says that the sustainability of the e-health process is a real challenge in southern countries, especially when we know that very little money is usually allotted by the government to this project. There are other questions we can cover, but I think that we also have questions from Thailand, in Bangkok, Dr. Bunjai. Now, Dr. Bunjai, I would like to know, how do you feel about this first session we've had this morning and concerning the assessment of these projects?
Hello, can you hear me?
Yes, that's great.
Okay. Congratulations for the first panel. There is quite a technology grid, and then we cannot listen to the conference throughout the period of the discussion. But in terms of the evaluation, I have some kind of I have some comments on about the evaluate or assessment. It seems like what we discuss is more on the innovation, like the application. How well I think the foundation that has been really difficult to evaluate within 1 year. For instance, if we would like to have the interoperabilities, building the standard and also gather people to understand the importance and also adopt the standard, it takes time. So maybe we can evaluate the success of the program by how well they adopt or they comply to the standard, which is be able to scaling up the projects. The evaluation of economics and also the number of the impact is also important. So another point for the investment is that is it possible that the donor to not just evaluate the application, innovation, or the system, but also invest it in the foundation, like our friend from the Transform Health and from Ahin Anis, talking about the foundation, like the governance and the leadership, how the projects contributed to building the leadership and the collaboration between stakeholders in the country to be impact to the long run of the e-health, transforming e-health in the country. Thank you.
Merci, Dr. Bunjai. J'ai envie de rebondir sur
I would like to pick up on what you've just said with Anis, because Anis is here. And what about Professor Bunjai has said that evaluation requires time. It's time-consuming because you have very many people involved in a project, and therefore, isn't this a problem because we have a fast-running environment when you are in the digital environment? Everything goes so fast. So how can we do that? I mean, how can we evaluate? Because we are in numbers, but we need time, don't we?
Thank you, Dr. Bunjai. I think when we discuss about evaluation, sometimes we also mention about short-term evaluation that should also come soon after any innovation or any implementation. Sometimes the result will be appeared after several times, midterm evaluation and also long-term evaluation. But I agree with you that we need to put the importance of evaluation for any implementers. And the call of Dr. Bunchai about investment, I think this is the question to Matilda, I think. But I agree with you, and also part of IHIN, we agree with you about the importance of evaluations. And also I agree with you that sometimes the digital health innovation, not the technologies, for example, the standard. I think the essence is also how to bring people awareness. Because implementing the interoperability, implementing the standard, it also takes long. And sometimes regulation should be there. So if we just calculate it from the adoption of technologies, probably easier compared to others. But then for this aspect, the soft part of technologies, it is rather difficult. So it is the time that socio-technical approach for any evaluation is very important, not only from the technological aspect, but also socio-perspective aspect is also important.
Des questions depuis cette salle. Allez,
Now, I don't know if we have questions here in the audience.
Vous présenter, s'il vous plaît, quand vous posez la question, puis poser des questions assez courtes, comme ça on va faire circuler le micro parmi notre panel assez rapidement.
Bonjour, et merci pour la parole. Donc, je suis Sébastien, je suis le fondateur de IT for Life. On parle d'évaluation, et d'évaluation notamment financière. Et encore une fois, je pense que quelque chose qu'on oublie, c'est pour pouvoir faire ça, il faut des compétences, et il faut encore une fois des outils. Dans les sièges,
Let's not forget that. And also in the field, of course, not only in the organization. You have to manage the budget, and you need skills for that. And we are more technical when we speak of assessing these projects from a technical, financial point of view. We are looking for skills for that. We need new profiles, and if not, we will never be able to do that if we don't have more investments. I think that private companies are dedicating up to 10% of their overall budget for digital tools and developments, and we sometimes less than 1 and sometimes less than 0.5%. So we can't continue like that. We really have to react, and I think that we have to allot more budget to that. We need experts, we have to train people, we need more technicians, and I think that Terre des Hommes is a very good reference for us, because I think that the budget that you have been devoting to the IEDA project is probably not the one that you have been devoting more recently, because you have to find skills. And you said yourself that you have to discuss with the Gates Foundation and make sure that you find the appropriate profiles. But that's not something you're going to find so easily. You're going to have to pay for that. And for that, you need money, of course. Thank you.
Yvette, justement, ouais, c'est
imaginable aujourd'hui dans un projet. You think that in a project today, I'm going to dedicate 5 or 10% of my overall budget?
Ça marche normalement, ouais.
Tout à fait d'accord.
Yes, I completely agree with what you've said. I'm completely in line. And I think that we should not forget the way we do this, because Terre des Hommes, what we do, we have a partnership with the academic environment, universities. It's not something that we have done on our own, okay? And the positive aspect is that we have external audits or evaluations. For instance, when we have a conflict of interest, what we have to try to do, how can an outside auditor will be able to do the evaluation? New university, for instance. This is a funding which is part of the project. You always have to embed this in the project. I agree. Joy.
Thank you.
Yes, it works.
Yes.
Just wanted to comment one. Usually it is said that if you cannot measure, you cannot manage. And any programs, like if we have these parameters defined typically in the beginning as a baseline, then it is easy to assess or evaluate. Usually many of them don't do. But I have one particular program that one of the first e-health program, multi-country program that was in Asia, that is Panacea, supported by IDRC Canada, where we had this formative evaluation in the development phase. And then at the end of the project, we also had this summative evaluation. But it was very structured. So any comments on that, like whether such evaluation efforts work?
And then how do we actually define the success? Because it's very important to define those. If you do not define what is a success, then it's going to be difficult to actually evaluate. Thank you very much.
D'autres... Voilà, Madame.
Yeah, more questions here in the audience. Madam, you have the floor. Valériane Leroy. I'm working at the INSERM Institute in the field of research. Thank you very much for organizing this meeting. It's a great pleasure for me to see that we are really improving from one year to another in the organization of the e-health program. Now, I have a question concerning the assessment or evaluation. I think that it's really important to start with upstream, but also you need money for that. You need partnerships like universities or independent entities. I think this is really essential. It has been said, but I think it's also important to have not only an operational evaluation, and that you have to try to understand if the project is going to be successful and why it's going to be successful. If it's not successful, why it's failed. I think that's important not only for the people who are implementing the project, but also for the funders, for the donors, and it's important also for the governments because they have to be involved in a project. And it's also, as you said, time-consuming. We need more time. We have tried to understand what the whole process is all about and how we can have a sustainable project. Very often the donors, the funders are looking into the expenses we have, and very often we have to stop the project because they don't want to fund anymore. So we have to go beyond these limits, and I think that everybody can understand this. Thank you. I think that we have different approaches, of course, when it comes to evaluating or assessing a project. Now, do we have other questions here in the audience? Yes, I think there's one here just in front.
Gildas Ediblet,
I'm in a project manager, and we're working with the EAD project in some countries. My question relates to the funding of the evaluation of the assessment, who should be normally upstream. It should be included at the very start in the project. Okay? Now, if we're speaking of a research protocol which has not been completely prepared and you already have the funding, you see, when I speak of a research protocol which will develop afterwards and which will have to take into account different aspects, my question would be, how are we going to adjust and adapt the budget afterwards once you have started developing the project? So shouldn't we have some flexibility so as to be able to discuss with the funders, the donors, as to adapt the budget? Now, who is going to do that? Because when you are in research, I mean, things develop and after the funding. Yvette, maybe could you say a few words about this and react? Oh, it's a bit complicated because if you start with a research project which is going to evolve and change, well, you're always going to have to find new funders so as to cover the costs. I know that's not so easy, so that means that you have to be flexible and agile. Now, I think the adjustment is one of the mechanisms you need, because if you have a first investment when it concerns the implementation of the project in the field, you have to continue developing the project. You're not going to stop research either because of that, you see. So it's complex.
Mathilde, vous vouliez compléter?
Mathilde, maybe you would like to say something.
I'm not a researcher or an evaluator, but I just want to share that I think similarly to the approach we are taking to investment in looking at better coordinated and increased investment for digital health, I also think that we need to look at ways to evaluate in a more coordinated manner. And so I think, for example, you know, when we are evaluating, like Jai said, much longer term impact when it comes to digital health transformation, for example, we need to look at those changes over a much larger period of time. At the moment, the issue is that we are evaluating everything on a very project basis, and this is causing the pilotitis that we're currently seeing. So I think both in funding and in evaluation, we really need to look at these longer term kind of investments as well as the way that we measure the success.
Rassembler les contraires, à la fois
yes, bring together flexibility, of course, and be able to adapt the evaluation, but also be able to work work on very long periods. Now, more comments? You have a comment? Yes, good morning. My name is Delphine. I'm a senior partnership in the Mali project. I would like to ask a question concerning randomized studies. I would like to know how you can convince governments or the private sector and the academic environment to invest in some of these projects. It's not enough to have monitoring and evaluation as we traditionally do. For instance, with DMAGI, where we are developing healthcare products. We are a huge platform. We've been operational for more than 20 years now. We have a massive rollout of our products in India, and we have only one RCT. So how can we convince people so as to make sure that we will get more funding? Because that's the real problem. I think that's really crucial. That's the hotspot. Maybe Anis, could you react concerning randomized
studies? It is interesting, and also it's also difficult to answer because the RCTs for any digital health innovations, it is also different from the context. We had in our setting mobile health innovation for patients with tuberculosis, but for RCT we start with to select randomize a patient with TB coming to the hospitals, but then we need also to develop the protocol on how to select someone to choose the mobile applications, and the other one with the mobile application but not with not a specific apps, for example. So developing this kind of RCTs, I think we could start from the good clinical practice. Sometime in the regularly setting in university, we teach students and university about how to conduct a good clinical research practice, and also RCTs are also part of that. And based on that concept and principle, and then we apply how the mobile health innovation could be part of the RCTs. But then the question about the numbers, about the money, for example, it also depends on how much impact that we need to be received from the implementation. Because later on we discuss about how many samples that we need to be involved in the settings. And also, if we would like to have, for example, multi-center studies, more hospitals to join, that also will be implicating the budget as well.
On avait le professeur docteur Boonjai qui nous suivait tout à l'heure à Bangkok.
Alors,
il y a plusieurs
Boonjai in Bangkok, but we also have other campuses connected with our observatory. And let's go now
l'heure est déjà avancée, la journée est déjà bien avancée aujourd'hui. Je propose de partir sur deux continents où la journée est moins avancée, qui se préparent à nous suivre, notamment cet après-midi. On va partir à Dakar, retrouver tout de suite normalement Michel Namar qui est sur le campus de Dakar. Bonjour Michel, quelle heure est-il à Dakar? Est-ce que les personnes commencent à arriver petit à petit sur le campus?
Allô, oui, bonjour.
Yeah, hello.
On vous entend. Alors, c'est pas Michel Namar. Qu'est-ce qui nous reçoit aujourd'hui à Dakar?
Who's there in Dakar?
C'est Madame Den Aminata, responsable du campus
numérique. Aminata, I'm in charge of the digital campus
here in Dakar. Qui est-ce qui va venir aujourd'hui assister à cette journée depuis le campus de Dakar? Est-ce que ce sont des étudiants, plutôt des soignants? Qui est-ce qui se prépare à venir?
Il y a le doyen honoraire.
The dean will be here, Professor San.
Voilà, je vous laisse.
And he's going to take over from me.
Bonjour.
Good morning.
Bonjour.
Hello.
Bonjour.
Hello, everybody.
Est-ce qu'aujourd'hui, alors qui est-ce qui se prépare à venir tout à l'heure à Dakar assister à cette conférence de l'Observatoire d'e-santé dans les pays du Sud?
Alors, c'est vrai que je viens, personnellement, je suis le doyen honoraire de la faculté de médecine.
I'm the dean of the pharmacology and medicine school. There are other colleagues who will join this afternoon. For the time time being, they have not arrived. We feel very privileged to take part to this event because we're very interested in e-health. You know that in Dakar we have a number of digital projects. We have projects with a number of partners, public and private stakeholders. And of course, we're very interested in any learnings. I think that e-health, there are projects around the world, and I suppose that there are interesting learnings for us in matters of, again, success criteria, but also the different types of projects that exist around the world.
En tout cas, écoutez, Monsieur le Doyen, ça nous fait chaud au cœur de voir que le campus de Dakar se connecte aujourd'hui, comme chaque année d'ailleurs, à chaque édition, à cette conférence de l'Observatoire de la santé dans les pays du Sud. Merci d'être avec nous. Je sais que vous allez écouter avec beaucoup d'attention ce qui va se dire cet après-midi. C'est donc la fin de cette première partie, la conférence 2022 de l'Observatoire de la santé dans les pays du Sud. On va à présent marquer une petite pause et on se retrouvera tout à l'heure à 14h30 heure de Paris, 12h30 temps universel. À tout à l'heure à tous. c'est pas la peine. Ok. Je vais vous inviter tous à venir vous asseoir parce qu'on va essayer de débuter à l'heure. D'abord pour tenter de finir à l'heure, c'est toujours une bonne chose. Et puis parce qu'on a des invités au niveau international qui ont des obligations, donc qui eux sont prêts à débuter à l'heure et qu'on ne pourra pas retenir outre mesure. Voilà, donc j'invite tout le monde à venir s'asseoir rapidement, s'il vous plaît. Puis on va faire venir, je vais demander à... Je vais demander à Sébastien de venir me rejoindre, comme ça on va gagner un peu de temps. Aristide Afenili Nassimbe, je ne sais pas s'il est là.
So, we're going to ask Jean-Philbert Nengzingma now.
Et on va pouvoir partir en régie dès qu'ils sont prêts. Et pour info, mon oreillette ne marche pas. Donc en régie, c'est pas la peine d'essayer de me joindre. Voilà, maintenant que tout le monde est là, les portes vont se fermer, puis on va pouvoir débuter. Bienvenue à toutes celles et à tous ceux qui nous rejoignent dans cette nouvelle conférence de l'Observatoire de la e-santé dans les pays du Sud. Depuis ce matin, nous nous interrogeons sur les manières d'évaluer les projets de e-santé, comment capitaliser sur l'innovation, ne pas reproduire les mêmes erreurs, apprendre des autres, trouver les facteurs de succès pour un projet, les facteurs qui vont permettre son passage à l'échelle. Et on va à présent poursuivre ces réflexions, si vous voulez bien. Nous attendons sur les facteurs qui font qu'un projet soit pérenne, parce que c'est pas tout de lancer un projet en e-santé, mais comment faire pour qu'il dure véritablement dans le temps, comment faire pour qu'il ne disparaisse pas si ses promoteurs s'en vont ou s'ils n'arrivent pas à passer le relais à d'autres acteurs. Et pour répondre à ces questions, j'ai le plaisir et l'honneur d'avoir autour de cette table aujourd'hui Aristide Afenimdou-Niassimri. Vous êtes alors coordinateur national pour la santé digitale au Togo, c'est-à-dire votre niveau de connaissance du sujet, et en plus, ou avant, j'ai envie de dire, ministre conseiller à la mission permanente du Togo auprès des Nations Unies. Merci beaucoup d'être des nôtres aujourd'hui dans cette journée de la Fondation Pierre Fabre, Observatoire de la santé dans les pays du Sud. Sébastien Cusnier, directeur d'IT for Life à Dakar, une entreprise qui apporte le soutien aux ONG, aux associations, aux entreprises pour les aider dans leur déploiement de leurs outils numériques. Et puis en duplex avec nous depuis Dakar au Bangladesh, si tout se passe bien, Mridoul Chaudhary, qui est directeur de Empower Social Enterprises, qui gère notamment Traumalink au Bangladesh, dont on a parlé ce matin. Bonjour Mridoul, je ne sais pas si vous nous entendez correctement. Quelle heure est-il aujourd'hui à Dakar, si vous êtes bien là?
Yes, I can hear you fine. Right now it's 6:30.
Écoutez, merci beaucoup infiniment d'être avec nous dans cette conférence. Pour des raisons de Covid, il faut le dire, malheureusement, vous n'avez pas pu venir jusqu'ici et assister en présentiel à Toulouse. Mais heureusement, la technique depuis ce matin nous fait des miracles. Deux autres invités en duplex avec nous cet après-midi, le docteur Sharma, qui est en Inde. Merci Mridoul. Oui, je disais le docteur Sharma, qu'on va découvrir également à l'image, qui est directeur de l'autorité nationale de santé en Inde. Merci infiniment d'être des nôtres aujourd'hui, docteur, depuis New Delhi, où vous êtes en direct. Vous avez notamment beaucoup travaillé sur la digitalisation des outils et processus de santé de manière générale en Inde. Et donc votre éclairage sera précieux tout au long de cette table ronde. Enfin, à l'autre bout du monde, voyez pas un continent, un autre, cette fois-ci on part aux États-Unis, à Washington, rejoindre Jean-Philbert Nsingamana. Bonjour, si vous entendez correctement Jean-Philbert Nsingamana. Vous êtes originaire du Rwanda, parcourez la planète entière, vous êtes à Washington aujourd'hui. Au Rwanda, vous avez été ministre de la Jeunesse et des TIC, et vous avez été également directeur général de la fondation, cette fois-ci plus globale, qui s'appelle Common Project. C'est une fondation qui travaille à l'amélioration de la vie des citoyens du monde et à leur lien avec leurs données personnelles. Et vous nous expliquerez notamment comment cette fondation a travaillé avec certains pays sur les passes sanitaires individuelles durant la pandémie de Covid et au-delà de ce rôle, vous êtes aujourd'hui consultant indépendant. Je me tourne tout d'abord peut-être vers Sébastien Cusnier. Sébastien, un petit mot peut-être en premier lieu sur la société que vous avez créée, IT for Life, parce que c'est aussi un éclairage quelque part sur notre question, cette histoire de société.
Déjà un grand merci pour l'invitation, un grand merci de la Fondation pour l'événement.
Foundation for organizing this meeting, which I think is very appropriate.
And on a créé IT for Life justement pour répondre à ces questions de pérennité.
IT for Life, what we want to do is to have sustainable perennial projects, especially bringing together skills and people who have these technical skills, so as to support some of our organizations which need this support. Now, so you have been working with NGOs, and you've noticed that they don't always have the tools they need. They don't always have someone who can help them, for instance, for the design or for the technologies. Answer: yes, this is true. Fair enough. But today we have very many different jobs, if I can say so. 10 years ago, you needed someone to manage the infrastructures and the different operational systems. Today, we need people who's going to do the evaluation, other people in charge of collecting data, other people in charge of security, technology and data science. So you see, all this is new. It means many different profiles. We don't find so easily those skills. It's very costly, and therefore we're trying to work with private companies, but it's not so easy to find all these people, you know, because they're very often willing to work with private companies, and even though they come and work with us, they don't stay long. So we have to try to find a stable team. And this is why we're going to be speaking of a paradox, says Leonard, because since we started this morning, we know that the projects today are becoming all digital projects. We've had a real ramp-up of digitalization with very many investments and funding of e-health, but this means that we need skills, profiles that you can't find so easily, that you have to go and look for outside, and which are costly too. And there is a new culture, a new digital culture that you have to try to acquire. And it's not always the case for NGOs. Yes, I agree with you. The private companies have what we call consultants or other companies supporting them. And they're also trying to train the people they have in technologies, and this to bring together all the skills they need. Now, what you've said is very interesting, but challenging too, because you've been trying to list all the skills that we need. You need people for each one of the skills, of course, in all these communication systems. And in the NGOs, I think people are not always so aware of how technical this is, and sometimes they want free software, simple softwares. What do you think? Yes, answer. I think that there's another layer of complexity because we are in a very fast evolving context. So that means that today we are more demanding in some fields. We weren't so demanding a few years ago, and today we need more experts, people who have other expectations too, and at all levels. So either for recruitment, either for the salary. So you have to be able to keep up with all these demands. Another question. Now, how do the donors or the funders react when they're confronted to this increasing complexity of e-health? Are they imposing specific specifications or not, or are they aware of the complexity? Answer. We have two levels. I think that there is the Anglo-Saxon environment world, I think, where people really know that they have to invest, and in our French-speaking countries, and in France, where we have to explain to the organizations that they have to start evaluating, assessing, because we have numbers, but we don't always have the funds. And donors and funders who ask for the evaluation don't always provide these NGOs with the money they need, because they don't stick to or match with the profile these donors are expecting. So that's a real issue, you know. No, another question. So there are no norms which are imposed? Answer, no norms, and I would say that we need more norms, especially when it comes to funding. I agree. And I think that we have today professions which have nothing to do with what we need. Now, Mr. Minister, I would like to know if you share this view, that is to say, we have complex professions, jobs, and sometimes it means more organization. It's not always easy for some of our NGOs or associations. Answer. Well, thank you very much. I would like to start by expressing my gratitude to the organizers, because it's a great honor for me to be here with you in the e-health conference and see you here all, because it's really challenging. So thank you. And I think that, so as to answer, we have the same issues in Togo, where you have very many associations, NGOs trying to develop skills in specific fields. And this is why we started establishing a synergy. We wanted to create a synergy, coordination, because people want to make more achievements, but we don't have the skills for that sometimes. So this is why we try to bring together all these skills, to have a pool of people and also train people, because I think training is really essential, because we're speaking of an innovative field, and therefore the experience we've had up to now clearly shows that when we started with the telemedicine network in Africa, has not always been easy. I think that some people in the field have not always complied with what we tried to do, and therefore when we started with the authorities, the governments were not convinced, so we have to start convincing the government, because they were not aware of the importance of having tools and technologies, and progressively this has been changing. The authorities, government have understood more clearly that we have to get back to the essentials, that is to say the tools, but I'll go into the details when we speak about this. Now, if we look into what is going on, everybody is speaking of telemedicine, of e-health, but it's communication. It's more centered on communication and not so much on skills. So we have been asking for the support of international consultants who are still working with you. We have very many organizations and associations in our country which are trying to develop their own skills, because they know that this is a new opportunity. They can't miss this opportunity. But it's not only the fact that communication. Now, do you agree with what has been said this morning by Florence Perkins and also what Sébastien has told us? That is to say that there is a breach between the English-speaking African countries and the French-speaking countries of Africa, maybe because the GAFA and the players, the major players of technologies are more present in the English-speaking countries, but in French-speaking countries in Africa, it's not the case. Okay, well, I can tell you that this is an issue, but it's not only in the field of e-health. And I'm in Geneva. I've been in Geneva for more than 8 years, and I've been a doctor, a physician in my own country. And when we get together, when we meet, we really notice that there is a gap, there is a breach between the English-speaking and the French-speaking countries. Even when they want to take the floor, it's difficult for them. So this is why we have to ask ourselves, what's going on here? And there are associations which have started to get organized and who have started to produce documents and share this with English-speaking countries. And when they come to the meetings, the questions they pose are very appropriate when it concerns the implementation of the programs. But having said this, these meetings don't take place very often to start with, and when we have to coordinate things, we can't, because we have very diversified views and approaches, so it's not easy, and therefore many issues crop up. Is it due to the language barrier, or is it because we have different cultures, you see? Well, I would like to ask someone else in another country who is an English-speaking, non-English-speaking country, in India, Dr. Sharma. You are in charge of the National Health Authority Government of India. It's a great pleasure for us to have you here. You're in New Delhi. Dr. Sharma, I would like to ask you, because you've been working for a long time now in the e-health in India, do you agree with what we've just said at the beginning of this roundtable session? That is to say that digitalization requires many specialized skills, which is not always the case in many companies.
Well, first of all, thank you very much for inviting me to this conference. It's really a privilege and pleasure to be here with you. And I've been hearing with interest the views of the panelists here. I think there is certainly an issue on the expertise available in various domains. But let me say that it's not really so much a question of expertise, but it's also a question of architecture. How do you architect the programs, or how do you bring together all the pieces of digital health is an extremely important issue. We have to think of this whole subject in a cohesive and comprehensive manner. For example, in India, we have started the National Digital Health Mission, which essentially means that we are making building blocks of an interoperable, structure, whereby the patient's health records are being maintained we are creating a health identity for each person, because we already have a digital identity called Aadhaar in India, of 1.3 billion people. So that's what we are doing, and we are creating registries, health professionals registry, health facilities registry, drug registry. And then we are having a situation where a person will be able to share his or her health record with doctor, with other institutions, with the insurers, for example. So I think, and of course, again, we are having an interoperable teleconsultation system, which means that you don't have, both the doctor and patient do not have to be on the same application. They can be on different applications. So in my view, what is important is actually to create an architecture which is interoperable, which is scalable, which actually takes into account the diversity, which is inclusive, which actually doesn't differentiate between the people who are digitally literate and people who are not digitally so literate. And that, I think, is what is required. And we in India, having built a number of large systems, like, for example, in the COVID period, we built what is called CoWIN, which is essentially a software or a platform which recorded the vaccinations of our people. And on this platform, we have recorded as much as 1.98 billion vaccination doses, and each dose is recorded. Each person can download his or her certificate of vaccination, and each person is basically reminded as to when his next dose is due. And we have already vaccinated about 80% of our population, which is, again, you will agree, is very large population of 1.3 billion people. So that, I think, we need to create an architecture, and having clarity in that architecture, I think you can always find people with requisite expertise and skills in the market. I agree with you that some of these skills are difficult to find, but then once you have this architecture, it is possible to basically scale up your programs. So I would advise, my advice will be that please ensure that you create something which is open source based, which is based on open standards, which is based on open APIs, and which actually is as inclusive, and a system which is able to capture the diversity of every country. In India, you have 26 languages, in a country, and you have hundreds of these dialects, and we are able to sort of cater to everybody. That itself is a big challenge, but I think that challenge can be met with open systems.
Docteur, lorsque aujourd'hui des ONG ou des entreprises viennent vous présenter un projet, ou présentent officiellement un projet aux autorités ou au gouvernement, quels sont les 4 ou 5 maximum points clés que vous allez regarder et vous dire d'un point de vue gouvernemental, ok, là je pense que ce projet va réussir.
And say that, well, that project may be a success if we meet all these requirements.
Well, one is that when you talk of digital health or e-health, it is not that the companies are going to submit projects. It is the government or it is the public systems who are going to prescribe what that project will consist of. And the companies are given what is called a clear mandate, a clear task, a clear job, which they have to perform. So that's number one. Number two, what we have to see is that the companies deploy appropriate resources to fulfill those tasks. It is not as if, they are coming and telling us what we have to do. We are going and telling them, this is what I require. And therefore, I also agree that there is an internal capacity which has to be there in the government systems, which means that we also have to know as to what we want. Otherwise, what will happen is that these companies will come and they will, drive the whole agenda rather than we driving the agenda. So while we can outsource many things, we cannot outsource thinking, the strategy. And that, I think, must remain within our control. And then after we have clearly defined what we want, thereafter the companies have to deploy resources with the appropriate skill sets, and then they have to do a particular job in a particular time, which means it has to be an outcome-based payment, which means that when you do this job, I'll pay you this much amount. When you do another job, I'll pay you this much amount. So that way, you are tying up the payments to the companies on the basis of what they perform and how they perform. Right. And I think that's the right way to go about contracting the jobs to various companies.
Effectivement, comme vous le dites, avoir des objectifs,
As you have very
clearly
said, we need common and shared goals.
Toute dernière question,
and a very
Dr.
last question, Dr. Sharma, because I know that you are very busy, and thank you for answering. Sébastien Cusinier just said that it was sometimes difficult for NGOs to find the appropriate expertise. They don't always have it themselves because they don't always know enough about the design and the architecture of information systems. Now, what about the public sectors? What about the governments? Do you think that this expertise can be found in the public services? Do you think you're acquiring this expertise? Do you think that this changed your approach when it comes to examining some of these e-files?
Is this question for me?
Oui, s'il vous plaît.
Yes, the question is for you, Dr.
Puisque vous représentez ici une institution, voilà, une institution.
I hope you understood the question.
Une institution publique, justement, c'est intéressant de savoir si les institutions publiques se structurent elles aussi pour changer de culture et changer de compétences en la matière.
Okay? Question is for you.
Yes, I think what is required is, you know, we have two kinds of systems in the public authority. One is the typical civil servants who may not be really experts in technology, but then we also hire people from the market and basically make them a part of our system and structure, which means then they work for us, they work like us, and they are the ones who are basically becoming an interface between the civil servants and the companies to whom we, give the work. I also want to share with you very, very important information that whatever system India has built, they are all very, very open systems. So, for example, those systems and architecture are available for free to any country. They are what we call digital public goods. We have made them as a digital public infrastructure. For example, the vaccination platform, which we have created called CoWIN, is available in open source, free of cost to any country which wants to use it. Our Prime Minister, actually, we had a conclave last year in July, and large number of countries, even from Africa and Europe, they participated. And there we said that we will make this whole project open source and also offer it as a gift to any country who wants to deploy that project. And because our projects are in open source, they don't cost anything. They just have to be configured and deployed. And I think that's the way to go about it. We believe in creating digital public goods, which means that anybody can use them and any country can use them, and they are open systems. But to the specific part of the question, I would say yes, there is a need for internal capacity building of the government, because we have learned the hard way that you cannot leave everything to the consultants. You cannot leave everything to the companies, private companies. They will not really you will not be able to control them, so to say. And therefore you need to hire people from the market. And I agree that it's a difficult market at this point in time, especially after COVID. People, it's difficult to find expertise, but I think you need to hire and you need to make them a part of the public system, and so that they are able to provide you and actually supplement our technical knowledge.
Merci beaucoup, Dr Sharma, de ces explications à la fois précises et pragmatiques aussi sur la manière dont vous organisez pour vous qui dirigez l'Autorité nationale de santé en Inde. Merci infiniment d'avoir été présent dans cette conférence. Merci à vous, namasté, et je vous libère puisque je sais que vous avez un emploi du temps qui est très strict. Merci beaucoup d'avoir été présent sur cette conférence. On peut l'applaudir, le Dr Sharma. Sébastien, effectivement, cette question se pose. Vous disiez tout à l'heure, et les ONG, et c'est normal, ne peuvent pas toutes avoir des experts aujourd'hui informatiques dans tous les langages qui existent et tous les designs possibles. Est-ce que du côté des gouvernements, des autorités publiques, vous avez aussi parfois cette difficulté à leur expliquer quelque chose qui n'est pas forcément de leur culture du quotidien non plus lorsqu'un projet est présenté?
Ouais, d'ailleurs on en parlait ce matin ensemble. Et c'est vrai aussi pour nous. Là on parle tout le temps du Sud, c'est vrai pour nous. Et si on parle de la France, pour que ce soit plus intelligible pour beaucoup, aujourd'hui on a cessé de rivaliser. C'est-à-dire que sur cette question des data centers, là la France vient de faire un partenariat avec un privé pour dire installez vos data centers parce qu'on n'est pas en capacité de faire la même chose que vous. Et du coup, ça, on doit aussi le comprendre, l'accepter ou pas. Mais si on l'accepte pas, ça veut dire qu'on va devoir revoir nos souhaits à la baisse, notamment sur tout ce qui est machine learning, intelligence artificielle, etc.
Ça veut dire, si j'entends bien votre propos, que là, on pouvait encore se permettre, allez, mettons, il y a 15 ans, 20 ans, d'avoir, pourquoi pas, plusieurs ONG sur le même type de projet, développer des outils similaires, chacune de leur côté, voire avoir de la concurrence, c'est arrivé entre ONG. Dans le monde globalisé, complexe dans lequel on vit et où chaque technique de recherche est de plus en plus précise, on ne peut plus se permettre ça.
Si, on peut toujours se le permettre parce qu'on a le droit à l'erreur et que c'est bien et que c'est important aussi. Par contre, on doit se parler. Et donc, ce type d'événement est hyper important parce qu'on doit se mettre d'accord aussi. Donc, on parle d'open source, mais l'open source n'est pas du gratuit.
Open source doesn't always mean that it's free of charge. We need to agree on products, on the right products to harvest data, for example. Now, there are some tools that work very well, but they're very expensive. People working in this company are expensive. Spotify, for example, want to start on that market. And so those tools, if you want to scale them up, they are not profitable. And also, you do not find a partner ready to finance.
On est en duplex tout à l'heure avec New Delhi. Je vous propose de partir à l'autre bout du monde, vers Washington, rejoindre Jean-Philbert Nsingamana. Sur le constat, Jean-Philbert Nsingamana, que dresse Sébastien Cusnier sur cette difficulté d'avoir des spécialistes aujourd'hui des systèmes d'information au sein des ONG, peut-être la nécessité demain d'externaliser ces fonctions. Quel est votre sentiment?
Yeah, absolutely. I think in many countries in Africa, the need for more expertise is clear. And in my experience, the expertise, people tend to look at the expertise just for the technical level, people who can develop systems, who can maintain, set up infrastructure. But there is, I think, the skill set that is most missing, in my view, is the skill set that bridges the needs between the policy people and the technical people. I think my colleague Sébastien talked about the difficulty to convince politicians, high-level decision makers on the importance of e-health or some of the projects in e-health. And I think that difficulty is a result in many instances of the fact that the people trying to convince don't speak the language of the people they are convincing. So there is a language that needs to develop between technology and health, and the people who can speak that language and translate between the two fields are very few. So when we talk about the lack of skills, I would actually start at the very top to ask the question, do we have enough people who understand both health and technology so that they can translate the opportunities of technology to the public health people, and the people in the public health can ask the right question to the technology people and have a conversation which will result in the right decisions to be made to push e-health forward. But at the immediate lower... Go ahead.
Non, excusez-moi, je voulais rebondir sur ce que vous disiez qui est assez
Yes, I'm sorry. I just wanted to pick up on what you just said because it's extremely interesting. Indeed, it's difficult for a top manager or a decision maker. Sometimes it's difficult for them to understand extremely technical projects. And sometimes it's pretty cumbersome when you're a health minister, irrespective of a country, be it in the north or in the south. You're not supposed to know what is DHIS2 or any Java code. So for you, how can you transform that in a criteria for success? Should we raise awareness in our top decision makers, or should we recruit the right persons? So for example, at the Minister of Health or the Minister of Telecommunication, should you recruit the people that are able to translate? What are the solutions?
Yeah. Those people exist, but they are very few, and I don't think there is enough to go by in each country, in each department that need those people. So you have the Minister of Health, you have the National Public Health Institute, you have these major health providers who also need digital transformation. So the demand for those kind of people is very high, and I think what needs to be done is to really invest decisively in training that kind of profile. I would say that I've seen in many places, including here where I am in the US, there is a very famous fellowship called Health Informatics Fellowship that is run by the CDC. The Africa CDC is going to embark on a similar type of training. I've seen public health schools in many countries starting public health informatics to try and train those people. And basically, I think we also need to recognize that somebody talked about the culture. I think it's you. You talked about the culture that comes with digitalization. And we need to also recognize that there is a nuance and difference in culture between the tech and the public health. Public health is a very vertical type of culture where the senior doctor, the senior consultant is almost like a general in the army. So it's a very hierarchical, and public health people tend always to see where they fit. Technology is flat. You know, it doesn't matter. You can go to any large multinational company, you'll find the CEO sitting on the same floor, open space with the people. So they promote a sort of an egalitarian kind of culture, so there is even a clash of culture between the two sectors. So what I have seen working well is actually to take public health people and train them on technology than taking technology people and train them in public health in order to bridge that gap. Both works. You can get very talented tech guys who can embrace public health, but gaining the respect of public health when you are not a doctor, you are not seen as, you know, somebody of their world, and gaining their respect and gain their attention, in my view, has been hard. But there is enough people in the public health domain who love technology, who love analytics, who love data, and who would love to do more with technology. I think those are the people that we need to go and find and really train them, equip them with the jargons and languages and understanding of technology so that they can import that into the public health. But I'm not suggesting we should also stop at looking at people with a primary background in technology who also like public health, because so far many of the applications and the platforms that we have today in existence in e-health actually were developed primarily with people who come from tech background and who are innovating to transform health. But no wonder why there are also a huge graveyard of e-health applications.
On voit bien avec vous effectivement que
we see very well from what you say that these solutions are not only technical, this requires change in culture, in mindset, in the way we work on both sides. Now, a last question,
vous avez vécu une expérience intéressante
you had a very interesting experience
sur un projet pour créer des passes sanitaires sécurisées, reconnus pour les personnes vaccinées contre
health pass to recognize people vaccinated against COVID crisis, especially COVID disease, especially in Africa. So safe, a lot safer, and free of charge, if I'm not mistaken. So you were part of that project. Now, very concretely, how did this project unfold? How did you collaborate with African government? What were the key success factors of that collective project? So how did you go about this?
Okay, first of all, I don't think there has been any successful health pass in Africa so far. There are so many projects. The Smart Health Card, which we try to use as a health pass, is one of them. But I have seen in different regions in East Africa having the EAC pass, in certain health passes in West Africa, Southern Africa. I've seen EUDCC, for example, trying to make inroads. I'm aware of the conversations that happen between certain African countries and India on adopting their health pass. I would say all those projects made progress. In fact, Africa CDC and the African Union had its own trusted travel pass as well. So I wouldn't really honestly say that there has been a huge success in any of this, because none of them really was able to be rolled out at scale. So, but I would say that the ones that I know that have made progress are the ones that, first of all, addressed a need of the countries at the moment of the height of the crisis. All these solutions tended to lag a little bit behind the waves of COVID. So, for example, there are so many good passes that are ready now, but the COVID wave is gone, and the need has disappeared. There was a time where countries were really afraid of being contaminated by the international travelers, but at a certain point, countries realized that they have COVID at home, so the pain they were feeling due to the fact that borders are closed, international trade has stopped, tourism has stopped, that pain became a lot bigger than trying to stop one guy who's got COVID and crossing the borders when they know they already have COVID in their own countries. So that need of a COVID pass or a health pass sort of died progressively, but countries had made commitments and so on. And I would say that the most important thing today, as I have seen, is to wonder all the efforts that were made in designing and deploying those pass sanitaire, COVID pass or health passes. How can we ensure that those efforts and investments don't go to waste? And here comes, I think, something that Dr. Sharma talked about, which is standard. Or norms, I think you also talked about them. If those passes were designed according to certain open norms, open standards, using open software, then all the efforts that were invested in developing those passes are not going to be to go to waste. And as far as the Commons project is concerned, we introduced the smart health cards in Africa, in East Africa, especially Rwanda, Kenya, and we worked with the East African community, and in Senegal. Senegal has finished the development and has started a limited deployment, and they are about to go wide in deployment of the smart health cards, which is an open standard, open software. But the most important thing is it's just not for COVID. So if you do something that can only be applied to COVID, of course that thing will be obsolete when COVID is no longer a priority. I'm not saying COVID is going anywhere, but from the policymakers' perspective, it will stop to become a huge priority, and those investments will go to it. Sure. And transforming, if just allow me to finish, the fact that the idea of using a COVID pass to just carry health information, I think that is the most powerful idea that can be applied across the entire health service spectrum.
Ouais, je voudrais rebondir justement sur ce que vous dites, poser la même question. Il y a plein d'idées qui ont été mises là sur la table par Jean-Philbert, Nguemana, Sébastien. La première, c'est celle des standards. On revient toujours sur la poule et l'œuf. Comment je peux faire un projet pérenne, sachant que je n'ai pas forcément de standard, non plus de cahier des charges qui m'est imposé, mais comment aider aussi des gouvernements ou des institutions internationales à monter un cahier des charges, sachant qu'ils n'ont pas toujours les compétences pour aller le faire. Quel est votre point de vue sur cette question?
Déjà que les standards, ils existent. Il y a beaucoup de littérature là-dessus. L'open source, c'est pas nouveau. C'est pas quelque chose qui vient d'être créé.
Open source standards are here, have been here for a while. A number of players have worked on Digital Square, for example.
Ça veut dire qu'on ne l'impose pas, le cadre, alors?
So you mean we don't impose this? Well, we do not impose this upon ourselves, because we need to understand those standards. GDPR is, for example, a standard which exists. Now we need to comply with it, accept it. This is not a given. This poses a number of constraints to the project managers, because you need to comply with a number of rules. GDPR, yes, that's right. The framework exists, it's defined, it's compulsory, and you may have sanctions if you do not comply. Does it mean that in countries of the South, they do not respect, they do not have a framework which is enforceable and may come with sanctions? Well, you know, it's not only in countries of the South. We're talking about health data, personal data. Yes, we need a framework, and this framework also defines limits, thresholds, and is also a way for us to push the envelope and go beyond this framework. Currently, we're talking about many initiatives that are not defined within such a
tout à l'heure, vous avez créé cette société après un long passage en ONG. Le constat que les ONG n'ont pas toutes les compétences, n'ont pas les moyens de se payer ces compétences en interne, et n'auraient peut-être pas les moyens de les occuper à 100% non plus. Tout l'intérêt de les externaliser vers une société privée. Et là, ça semble coincé parce que les bailleurs, eux, ont du mal à comprendre cette manière de penser. Est-ce que vous pouvez développer?
Oui, tout à fait. Pour moi, l'une des solutions, c'est l'entrepreneuriat social et solidaire. Du coup, on a créé une entreprise sociale qui est à l'intermédiaire purement privé, qui a vocation à viser du profit, et du milieu associatif où justement on est tributaire des bailleurs, de la durée des programmes, etc. Pour pouvoir assurer de la pérennité, il faut avoir une structure qui va durer au-delà des programmes, pour pouvoir faire de la maintenance, pour assurer, pour pouvoir faire de l'accompagnement quand une formation, etc. Par contre, effectivement, on est hors scope des bailleurs. En fait, on doit vivre
hors scope parce que vous êtes entreprise privée, donc suspect d'aller gagner de l'argent?
Non, c'est pas une question de suspicion, c'est juste qu'on rentre pas dans les cases. En fait, c'est trop nouveau, très nouveau. Du coup, on n'est pas une asso et on ne peut pas être éligible à tout un tas de subventions,
we are not an association, we do not have the right legal foundations, and for that reason we are not funded by conventional sponsors. They do not know the social entrepreneur industry. There are rules, and we need to raise awareness about that. And one of the rules, for example, is that incomes or salaries
et qui font aussi qu'on a une capacité d'attraction sur des talents qui sont en quelque sorte extrêmement élevés.
Donc, c'est-à-dire que les bailleurs, quelque part, ils se tirent une balle dans le pied en continuant à financer des projets comme il y a 10 ans, 15 ans ou 20 ans, alors que vous expliquez qu'aujourd'hui, il faut une technicité qui est nécessaire et qu'on ne trouvera pas dans les ONG.
On arrive à la trouver, mais c'est
well, you know, we managed to hire. Nonetheless, we find the talents, but it's difficult to retain them. And so it's very difficult to locate our talents. And we need, you know, not only one, sometimes we need maybe 20. on security, on development, on a number of topics, new topics, cutting-edge jobs, new jobs for some that are very new.
Je voudrais qu'on se tourne vers quelqu'un justement qui est un peu dans la même philosophie que vous, qui est au Bangladesh, à Dakar. On va aller rejoindre Mridul Chaudhary, donc je rappelle directeur de Empower Social Enterprises, qui gère entre autres Trauma-Link au Bangladesh, dont on a parlé ce matin. Mridul, est-ce que vous partagez le constat de Sébastien? Tout d'abord, il y a une technicité aujourd'hui que des ONG ne peuvent pas se permettre, et paradoxalement, il y a une difficulté pour des entreprises vis-à-vis des bailleurs à qui elles peuvent pourtant apporter cette technicité.
I'm sorry, I actually couldn't hear Sebastian very well through the audio system. So I'm actually a little blinded there.
Pas de souci. Je reprends les propos de Sébastien. Je pense qu'ils vont se rapprocher des vôtres aussi, qui nous dit aujourd'hui, les projets digitaux nécessitent de plus en plus de technicité, de compétences techniques. Les ONG, pour la plupart d'entre elles, n'ont pas les moyens d'avoir ces compétences techniques en interne. D'où l'intérêt de faire appel à des entreprises privées. Mais ce statut d'entreprise privée aujourd'hui est compliqué vis-à-vis des bailleurs. Est-ce que c'est votre sentiment?
Do you have the same issue in your country?
Yes, certainly. I mean, in my country, there are certainly restrictions regarding, grant funding coming to private companies. So grant funding generally has to come through NGOs. So getting private sector involved is not a very easy process, generally in development sectors, in development programs, unless there is a procurement process, and it's a cumbersome bureaucratic process.
Quelles sont les manières justement de contourner ce verrou, à votre avis, et d'arriver à une meilleure collaboration? Parce que si je comprends bien, on sera obligé de passer par ce passage.
You will need those skill sets eventually.
Right. So what happens, in Bangladesh at least, what we have done so far in a number of cases is that we have actually partnered up with NGOs. So when NGOs often think of getting the private sector involved as an afterthought. After they get a project funding from a donor, then they think about which private sector to get involved. Instead of that, what has often happened in Bangladesh, and then also with us, because I represented a private company, a digital health company, and we work very closely with the government and with several NGOs in Bangladesh and abroad. So what has happened often is that the NGOs, when they're writing the grant proposal to the donor, they essentially partner up with us. And then they write a joint proposal that, this is what we are planning to do, and this is how we want to execute things. So there are two advantages to that. Like the advantage, the problem that you were just talking about before, that NGOs often do not have the expertise in-house to be even coming up with a proper project proposal for a donor. And hiring a private company when you're writing a proposal or writing out an idea is often not sustainable. It's not financially feasible. So partnering up with a private company in a very early stage actually solves that problem. From both ends, from the donor end and also the NGO end.
Vous nous dites, et on voit bien depuis le début de cette table ronde, la clé d'un succès pérenne, c'est la capacité à avancer, on va dire, en crabe, peut-être de la part d'une ONG et d'un gouvernement. On avance en le faisant. Et vous avez le même constat avec Trauma-Link que vous avez développé. Vous dites tout dépend de la maturité numérique ou digitale du gouvernement que l'on a en face de nous. Et il y a des grades dans cette maturité. Est-ce que vous pourriez nous expliquer justement
Could you tell us the different levels you are faced with?
So, we work with a number of different countries in Asia and Africa. And what we have often seen, over the last 15 years or so for the digital work that we've done, digital health work, is that, broadly speaking, countries are generally in three different levels of development in digital health. In the first phase, countries are generally just doing pilots here and there. Often they're not following standards. Often they're just deploying solutions just to test something out. Often they're small level pilots. So that's what happens in the initial stage. And I don't necessarily look at that as being absolutely bad, because I mean that's the learning phase, when you're making mistakes, when you're learning what's wrong and what's working and what's not working. But that's a phase that often countries just have to go through, and how long they will go through depends on policies and so on. In phase 2, I mean, government starts building their capacity when they have built some of their capacity in-house, so that they don't have external dependence as much as in phase 1. In phase 3, government starts taking leadership of digital health projects. I mean, they start developing projects, they start defining what they want to do and the kind of impact they want to have. So I think from a donor perspective, it's very important to identify early on which phase a country is actually in. Because if a country is in phase 1, expecting a phase 1 country to build internal capacity and internal sustainability overnight will not be feasible. So the expectations of sustainability, I think, will have to be customized for phase 1 countries. And the expectations can be more around, making sure that the right lessons are learned. And also, I mean, the other thing that happens often is that when you're making projects, I mean, there is just not enough resource allocation kept for building capacity within the government. I mean, too much money is spent on actually implementing the project, and not enough on building capacity within the government. So I think that's often a kind of oversight that I see in a lot of these development projects.
Ridoul, alors qu'on découvre en même temps les images de Tourmaline que vous avez développées, dont on a parlé ce matin au Bangladesh, quels sont les facteurs internes ou externes qui font qu'un gouvernement va passer ou qu'un pays va passer du stade 1 au stade 2, puis du stade 2 au stade 3 ?
I think internal factors would definitely be, governments' willingness, I mean, political willingness. I think that plays a big part, because some governments, like in the case of Bangladesh, a digitalization of all sectors was a political mandate. So digital health became a very big mandate to begin with. So I think that's one. So moving from, so that's a big incentive for a government to move from one phase to another. The other incentive is when governments clearly see that digitalization actually leads to visible impact, and it leads to voter confidence, it leads to citizen confidence in government policies. Because digitalization, I mean, if you look at it from the point of view of a beneficiary or of a citizen, does not necessarily mean better services. Because often what happens is that a lot of the digitalization is about automating workflows. Like, you're automating forms, you're digitally creating reports, but that does not really bring benefits to the government, I mean, to the citizens directly. So the citizens don't really see a real impact. So I think the other thing that needs to happen, I mean, when you're trying to push a country to adopt digital health, is to make sure that from the very start, that projects are defined in such a way so that impact of digitalization can actually be felt by the beneficiaries in terms of, greater coverage, in terms of, a government worker's ability to reach somebody on time and in a timely manner. So all of these things that go with actually utilizing the data to bring about more efficient services. So I think that has to be taken as a big priority, because often I've seen in a lot of digital health projects that it's mostly about collection of data, as if collection of data and automated generation of reports is the end by itself. And if that is the end by itself, beneficiaries don't see any benefit. And they don't really buy into it. And then eventually governments also don't buy into it. So I think when you're designing projects, citizen benefit and citizen engagement has to be a big priority when designing projects, because that is what really keeps the government incentives going from one phase to another.
Mridul, il nous reste 2 toutes petites minutes avant la fin de cette table ronde. Effectivement, vous parlez de métiers et de fonctions de plus en plus précises, la collecte de data, l'analyse des data, la montée en compétences des uns et des autres. Il y a une question qui est centrale et peut-être aujourd'hui...
Sorry, I'm not hearing any interpretation.
Can you hear me now? Yeah,
alors,
now we are. We're
ça bascule voilà, sur le bon canal. Vous nous parlez de fonctions et de besoins de plus en plus précis, collecte de data, l'analyse de data, l'hébergement de data, et tout ce que vous avez d'ailleurs mis en place sur Trauma-Link, géolocalisation ou autre. Il y a une question qui reste centrale et qu'on ne se posait peut-être pas il y a 15 ans, 20 ans dans ce monde, c'est celui de la formation,
training, okay? Training to have new skills, and how can you maintain these skills in the digital services or NGOs, because you know that these people could leave and get better salaries in private companies. Do you have ways of training people and keeping people in your companies?
Yes. So are you mentioning about retaining talent within a private company, or are you talking about training people in the government or NGOs?
Je disais former et garder les gens dans votre entreprise où vous n'avez pas forcément les salaires des grandes entreprises à côté.
Sometimes they might want to leave to other companies where they're going to get better paid.
Of course, yeah. Yes, I mean that is actually always a kind of a holy grail problem when you're dealing with a digital company of any sort, because technologies tend to change and people will want to change. I mean, in the digital sector, it's just so that, I mean, except for countries like Japan and South Korea where people have lifelong employments, in most countries that's not the case. I mean, people tend to switch jobs. And then we have faced that. And one way we have tried to prevent it is always making sure that we are moving up the value chain in terms of technology. What that means is that technology is always, newer technology is always coming. Like for instance, when we started out digital health 10 years ago, 15 years ago, the kinds of technologies that people were mostly getting trained in was about, collection of data, mobile applications to collect data. Then came different kinds of visualization tools such as DHIS2, where you can visualize that collected data in a very interesting manner. Now people are, I mean, this entire industry is moving more and more into artificial intelligence. Like, how do you deal with a lot of data, analyze a lot of data, and come up with machine learning based assessments and algorithms. So for a private company to retain people, I think it's very, very important to kind of keep going up that value chain, because if it's stuck in the 10-year-old, 5-year-old technology space or the solution space, they will not be able to retain talent, because new talents will essentially want to go into the new technologies that are coming up and the new fields that are coming up. So for companies that want to retain talent, I think that kind of progressive mindset and looking into the future and preparing its employees for that future is of crucial importance.
Merci Mridul de ces explications.
Thank you very much, Mridul. I would like to ask the same question to Sebastian, because you have recruited, you're still recruiting people in IT for Life, and this is something which was not an issue for you 10 years ago, where you didn't have such a digitalized environment. People were always there, they would stay, would be very stable. You didn't have to retain talents. People would get trained to stay in an NGO. But now with digitalization, things have really changed, and the issue of training is really, I think, basic and crucial.
Du coup, ça, on en parlait aussi ce matin, et on a parlé cette semaine avec la Fondation Pierre Fabre, et là, j'ai pu en parler aussi avec l'AUF. Je pense que oui, c'est essentiel de former des gens, localement, et sur ces technologies-là, qui sont rares, donc sur des chaises de Comcare, qu'est-ce que c'est que de la collecte de données, comment on fait une analyse, comment on répond à un cahier des charges, comment on construit un cahier des charges. Donc c'est au-delà des compétences techniques, c'est ce qu'on disait au début, c'est tout ce qui est autour. Et du coup aussi, faire des stages, faire de
environment we
de
have
l'alternance dans des
for
ONG pour aussi comprendre
digitalization.
quelles
We
sont les
also
problématiques
have
de
to
terrain.
have people
Parce que
who
quand on
can
sort de
change
l'école, on n'a plus
positions
une
in the same
compréhension de tout
company
ça.
so as to make
Et
sure
on se
that
dit,
they
bah oui,
understand
on va
what
aller
is at
connecter les centres de
stake.
santé.
And
C'est ce que
therefore,
disait Florence ce matin. Oui,
as Florence said
Internet,
this morning,
on va rien connecter.
we're
Et tant
not
qu'on
going
n'a
to be
pas
able to connect
expérimenté ça,
people. If you don't have connectivity, well, you can't do anything. So you need connectivity. You need people, experts who can train other people, and where you're sure that you're going to be able to master the tools you have. And we know that the people we're going to train are always going to find a job elsewhere. So this means that we have to be very inclusive. We have to take into account gender issues. We have to take into account the awareness concerning these tools. Aristide Afinindou Gassimbe, I would like to ask you the same question. That is to say, how can you retain talents? That was not a problem 15 years ago. Is this something you really keep in mind today? Well, thank you for this question. Yes, yes, I'm happy to take the floor again. I was very interested by what was said, and especially by our friend in the United States, when he said that you
Vous savez, je pense que le décideur politique n'a pas besoin de comprendre tout le langage possible. Il faudrait lui faire comprendre l'importance de la chose. Quand nous sommes passés au numérique ou à la digitalisation, est-ce que c'est parce que quelque chose n'allait pas à la base? C'est la première question qu'il faut se poser. Si ça allait, pourquoi on veut passer à la digitalisation? C'est parce que ça n'allait pas. On pense que la digitalisation est une solution. Le décideur veut comprendre si on investit ici, qu'est-ce qu'on peut
do that anymore. So we have to explain to the decision-making people that we need digitalization, even though we're not going to go into the technical details and try to explain everything to them. Now, when it comes to recruiting and retaining young talents, well, in Togo, when we started digitalizing and when we had telemedicine developing, we had internet connections. And today, this is not the case anymore because Togo is one of the first countries which has fiber optic.
N'est plus d'actualité. Maintenant, comment motiver les uns et les autres? On ne va pas former des médecins pour devenir tous des informaticiens, tout ça là, ou former des informaticiens pour devenir des médecins. C'est l'approche beaucoup plus intersectorielle qu'il faut promouvoir. Cette question de la santé numérique est une question transversale. On ne peut pas la gérer seul. Vous avez besoin d'un autre, l'autre a besoin également de vous. Aujourd'hui, ce qui se passe sur le terrain, c'est de l'amalgame. C'est pourquoi il faut mettre les moyens au-delà du développement des compétences en technicité. Il faut également former aussi des praticiens parce qu'à la fin, l'outil ou la technologie ne va pas remplacer l'humain. Et tenir compte aussi des besoins des populations à la base. La population à la base, elle est bénéficiaire. Donc, il faut tenir compte d'abord de leurs priorités. Donc voilà un peu ce que moi je pense. Retenir quelqu'un, si la personne qui est en train de travailler se sent à l'aise dans un domaine défini, et s'il a ce qu'il faut pour mener à bien son travail, il va y rester. Mais généralement, qu'est-ce qui se passe? Pourquoi les hommes partent? Parce qu'ils trouvent mieux ailleurs, et c'est la question financière. Donc vous voyez un peu qu'il y a trois niveaux. D'abord les ressources humaines, les ressources financières, et puis les ressources matérielles. Aujourd'hui, on parle de la télémédecine. Il y a la technologie, il faut que les États soient en mesure d'acheter aussi les outils nécessaires. Et chaque jour, il y a des mises à niveau, tout ça là, ça évolue. À chaque fois, il faut insister sur la formation aussi continue. Donc voilà un peu ce que moi je dirais. Si les hommes partent, ils partent parce qu'ils trouvent mieux, ou soit ils sont sous-utilisés, ou soit ils trouvent mieux que leurs compétences peuvent être mieux valorisées ailleurs.
Merci de ces explications. Il nous reste quelques minutes cette fin de table ronde. Beaucoup de choses qui ont été dites depuis le départ. Cette question de la pérennité, peut-être sur les projets aujourd'hui en santé digitale. Je vous propose de prendre la parole. On va faire circuler un micro dans cette salle pour tous ceux qui veulent poser des questions. Et on partira également tout à l'heure sur un autre campus de l'AUF. Voilà. Monsieur, on vous apporte le micro rapidement. Je vous demanderai de vous présenter, puis des questions courtes à chaque fois, comme ça on aura pas mal de réponses pour les intervenants ici ou pour nos intervenants qui sont à distance.
Merci beaucoup, je suis Rodrigue Akoli, fondateur de la plateforme e-Santé Convivial, je viens du Togo. Et je voudrais m'intéresser à l'intervention de Sébastien par rapport à l'obstacle qu'il a eu en tant qu'entreprise. Effectivement, quand je prends notre situation au Togo, nous avons eu la même difficulté en tant qu'ONG. En tant qu'ONG, nous étions confrontés à un obstacle par rapport à la mobilisation de ressources. Donc, ce qui nous a amené progressivement dans notre plan d'action, dans notre plan stratégique, à passer de l'étape d'ONG en entreprise. Et grâce à une formation que nous avions obtenue auprès du groupe, nous avons pu créer une entreprise qui intervient dans le même domaine et qui d'ailleurs arrive à mobiliser les fonds et à appuyer l'ONG. Donc je pense que c'est également une opportunité de réfléchir dans quelles conditions on peut également pour freiner ou bien lever cet obstacle et que vous avez parfois auprès des bailleurs passer à l'étape sociale également.
Sébastien,
Sebastian, maybe you would like to react to what has just been said. Yes, this is what we're going. We're not going to do that. We're going to create an association so as to collect funds. We come from an NGO. We were 100% NGOs, and we had a conflict of interest, and therefore it didn't work too well. And this is why we wanted to create an association so as to be able to have the possibility of developing our activity. And this is why with our donors, we had this discussion. They told us, no, you have to have two separate entities, and this is why we're going to create an association. But as I said, we have a difficulty here for the sustainability because we're going to be creating this association. We're going to say we're wonderful, we're doing very well, but we know that it's not going to be the case in a sustainable manner. We can't just stay in the marketing.
Je poursuis la réflexion de monsieur en matière de formation de talents, capacité à retenir des talents, notamment sur des capacités digitales. Est-ce qu'aujourd'hui,
what is your situation? Do you think that the fact that you're being a company, it's going to be better when you want to attract young talents? Because probably they believe it's more interesting to be in a company than in an NGO. You see, or in a company incubator with digitalization, young people feel better. It's more attractive. Answer: yes, I think that we have to do is become a social company, because then we have different talents. And the difficulty is the scale of our structure, because our structure is small and limited. And we're very dependent upon the people. We have very, very good talents in the company, people who are very good in technologies and who have been awarded by our foundation. But with all these exceptional talents, we also attract other people who are going to try to take them away. So we have to have more positions so as to make sure that we're not going to be in a difficulty when we lose some people in the company. Other questions?
Toutes vos questions sur cette thématique, comme ça, elles nous arrivent en direct et on peut les donner en direct. Laurence Gauthey-Berkins.
Je voudrais juste vous remercier parce que j'ai trouvé ça absolument extraordinaire, cette session. Donc, vraiment merci aux intervenants. En fait, moi, je voudrais juste dire, est-ce qu'on peut faire un plea to action? Comment est-ce qu'on dirait en français? Un appel à action. Parce que je disais ce matin, je reviens sur les routes ou le tronc de l'arbre, c'est-à-dire je disais ce matin, il y a 12 pays seulement qui ont implémenté des stratégies. Donc on a parlé tout à l'heure de ce besoin de formation au sein des gouvernements aussi. Vous parlez de différentes problématiques de formation. On sait qu'il y a 3 programmes aujourd'hui. Il y a Derek qui est là, il y a un programme au MSIT de formation. On a la Fondation Pierre Fabre avec COB, je ne vois pas où est COB.
Il est dans la salle. Voilà.
Il m'a dit
Cheikh Oumar Bagayoko, COP pour les intimes.
60 candidats COP, je crois, et pas forcément que des gens du gouvernement, j'imagine, dans la prochaine session. Et puis on a un autre qui s'appelle le DALP, le Digital, c'est comment ça dit, Derek, qui est l'appel d'offres qui a été lancé, c'est avec l'Université du Rwanda, je crois. Digital Leadership, DLAP, right? Applied Digital.
Applied Digital, I think.
Donc on a 3 programmes de formation, mais qui accueillent qu'un nombre limité finalement de candidats. Donc voilà, il y a certaines personnes dans la salle, je pense que soit on peut essayer d'imaginer de passer à l'échelle, Mais moi, en ce qui me concerne, je trouve qu'il y a urgence parce que je vois cette effervescence. J'ai évoqué ce matin, il y a des startups, il y a les investissements privés, parce que je n'ai pas tout dit ce matin, mais je sens que c'est prêt à décoller vraiment beaucoup. Et tant qu'on n'a pas ces routes en place, ça ne va pas. Donc, si le frein essentiel, et c'est ce que moi j'ai pu observer dans certains pays, c'est la formation de personnes au sein du gouvernement pour maîtriser ce sujet assez pour pouvoir développer ces routes. Voilà, c'est un appel à l'action.
En tout cas, on voit que c'est une carte, la notion d'information, de sensibilisation et de formation est une carte centrale. On va amener un micro. Voilà.
Merci beaucoup. Thank you very much. I couldn't resist myself after the point that Florence mentioned. So I wanted to give a quick intervention, complementing what has been mentioned and what others have mentioned. The issue at hand is how do we ensure that the transformation of the health sector leaves no one behind when it comes to the capabilities of the individuals, the people that exist in that ecosystem. Florence and other speakers have highlighted an important point because for 15 years, we have seen the industrial revolution going forward, but the people skills and the structures in which the people live haven't gone addressed. We still have old job descriptions. When you go in governments, you still see titles, systems analysts, okay, IT manager used previously. And in health, you still have the challenge because governments have not changed the job descriptions to include e-health and digital health skills. So the question of competencies to inform revision of job descriptions becomes important so that people are employed appropriately, they are interviewed correctly, and the job market changes consistent with the changes in the ecosystem. So it's an important area for all of us, developing partners, to address so that we're in touch with the changes in the environment. Merci beaucoup.
Merci. Sébastien, est-ce que vous voulez compléter effectivement?
Sebastian, would you like to pick up on this because it's really interesting to see that after the roundtable training, which was not the main topic, is really becoming is really at the heart of our concern. Yes, I think that what you just said concerning explanations, information, rolling out training for NGOs, and explaining what we're expecting from all these skills is really important because if you want to recruit someone who is good in IT, it doesn't mean anything anymore. You have to be more specific. You have to make sure you know what kind of profile you're talking about. And therefore, I think that what are the jobs we need today, what are the skills we need, and it has to be well understood by everybody.
Je vous propose, Sébastien, d'aller à la rencontre d'autres personnes qui vous écoutent attentivement depuis le début de cette table ronde. On va se rapprocher d'un endroit qui vous tient cher à cœur, qui est la plage du Virage à Dakar, où on va se rendre sur le campus de l'AUF, qui nous écoute depuis le début de cette session et qui a très certainement des remarques ou des questions à poser à l'issue de cette session. Qui est-ce qui est là à Dakar?
Alors merci à Dakar, Michel Nama, responsable du
Michel.
Je suis toujours en compagnie doyen honoraire de la faculté de médecine.
Here I am with some of the colleagues of my faculty. The sound is very bad, says the interpreter. We're sorry, we're doing our very best. So I don't know, after what you've said, and very challenging discussion, we will be able to ask my colleagues here around the table if they have anything special to say, because I'm here with my colleagues here. I don't know, maybe they have comments. Thank you. Thank you very much, Michel.
Je pense que ça a été dit et je pense que ça c'est la chose la plus importante.
I think that what we've said today is very essential. That is to say, training. Training is the really the essential concept we've been dwelling on. And this is important for the e-health sector. Of course, you need IT experts, and we need people who are skilled enough, and this is why we have to train them, of course, not only in the field of IT. This is what we've tried to do in Senegal, in Dakar. We have been trying to set up some training modules for that, and it's something we're very much aware of the importance of these new skills for the development of the e-health. So, as I said before, this is really the main effort we have been making. We have many tensions on the market, and we have to train people, as I said before, taking into account this cross-sectionality and this complementarity you've been talking about. Make sure that these people who are going to be trained are going to be able to work one another. Sébastien, we have the possibility.
Allez, très rapidement, Michel, effectivement.
The sound is very bad. I'm very sorry, says the interpreter. There's an echo in the room. I'm working in the veterinary school, and I would like to speak of e-health, e-health for humans, but also should we take into account animals, because the animal health is also very important. And this is something which is also one of our concerns.
Merci beaucoup de ces interventions depuis Dakar. Je sais que vous suivez cette journée avec beaucoup d'attention. Merci, puis on vous retrouvera d'ici la fin de la journée. Merci également à nos intervenants qu'on peut applaudir sur cette table ronde. Et on va poursuivre ce programme ambitieux aujourd'hui sur cette question de la pérennisation, de la capitalisation des expériences des autres. Et pour ça, on part dans quelques instants au Pakistan. Alors, on part pas pour la bonne carte ni pour le bon jingle, mais c'est pas grave. On a la bonne personne en face de nous, donc c'est ce qui compte derrière. On va continuer notre partage d'expérience dans cette conférence toujours d'observatoire dans la e-santé dans les pays du Sud. Et donc à Karachi, à Pakistan, on retrouve Salem Sayani. Bonjour Salem Sayani, est-ce que vous nous entendez bien? Parfait. Alors, merci beaucoup. Vous êtes directeur du Centre de ressources en santé numérique de l'Aga Khan Development Network. Merci de participer en direct aujourd'hui à cette conférence. Et vous avez tenu à partager avec nous les retours d'expérience de programmes de e-santé au Pakistan. Et je vous laisse donc la parole pour une trentaine de minutes. Et pour vous, je rappelle que vous regardez en direct, sachez que vous avez la possibilité d'adresser toutes vos remarques, toutes vos questions, et qu'on les posera à Salem Sayani à l'issue de sa présentation. Voilà, Monsieur Sayani, je vous laisse la parole.
Thank you. I appreciate this. So, as you know, my name is Salim Sayani, and I am the Director for Digital Health Resource Center for Aga Khan Development Network. And I am also the Director for Technology Innovation Support Center for the Aga Khan University. Do I need to pause for translation, or I just go?
Allez-y, on déroule la présentation en même temps.
You do not need to wait for translation. I do that simultaneously, sir. So you can go ahead. Thank you.
Fantastic. Thank you. So I'm here to talk to you about a project, a very successful implementation that we have in Pakistan. It is called Hayat project. Hayat in local language means life. So this is a project to digitize the entire process of MNCH, maternal neonatal child healthcare services, starting from antenatal care to delivery to postnatal care, child growth monitoring, family planning, and then all that. So let me just briefly talk about how it all started. So in 2018, government of Pakistan in Gilgit-Baltistan and Khyber Pakhtunkhwa, these are two provinces in Pakistan, in the northern areas of Pakistan. So they came to us, the Department of Health, they came to us and they said, well, we need Aga Khan University's help to this entire process of vaccination and also MNCH care. Right now, we have people, we have lady health workers, we have vaccinators, they go out in the field, but we don't know, we cannot monitor them real time. So how Aga Khan University can help us in strategizing and developing a solution that is digital solution that will help us create more transparency in the process and more accountability for the work that is being done. So we sat down with our stakeholders, we went through different brainstorming sessions, and we came up with a solution that is that had two parts. One is a mobile application, and the other one is web portal. So what mobile application would do is that it would actually convert all this data collection that was happening in the field on the paper into a mobile application. It was HL7 compliant in terms of architecture. It had personal family health records, so it has not EHR, but PHR, which is personal health record for individuals. And then it can have a tracking for all these vaccination and other services that were provided by frontline health workers, such as lady health workers, vaccinators. It also had a module for COVID-19 vaccination tracking. And also, one thing which was very important is that it had an awareness session video content, so that we standardized entire health promotion messaging. So if there is a message about family planning, it is a consistent message that is videotaped, and it is a short video for 30 seconds, maybe 90 seconds, from 30 to 90 seconds about that topic. So you as a health worker, you don't have to think about how you're going to communicate that message to the pregnant woman or other family members of the household, but you can simply play that video, and those videos are in local language. And then there is this other part of the solution, that is web portal. The web portal is a centralized server, and it provides geo-mapping and tracking of all activities of all healthcare, frontline healthcare workers. So if you are a vaccinator and you are supposed to be in village A on Monday at 9 a.m., your supervisor sitting in his or her office, in the head office, can I see if you are actually there? And just important that you being there, if you perform a certain task, for example, if you are a vaccinator and you're vaccinating a child, your color of your tracker changes from red to green, so that your supervisor sitting far flung can actually see the workload that you had and also the amount of work that you're performing every day. So this provided a lot of transparency and accountability in the entire process. Now, one of the challenges that we face, and I heard this earlier in the session, that the geographies that we work in low and middle income countries, we don't have luxury of having internet connection all the time. So we took that into account, and we made sure that our application, the solution that we have, Hayat, is an application that works in an online mode as well as offline mode. So that where the geographies or the villages where there is no connectivity, healthcare worker can go out in the field, perform the task, and then come back to the health facility where there is internet connectivity, and then can upload the data. It is a very similar concept like in North America. If you go to Starbucks or in Europe, you go to Starbucks or Dunkin' Donuts coffee shop, you have Wi-Fi hotspot, and then you can upload your data. So it has worked very well, and that is why as healthcare providers and also technologists in e-health space, we always think that we need to have a real-time information, but we need to also think about close to real-time information where we don't have infrastructure, right? Next slide, please. So this is to give you an idea about the application. This is a screenshot of different screens of the application, Hayat application. So you can see that this application mostly is bilingual in English and in Urdu, but mostly in Urdu, so that there is no learning curve for healthcare, frontline healthcare workers, because they are well aware of the language, Urdu language, and this entire application is in Urdu. And we also have QR codes. So once you scan the QR code, we can just extract information about your family, about your health record, and then the health record of your household. Next slide, please. And these are some of the pictures, and it gives you the context of where we work. So this is a mountainous area in northern Pakistan. It borders China and India. So very close to the border, and very difficult and hard to reach valleys and areas where sometimes you don't have access to people because, you know, there's a landslide or there's snow that you cannot even travel. But that does not mean that people living in these communities, they don't need health services. They do. And one of the ways to provide better health services and access is digital health or e-health. And at the bottom, you see on the left, the educational videos are shown on a mobile phone, not having internet connection, so that people can learn more about different topics such as birth spacing, such as family planning, such as child growth monitoring, and others. Next slide, please. So these are some numbers that I would like to share with you in terms of beneficiaries of Hayat project. So as you can see that we have registered, there are about more than 43,000 children under 2 years over the period of last 3 years that we have registered, and adolescent women especially from 15 to 19 years of age are about 42,000, close to 43,000. And then from 20 to 49 years of age, we have about 163,984. These are the beneficiaries who benefited from this Hayat project one way or other. So as you know, in Pakistan, the person who is head of the household is usually husband, but the person who actually makes decision about pregnancy and where a woman is going to be delivering, that is mother-in-law. So this number shows the inclusion of mother-in-law in the household. And also, you can see that pregnant women who receive 4+ ANC visits is about 9,446. Now, what used to happen is people did not have enough awareness of why they should get antenatal care visit, let alone 4 visits. So we created that culture, and then through our behavior change messaging, we made sure that people are aware why ANC is necessary, antenatal care visits are necessary, and how they can help reduce complications earlier in the pregnancy so that you can have a successful delivery. Now, also, there are some numbers about the children with basic vaccination, about more than 30,000 in that catchment population. And we conducted about 187,000 awareness sessions for different folks. And this application is used by frontline health workers, as I said earlier, and there are about 530 health workers. They are using this application. Next slide, please. So how this application actually, as you can, I'm sure you have similar structures in your respective countries. So there is an EPI component in health department, which is assigned for vaccination for children. And then there is a lady health worker program, which are, sometimes you call it community health workers, lady health workers, community midwives. So these are the workers, health workers, they provide MNCH related services in field. But the challenge was in Pakistan that these programs, they did not talk to each other. So these are vertical programs, but they did not have any collaboration or coordination within the programs. Can you go back to the slide, please? Thank you. The next one. Yeah, thank you. So we made sure that through this platform, through this application, there was an integration between two programs, and there was close to real-time monitoring that I talked to you about. We also made sure that there was a transparency and accountability mechanism through this application. Something that is very important is that we had buy-in from the government in Khyber Pakhtunkhwa and Gilgit-Baltistan so that this program can be sustained long-term. So now I'm very happy to report that the initial phase of this program has been now taken over by the government in Gilgit and Baltistan, and also in Khyber Pakhtunkhwa, so that they are now paying for the operating cost of this program, like connectivity and other stuff. So that is very important for any program to be sustainable. I heard about sustainability earlier, that you need to make sure that government of that respective country, in this case Pakistan, is fully on board, so that if we show successful results, they are willing to take over the operation, and it is not a project that has a start and finish date. It continues as a program. Next slide, please. So this is what we are planning to do moving forward. We are actually scaling up this project in Gilgit-Baltistan and 5 additional districts, and I'm happy to report that actually this is partially funded by the government based on the result that they've seen earlier. So that is a good sign. We are also adding some features and functionality into this application. We are now adding another module to it, which is related to non-communicable diseases. And we are going to integrate DHIS2 so that there is a direct reporting to the provincial level into DHIS2 system. And of course, as I said earlier, that we work very closely with the government so that we can achieve long-term sustainability, be it in Khyber Pakhtunkhwa or Gilgit or in any other country. So with that, I will conclude this presentation, and I'm very happy to answer any question that you may have.
Merci beaucoup pour cette présentation, Salem Sayani. Effectivement, profite pour me retourner vers cette salle et puis aussi vers les internautes. N'hésitez pas à nous adresser toutes les questions. Est-ce qu'il y a des questions par rapport à ce projet Hayat qui nous a été présenté par Salem Sayani? Alors, on va vous apporter un micro. Voilà, tout de suite. Hop, pas de course.
Yes, please jog, run around. Here we go.
I'm going to speak in English. Thank you very much, Doctor, for your presentation. I have a question regarding the acceptability of the tool and sharing a little bit the experience we had in Afghanistan, where we gave tablets to the midwives while they were doing the household visits. But then we found that they were still collecting data on paper and then coming back home and then digitalizing everything at home, basically because going to the household with a tablet was not acceptable by the community. So I just would like to know how that happens. Of course, Afghanistan is not the same as Pakistan. The situation is very different, but culturally could be similar. And I would like to know how that goes in Pakistan and how the communities have been reacting to this. Thank you.
Very good question. And so what I did not mention in part of my presentation was that this Hayat project was implemented in Pakistan as well as in Afghanistan. So we had a very successful implementation in Afghanistan of Hayat project. And there was no issue that we faced in terms of community health workers taking mobile phone out in the field and collecting data. What we actually modified from our approach in Pakistan, in Afghanistan, was that we changed that application and the way people collect data, because as you can tell, that in Afghanistan, the literacy rate of healthcare worker is comparatively low than the literacy rate in Pakistan. So we make sure that they are comfortable in a way to collect data so that they don't have to learn anything different, right? So the user interface was very different, and it actually depicted the way they were collecting data on paper. And sometimes we see that that is usually the problem, that when people don't say the real cause, they have all these smoke screens. So if you go through those smoke screens, in my opinion, we find the real cause. And if we address that, then there's a problem. Culturally, I did not see any problem, and we did not face any problem. But you may have implemented the project that you talked about in more challenging province than we implemented Hayat in. So we implemented Hayat in Bamiyan and Badakhshan. So I hope that answers your question, partially maybe.
D'autres questions, d'autres remarques, madame?
Oui, bonjour, merci. Je vais parler français. Tout d'abord, merci beaucoup pour tous ces partages qui sont très intéressants. On parle de pérennité et du coup, je souhaiterais poser la question de manière peut-être un peu plus large que l'expérience, mais aussi l'expérience actuelle de ce projet, sur notamment tout ce qui est maintenance des équipements qui sont utilisés. Parce que c'est souvent un des problèmes récurrent, c'est-à-dire que le projet se fait, mais quid de la suite, et notamment en termes d'équipement.
Peut-être poser la question à Salim Sayani. Au Pakistan, comment il assure la maintenance ou le rachat éventuel de ces équipements?
Yeah, very good question. And when it comes to sustainability, we also sometimes forget, actually, to include the upkeep of the hardware. So we included that, and we have a technology refresher or equipment refresher cycle for 3 years. So we change our equipment after third year. We started changing at the 33% rate. And when it comes to who's going to fund it, so initial funding was provided by the donor. But later on, how to sustain it and then keep changing it was part of our agreement with the government. So now, as I said earlier in my presentation, that government is actually paying for connectivity and the devices if we need to change devices. And that is a big achievement, because usually we don't see that in donor-funded programs. And that is why sometimes, you have a start date and end date, and then when funding ends, the project ends. So we made sure that we don't get into that cycle for this project. So we started collaboration from the design phase with the government, so that they had ownership and still have ownership of this project. And now they are scaling this up, working with us. in 5 additional provinces, for example, in Gilgit-Baltistan, and they are actually funding most part of it.
Monsieur, une autre question.
Another question here from the gentleman.
Je suis le point focal
Mr. Kayozun, I am the focal point in e-health at the Ministry of Health in Togo. I have a concern I would like to share with you. And this, of course, I don't want to speak too much because I know that there's still a busy agenda. But I wanted to know, again, in the purpose of sharing experience, I would like to know, before you went for this digital solution, I suppose that you already had a digital health system, and I wanted to know how you also integrated the training of staff in e-health so that it can work very smoothly, so that you don't have to retrain everybody.
On va pouvoir poser cette question à Salem Sayani, savoir comment
we are also indeed going to ask the question, Mr. Sayani, how did you integrate these digital systems to pre-existing systems, and how did you train the people?
Yeah, it's a very good question. So I'll start with training first, and then we'll go to integration. So training is very important, and it takes a lot of time, and the expensive component of training is the HR. So who is needed to provide training usually. So what we have done is that we created training modules, digital training modules on on different features of the application. So whenever we hire new staff or we need refresher training, we don't have to have a trainer go all the way out in the field or call our participants at a location to provide them training. These modules are available within the application. So you can actually, if there's a new hire, they can go through different steps on how to do certain things or how to use digital health application. And usually they are trained by that. And if they have any question, we have maybe one person on site who can do some hand-holding, but mostly it is done digitally. So that is to answer number one. So we did not just digitize the process, we actually digitized the training as well, so that it is just one-time effort, and after that we can use this repeatedly for the same purpose. Now, when it comes to integration, fortunately, in Pakistan, there was all paper-based system when it came to EPI and also for LHW. There is an MIS program or solution, and then we integrated with the MIS system. However, the DHIS2, which is the provincial reporting system, we are planning to connect with that system so that we can integrate, so there is no paper-based data entry into DHIS2, because we believe that integration is so critical. Without having integration, you are just creating parallel structures which are not sustainable at all.
On retient une fois de plus, je trouve ce mot qui s'est invité dans cette conférence, alors qu'il n'est peut-être pas prévu au départ, qui est celui de la formation. Formation et compétences à chaque fois. Merci beaucoup, Salem Sayani, de cette intervention directe, de nous avoir décrit, on peut l'applaudir, ce projet développé au Pakistan. Et on va donc poursuivre cette conférence avec un moment toujours important, qui est celui de la remise des prix cette fois-ci, suite à l'appel à projet sur la recherche opérationnelle en santé digitale. Et pour présenter ces prix, nous accueillons, et on peut l'applaudir franchement chaleureusement, Léa Mattel, qui est chef de projet à la Fondation Pierre Fabre et l'une des chevilles ouvrières, il faut le dire, de cette journée, de cet observatoire et de cette conférence. Alors Léa, pas de lauréat e-santé cette année, mais un appel à projet un peu particulier. Pourquoi? C'est bon, c'est ouvert.
Alors, il faut savoir que dans le cadre de l'Observatoire de l'e-santé dans les pays du Sud, la Fondation a lancé cette année un appel à projet de recherche opérationnelle en santé digitale en Afrique. Afrique francophone uniquement pour cette année. Et ça s'inscrit à la fois dans une démarche de capitalisation qu'on mène en interne à la Fondation, mais c'est aussi notre réponse à un besoin, un constat, en tout cas, de manque de publications scientifiques en santé digitale, particulièrement en Afrique. Voilà pour le lancement de l'appel. Alors cet appel, il a été fait au mois d'avril et on a pu sélectionner avec un jury un certain nombre de projets.
Sur un appel assez court, assez court, vous avez eu combien de personnes à répondre et des projets qui arrivent de quel pays?
On a des projets qui sont arrivés finalement et d'Afrique de l'Ouest et d'Afrique centrale, une grande diversité de projets, une grande diversité de thématiques de santé aussi. Et puis au niveau des pays, alors je vais peut-être citer les pays.
On peut, oui, tout à fait, ce qui nous écoute aujourd'hui.
Donc on a la Côte d'Ivoire, le Mali, on a aussi le Cameroun, le Burundi et le Togo.
Et on va donc dévoiler ici en direct pour la première fois les 5 projets retenus, les 5 lauréats. On commence avec le nom du premier, Léa. Et c'est
alors le premier lauréat, c'est le projet d'évaluation. Pardon, j'ai pas le.
I'm sorry, I don't have.
Heureusement qu'il y a les anti-sèches.
Le projet d'évaluation de la phase pilote de déploiement d'une plateforme numérique de suivi des patients et gestion des stocks de médicaments anticancéreux en Côte d'Ivoire.
Voilà, que l'on peut applaudir, c'est le docteur Franck Gnahatin qui recevra bientôt ce trophée et qui nous explique en images le principe de cette évaluation.
What the content of the project is and how you can evaluate the stocks or inventories of anti-cancerous drugs. So it is the evaluation of the pilot phase of the development.
Notre projet est un projet d'évaluation d'une plateforme numérique du parcours du patient en cancérologie en Côte d'Ivoire. Et cette plateforme a été mise en place à travers un projet pilote depuis l'année dernière jusqu'à de mars 2021 à mars 2022. C'est un projet de digitalisation du parcours du patient, un projet qui a été mis en place pour suivre les patients et en même temps suivre le stock des médicaments anticancéreux dans 2 sites de prise en charge des cancers. Il s'agira pour nous de pouvoir, au début de cette évaluation, pouvoir identifier les difficultés ou les problèmes de traitement dans la mise en œuvre d'un projet numérique au niveau de la prise en charge des cancers. Franchement, on ne s'y attendait pas. C'est un honneur pour nous d'avoir été lauréat à ce prix. C'est une joie, une immense joie qui nous anime. Déjà, pour un projet pilote, ça nous permettra ça nous donne plus d'allant pour continuer ce projet, travailler à améliorer ce projet, le déployer au niveau national. Ça nous permet d'avoir une visibilité, voilà, de nos actions au niveau
the overall inventories of drugs we have. So it's really wonderful for us to be winners of this project. It's going to be very motivating, and I would like to thank the Pierre Fabre Foundation for giving us this opportunity.
Voilà, le docteur Franck Gnahatin qui nous écoute certainement depuis Abidjan, en Côte d'Ivoire aujourd'hui, qu'on peut applaudir à nouveau pour ce trophée, alors qu'on va lui remettre symboliquement, voilà, puisque les trophées sont là, et il partira d'ici quelques jours pour la Côte d'Ivoire. Léa, en quoi ce projet il est intéressant, il méritait d'être suivi par la Fondation? Le micro est là.
Eh bien, c'est un projet qui nous vient de l'Institut national de santé publique, donc c'est à la fois une structure reconnue et puis le sujet, lui aussi, est au cœur des enjeux de santé publique nationale, puisqu'on est bien à la fois sur du suivi des patients et puis sur le suivi de la gestion des médicaments. Deux enjeux cruciaux.
Enjeux cruciaux et sur lesquels, toujours le même esprit, on va pouvoir capitaliser, bénéficier, comme ce qu'on fait depuis ce matin, de leurs forces, de leurs faiblesses, pour les transmettre aux autres projets derrière. Merci beaucoup Léa pour ce premier prix. Pour remettre le prix suivant, j'appelle Marion Lelouvier, qui est présidente du directoire de la Fondation de l'Avenir, partenaire de cette journée, Fondation de l'Avenir pour la recherche appliquée. Tenez, hop, j'attrape un micro au passage. Voilà, merci d'être des nôtres aujourd'hui. Un petit mot peut-être sur cette fondation. Elle est connue ici à Toulouse, elle est connue à Paris, elle n'est peut-être pas connue dans les pays qui nous écoutent actuellement.
Oui. Bonjour à tous, merci beaucoup. Et puis je me joins évidemment à tous les saluts et souhaits de rétablissement amicaux qui ont été adressés à Béatrice Garrett. Nous travaillons, c'est la première fois que je suis à Toulouse avec vous. Vous connaissiez peut-être Dominique Le Tourneau, mon prédécesseur, et vous connaissez peut-être quand même la Fondation de l'Avenir, puisque la Fondation Pierre Fabre et la Fondation de l'Avenir sont partenaires depuis quelques années déjà, depuis 2017, autour des questions de santé numérique. La Fondation Pierre Fabre est membre du Fonds Avenir Santé Numérique que la Fondation de l'Avenir mène et qui traite notamment dans une chaire Avenir Santé Numérique de l'évaluation de projets de télédermatologie, de télémédecine, de téléconsultation. Et évidemment, je rejoins tout à fait ce que vous avez dit ce matin, la digitalisation maintenant est complètement actée et nous-mêmes, effectivement, dans cette chaire, nous avons pu accélérer des projets sur l'année 2020-2021, finalement, par l'intermédiaire du Covid-19. Et inversement, la Fondation de l'Avenir, qui soutient, au-delà de projets en santé numérique, la recherche médicale partout en France, de manière très généraliste, sur des projets de chirurgie mini-invasive, de médecine interventionnelle, d'accompagnement des patients en cancérologie, que ce soit sur le plan sanitaire ou médico-social ou dans l'organisation des soins. Eh bien, la Fondation de l'Avenir a choisi d'accompagner la Fondation Pierre Fabre sur cet observatoire e-santé, parce que c'est important de dialoguer Nord et Sud ensemble. Cette journée l'a bien illustré. Si je reprends les termes de ce matin, issues and topics are the same. Exactement, je suis tout à fait d'accord. Et nous pouvons consolider ensemble et nous rassembler les personnes autour des soignants et les soigner ensemble.
Et donc ce prix, Marion Lelouvier, est remis à...
Ce prix est remis à Ania Namaye Diallo, qui est étudiante à l'Université de santé de... Alors, je n'arrive pas à me relire. Kankov Moussa et au Centre Innovation DigiSanté du Mali. Elle est en lien également avec le Centre expert de recherche en télémédecine et en e-santé, le CERTES. Et c'est un projet qui accompagne et qui évalue sur le plan médico-économique. Je trouve que pour parachever cette journée, en tout cas faire partie de la fin de la journée, c'est une belle concrétisation, puisqu'effectivement, c'est un projet d'évaluation médico-économique du déploiement d'un système d'information hospitalier qui est au cœur de la politique de santé du Mali depuis plusieurs années déjà, qui est un système informatique hospitalier déployé dans 22 structures et qui donc va étudier sur le plan médico-économique les apports de cet outil. Et je pense que la chercheuse va le dire mieux que moi.
Exactement, c'est ce qu'on va découvrir en images tout de suite, donc avec Anna Nanamoye Diallo et ce prix pour l'évaluation du système Sinzan.
Mon projet consiste à faire une évaluation sur l'impact médico-économique du système d'information hospitalier Sinzan. Sinzan est un système d'information hospitalier qui permet une gestion informatisée des structures de santé privées et publiques. Alors, à travers cette étude, nous souhaitons évaluer les bénéfices médico-économiques qu'un système d'information hospitalier peut apporter à une structure de santé en identifiant son impact sur l'amélioration de la qualité de soins, en mesurant ses effets sur la maîtrise des dépenses de santé, en déterminant son rôle dans le pilotage des structures de santé et la prise de décision, et enfin, en appréciant la satisfaction des utilisateurs. Il faut savoir que ces bénéfices potentiels sur le plan médical et financier d'un système d'information hospitalier sont évidents. Mais il faut arriver à les matérialiser sur le plan scientifique avec des données fiables. Or, ces données scientifiques manquent beaucoup en général et en particulier dans notre contexte malien et africain. Ce projet, c'est mon projet de thèse et c'est la toute première reconnaissance scientifique pour moi. Ce n'est pas rien. J'en suis d'autant plus ravie que mon directeur de thèse et tous mes encadrants en sont fiers. Cela m'amène à me surpasser désormais car c'est une responsabilité aussi. Et ce prix nous offre les moyens matériels de réaliser ce travail de façon convenable et d'atteindre les objectifs de l'étude. Il permet aussi de donner une visibilité à nos résultats de recherche grâce à une meilleure dissémination à travers les réseaux de l'Observatoire e-santé. Je remercie sincèrement la Fondation Pierre Fabre de nous donner cette opportunité. Merci beaucoup.
Et toute l'émotion de la jeune, j'ai envie de dire, Anya Nyanyamwanye Diallo au Mali, qu'on peut vraiment applaudir chaleureusement parce que je suis sûr, certain qu'elle nous regarde en direct. Et Marion, on va lui remettre, elle est symboliquement ce prix devant la caméra, voilà, qui va partir pour le Mali dans les prochains jours. Bravo, bravo à Anya Nyanyamwanye Diallo, bravo à elle. Et on va passer, merci Marion, on va passer au troisième prix. Et pour remettre ce prix, va nous rejoindre le docteur Mehdi Benchoufi, qui est praticien hospitalier, impliqué dans de nombreux projets de télémédecine, dont Ecopen, dont on a beaucoup parlé déjà dans cette conférence, qui est un outil bon marché pour réaliser des échographies à distance, qui a été primé par la Fondation Pierre Fabre. Mehdi Benchoufi, vous êtes aussi membre du groupe d'experts de l'Observatoire d'e-santé dans les pays du Sud, praticien et aussi chercheur, il faut toujours le rappeler. En quoi, juste entre parenthèses, en quoi cette initiative sur l'évaluation et des prix sur cette évaluation quelque chose d'important pour vous qui êtes et praticien et chercheur?
Je cherche précisément dans le domaine de la santé publique et encore plus précisément dans l'épidémiologie clinique, qui est précisément cette science qui consiste à bien faire de la recherche. Je pense que c'est important ce qui a été fait, ou en tout cas ce qui accompagne la Fondation Pierre Fabre est important à plusieurs titres. D'une part, il s'agit d'un problème de santé publique majeur à l'échelle planétaire, qui est la problématique de cancer du col, en particulier au Cameroun, avec une couverture vaccinale aujourd'hui qui est assez faible. Par ailleurs, c'est la mobilisation d'outils modernes, l'utilisation, on va dire, simple d'outils modernes qui permet d'aller investiguer l'état de la population qui est susceptible de faire des cancers du col.
Alors là, Mehdi, on est obligé de préciser justement que ce prix va être remis pour l'étude de faisabilité d'utilisation d'un spéculum intelligent pour le dépistage du cancer du col de l'utérus.
Le troisième point, c'est qu'en effet, avant de s'engager plus avant dans des études de validation, donc l'équipe en question prend soin de faire ce qu'on appelle des études de faisabilité pour voir quelles sont les conditions optimales pour procéder à de la recherche clinique, encore une fois, sur un sujet de santé publique majeur.
Et ce prix est donc remis à GIC-Space pour une étude de faisabilité de l'utilisation d'un spéculum intelligent pour le dépistage du cancer du col de l'utérus. Et c'est le docteur Konrad Tonkou qui va nous expliquer tout de suite le principe de ce projet.
HealthMed est une start-up camerounaise qui développe des technologies dans le domaine de la santé adaptées au contexte des pays africains. Et notre objectif majeur est d'éradiquer le cancer du col de l'utérus et le cancer du sein dans le monde en général et en Afrique en particulier. Un de nos produits phares est un spéculum intelligent qui permet le diagnostic du cancer du col de l'utérus dans les zones les plus enclavées où l'accès à des soins de santé qualifiés est inexistant. Grâce à ce spéculum intelligent, le diagnostic du cancer du col de l'utérus peut se faire à distance. Le diagnostic se fait de façon instantanée avec un spécialiste qui peut se trouver n'importe où dans le monde. Ça va déjà faire presque 2 ans que nous développons cette technologie et nous avons fini tous les essais techniques. Nous avons eu l'approbation pour un brevet technologique dans le monde entier. Et donc, ce prix nous permettra de faire les essais cliniques qui permettront de valider scientifiquement cette innovation.
C'est une sorte de reconnaissance de tout le travail que nous avons eu à mener jusqu'à ce point, en considérant d'abord que c'est d'abord compliqué de créer une innovation étant basée dans un pays sous-développé. C'est également une sorte de boost pour le chemin à venir. Pourquoi? Nous sommes à l'étape où nous voulons démontrer de manière scientifique l'importance de ce que nous avons créé et la pertinence de ce que nous avons créé. C'est une autre reconnaissance parce que c'est croire au talent des jeunes, croire à l'innovation des jeunes. Et c'est une sorte de boost de motivation également pour démontrer que les solutions africaines peuvent venir des Africains. Donc on peut oser, on peut créer et puis changer vraiment l'Afrique pour monter notre image.
Voilà, un prix remis pour une étude de pré-projet, justement, sur de la faisabilité. On n'attend pas de faire, ensuite d'aller prouver que ça avait un intérêt. On prend la question dès l'amont, est-ce que ça a intérêt? Et ensuite, on va faire. Mehdi, on va remettre symboliquement ce prix pour la photo, avant qu'il ne parte pour le Cameroun dans les prochains jours. J'en profite parce qu'on a notre photographe, voilà, à l'autre bout de la salle. Et puis on salue justement nos amis camerounais qui nous regardent en direct pour cette journée. Merci beaucoup Mehdi Benchoufi. Et le 4e prix sera remis par Demba Diallo, qui est consultant, qui est spécialiste en santé digitale, entre autres, et qui est membre aussi, venez nous rejoindre, qui est membre du groupe d'experts de l'Observatoire de la e-santé dans les pays du Sud. Voilà, je trouve un micro ici. Voilà, Demba avec Mehdi, tout à l'heure on avait un regard de praticien hospitalier sur l'importance de ces prix sur l'évaluation. J'ai envie de vous dire, pour vous qui êtes consultant, spécialiste de la santé digitale, en quoi justement la création de ce type de prix est importante? Il marche, il n'y a pas de souci. Ouais.
Je pense que c'est important à un minimum. On a beaucoup parlé de scalabilité aujourd'hui. Donc c'est bien quand des projets fonctionnent à petite échelle, c'est mieux quand ils sont scalables. Et donc évaluer permet de voir notamment quels sont les bottlenecks qui permettent de pouvoir déverrouiller les points de scalabilité. C'est un premier point, donc les verrous en fait. Deuxième point qui est intéressant, c'est de pouvoir mesurer l'impact concret auprès des bénéficiaires. Parce qu'il ne faut pas oublier l'enjeu de tout ça, en tout cas au niveau de la Fondation Terra, c'est d'avoir un impact sur les populations les plus vulnérables. Et donc par rapport à ça, c'est de pouvoir voir en quoi est-ce que ces projets ont vraiment impacté les plus vulnérables de manière très concrète. Voilà.
Et ce 4e prix est donc remis à
Kiramama.
Kiramama pour l'évaluation du projet Rapide SMS, intéressant puisque c'est un projet qui doit être transposé du Rwanda au Burundi, mais selon des modalités différentes, dans des pays différents, des cadres différents, des cultures différentes. Et on découvre tout de suite ce projet avec Anissé Nyondai.
Mon projet, c'est un projet d'évaluation d'un projet appelé Rapid CMS, qui est utilisé pour améliorer la santé maternelle et infantile au Burundi. Donc, il s'agit d'une technologie qui utilise des messages qui sont envoyés aux agents de santé communautaire. Avec ce téléphone, ils peuvent enregistrer des phénomènes de santé dans la communauté. Et il peut même envoyer des messages d'alerte ou bien des rappels et des conseils pour des soins prénataux et des soins postnataux aux femmes et aux enfants qui nécessitent la vaccination. J'ai voulu évaluer ce projet car c'est un projet d'innovation, mais à regarder dans la littérature, nous voyons que la plupart de ces projets échouent. C'est parce que ce sont des projets qu'on répète en provenance des pays étrangers. On ignore le contexte dans lequel ces projets s'insèrent. Cette évaluation que j'envisage d'effectuer une recherche qualitative et quantitative va démontrer les obstacles, bien les succès, bien les éléments qui pourraient être favorables pour ce projet. Je suis énormément heureux de pouvoir gagner ce prix. J'avais candidaté pas pour question de curiosité. Je ne pensais pas que je pourrais gagner. Mais voilà, j'ai gagné. Ce prix va me permettre d'étudier dans de bonnes conditions et je vais effectuer une recherche de meilleure qualité parce que la recherche, ce sont les moyens qui comptent. Pour effectuer une bonne recherche, ce sont des moyens. Donc, je pense qu'avec ce prix, je vais quand même obtenir de meilleurs résultats pour mes objectifs. Je dis vraiment merci beaucoup à la Fondation Pierre Fabre.
Voilà, toute l'émotion à nouveau, un jeune chercheur qui tout d'un coup, alors qu'il ne s'y attendait pas, avoir des moyens pour mener ses recherches à bien dans de meilleures conditions et un prix qui va bientôt lui être adressé. Demba, vous vouliez commenter un petit peu ce projet de recherche?
Peut-être pour le mettre un peu en contexte, parce que l'audience, je pense, ne sait pas trop ce qu'il y a derrière tout ça. Le projet Rapid SMS au Rwanda, en 3 mots, c'est un projet qui a permis de sauver la vie de près de 600 000 enfants entre 2009 et 2015, qui a permis de réduire la mortalité maternelle, qui est passée de 31 à peu près, de 47 à 31 à peu près pour autour de 10 000 personnes. Donc en fait, c'est un projet qui a un fort impact et qui a été évalué par l'UNICEF. Donc ce qui est intéressant ici, c'est la tentative de réplicabilité. Donc on est sur des grosses échelles d'impact. C'est ça que je voulais dire.
Merci beaucoup et je vous laisse aller lui remettre symboliquement à travers la caméra ce prix qui va, voilà, dans le bon sens, qui va bientôt partir donc pour le Burundi. Je suis sûr où Anissa nous regarde en direct aujourd'hui et voilà, on lui remet ce prix symboliquement en direct. Dernier, 5e et dernier prix pour le remettre, Bertrand Parmentier, qui est membre du conseil d'administration de la Fondation Pierre Fabre, qui va nous rejoindre sur cette scène. Voilà, Bertrand, je vous tends un micro pour remettre ce 5e prix. C'est le rôle de la Fondation, justement, d'inciter à la recherche, à l'évaluation par des prix spécifiques.
Tout à fait, parce que ça fait partie des facteurs de développement à long terme. Et la recherche, c'est le principe moteur qui est à l'origine des laboratoires Pierre Fabre en tant que tel. Et la recherche va permettre derrière de développer également la formation. Et encore une fois, c'est ça qui permet de tirer un développement durable à l'intérieur du pays.
Et ce 5e prix est donc remis à...
Alors ce 5e prix est remis au Centre de formation et de recherche de la santé publique de l'Université de Lomé, au docteur Sibabe Agoro, pour un projet de recherche sur l'évaluation de l'utilisation d'une plateforme électronique de messagerie mise en place dans la direction régionale de la santé de la région de Kara, au Togo, pour le suivi et le référencement des femmes enceintes.
Et on écoute tout de suite les explications sur ce projet du docteur Sibabe Agoro.
Nous avons, selon les documents donc, de notre plan national de développement sanitaire du Togo, pour le compte des années donc 2017-2022, la mortalité maternelle et néonatale reste élevée. Alors depuis 2019, nous avons mis en place une plateforme au niveau de notre région pour essayer de travailler dans le sens de réduire cette mortalité. Cette plateforme n'a jamais été donc évaluée. C'est pour cela que nous nous proposons de faire ce travail. Et nous avons posé quelques hypothèses, à savoir que la plateforme contribuerait énormément à réduire la mortalité et que cette plateforme aussi permettra d'avoir des données sûres qui peuvent être donc utilisées pour avoir de bons indicateurs et améliorer donc la référence et contre-référence des femmes enceintes. Nous avons aussi prévu un point très important, c'est de parler des points forts, des faiblesses, des opportunités, la menace liées à l'outil. Est-ce que, en termes de confidentialité des patients, les données qui sont générées sur cette plateforme, est-ce qu'il faut à la fin continuer par l'utiliser ou bien proposer donc au ministère de la Santé de chercher un outil beaucoup plus sûr. Donc voilà des questions sur lesquelles nous allons beaucoup travailler. D'abord, je voudrais dire tous mes remerciements donc, à la Fondation Pierre Fabre. C'est vraiment une grande opportunité que cette fondation m'offre. C'est un sentiment de joie que j'exprime et je crois qu'avec donc ce prix, je vais pouvoir davantage travailler avec les prestataires de soins pour qu'on améliore ce système parce que continuer par avoir une mortalité maternelle élevée, ce n'est pas une bonne chose.
Voilà, et on peut applaudir la joie du docteur Sibabé Agoro et ce prix qui va bientôt partir, peut-être même dès ce soir, tiens, dans certains bagages de la salle, qui va pouvoir partir pour le Togo. Bernard Parmentier, une réaction face à ce prix?
Ouais, écoutez, à la fois par rapport à ce prix et par rapport à cette conférence ODS, parce que d'année en année, ce qui me frappe, c'est la montée en maturité de ce parcours digital que nous essayons d'accompagner. Cette année, l'évaluation était vraiment au centre des thèmes qui ont été abordés. Ça montre bien qu'on a déjà passé plusieurs étapes et on a une illustration très bonne à travers ce projet, je dirais, de l'intérêt de ce process d'évaluation qui permet quelque part de passer à l'échelle, de partager des expériences et d'exploiter de mieux en mieux la data pour des problématiques de santé publique. Donc je trouve que c'est vraiment un très bon signe de la montée en puissance de cette maîtrise du parcours digital à l'intérieur des pays du Sud. Et première chose. Et deuxième chose, qui est extrêmement intéressant également, le fait que nous allons pouvoir, dans le Nord, capitaliser sur ce type d'expérience avec un renvoi d'ascenseur qui sera extrêmement à valeur ajoutée pour les pays du Nord.
Oui, on a tous à apprendre les uns des autres. On passe notre temps à le dire depuis ce matin. Bertrand Parmentier, je laisse remettre symboliquement ce prix, justement, qui va partir au Togo, peut-être dès ce soir ou demain et dans les prochains jours. On a beaucoup d'amis du Togo, une belle délégation du Togo dans cette salle. Voilà, merci beaucoup à vous, un bravo à tous les candidats qui ont été primés. Et il est temps maintenant déjà, j'ai envie de dire, de clore cette conférence très dense depuis ce matin. Et pour ça, je vais laisser la place à un acteur essentiel, incontournable dans notre domaine, c'est l'Organisation mondiale de la santé. Nous avons l'honneur et le plaisir d'accueillir ce soir monsieur Derrick Mounene, qui est chef de l'unité de renforcement des capacités et de collaboration en matière de santé numérique à l'OMS. Voilà, je lui laisse la parole pour la conclusion de cette conférence. Voilà, Derrick Mounene, représentant de l'OMS ce soir à Toulouse et en direct. Voilà.
Well, good afternoon.
Okay, I repeat. Thank you so much, Lionel. Checking if the microphone is okay. All right. I will speak in English, but wanted to maybe begin by thanking the organizers, more specifically to just recognize the tremendous support that Beatrice and the foundation and the other organizers have provided towards organizing such a robust event. And I would also want to thank the moderator, Lionel, excellent moderation, tremendous meeting, and definitely I believe that you all agree that this has been a tremendous meeting. Why don't we give an applause to all the participants, the organizers, and the takers. Now, my task is very simple. My task is very simple. It also includes holding the microphone properly. We're excited as the World Health Organization to be part of this event. More also because we are partly in the midway regarding the implementation of the Global Strategy on Digital Health 2020 to 2025. The discussions we've had today are the heart of that resolution. In the morning, we discussed key issues around the enabling environment, around assessments, issues of scalability, topics that have been with us for the past 20 years. And then in the afternoon, we engaged in discussions on capacity building. How do we ensure that the transformation that we speak about, the fourth industrial revolution, leaves no one behind, both the people and also the actors that are involved in using the digital solutions that we speak about. We're thankful because this discussion could not have come at a very timely time because, as you know, the COVID-19 pandemic has both challenged health systems, brought about tremendous opportunities of digitalization, and at the same time has promised a future that is characterized with digitalization. Indeed, the new normal is actually digital. And as Dr. Tedros, our Director General, once mentioned, the future of health is indeed digital. And what we call digital health, or e-health today, in times to come, is more likely to be referred to as simply health, delivered by digital means in a digital space. I would like to emphasize 3 words that came out today. And these promise a better transition into the new normal for scale. These are scalability, sustainability, and also systems thinking. Tremendous projects have been presented. Thank you to all the presenters and all the projects. We must continue to think system-wise so as to avoid the challenges we've had in the past decade or two, which were characterized, as was mentioned from Bangladesh, on verticalization, digital solutions focused on programs. But really transitioning towards thinking system-wise, and at the same time thinking for the future, and as participants mentioned, designing testing, assessment as an integral part of these interventions. To do this, international collaboration, international actions, and coordination on the part of all is essential. And that is why our global strategy on digital health is formed on 4 principles. Principle 1, focusing on collaboration as we are seeing here. And principle or objective number 2, focused on integrating actions in national strategies. And then thirdly, principle or objective number 4, really focused on governance, making sure that the cognitive capabilities to manage systems are established within the civil entities, governments, academia, including the private sector. And then lastly, the people we're describing, patients, health seekers. ensuring that our interventions put people first, which is objective number 4. Patient centricity. Digital health and e-health exist because of the promise and aspiration of bringing about better health and well-being of the people. The discussions we've had from the morning to now is simply because we're aspiring to use ICTs to improve the health and well-being of the people that we're serving. And that is why we're pleased that we're able to participate actively and we're able to indeed contribute effectively to this particular session. It's been very effectively conducted, and being in person is much, much different than virtual connections. And so we hope next year we'll be able to meet also in person. We hope next year all the people that were speaking virtually will be able to join us in person. And as we strive for universal health coverage, leaving no one behind, let's make sure that we leave no one offline. Merci beaucoup, and thank you very much, everyone.
Merci, merci beaucoup, Derek Munene, de cet enthousiasme et de cette conclusion qui nous ouvre de nouvelles perspectives, pas seulement jusqu'à l'année prochaine, mais effectivement pour le futur, les prochaines années. Toute dernière personne à venir clore pour cette conférence, pour cette journée, celle qu'il a ouverte ce matin, en lieu et place de Béatrice Garrett, Chose France. Béatrice, si tu nous écoutes, j'espère que ça va beaucoup mieux déjà ce soir. Et pour clore donc cette conférence, nous rejoint Solène Barbe, directrice des programmes de la Fondation Pierre Fabre.
I hope she's feeling much better. So thank you for being here with us now. And for closing this session, you have launched this morning.
Oui, c'est bon, pardon, excusez-moi. Oui, merci beaucoup. Du coup, je pense que je crois que la journée a tenu ses promesses, que ce soir, tout le monde repart avec quelque chose en plus. Je pense également que c'était une journée très riche en échanges. Merci, je rejoins évidemment tout ce qui a été dit, les remerciements à l'attention de Lionel, de la qualité de la modération, avec beaucoup d'énergie et d'acuité. Tous les participants, évidemment, les conférenciers, les personnes qui sont connectées partout dans le monde. On espère que ça a été agréable de suivre aussi à distance comme ça l'a été dans la salle. Je remercie évidemment toute l'équipe technique pour avoir assuré le duplex et puis les connexions sur les campus de l'AUF, les traducteurs et puis évidemment l'équipe de la Fondation Pierre Fabre et en premier Léa Mattel et Maxime Collin qui sont les organisateurs, les chevilles ouvrières de tout ce travail-là et toute l'équipe derrière aussi qui a assuré toute la logistique, vos déplacements, etc. Voilà, donc c'est avec un grand plaisir qu'on espère vous retrouver l'année prochaine, bien sûr. Et puis, il y a un rafraîchissement qui vous est offert dans la salle à côté pour continuer les conversations si certains le souhaitent ou en attendant vos transports pour rentrer. Et puis, je vais demander aux conférenciers intervenants de nous rejoindre sur la scène pour la dernière photo de famille. Voilà. Merci encore à tous et à toutes. Et puis, j'espère à très bientôt.